Assalamu alaikum and good morning, everyone. My name is Dr. Kuratulen, and I will be the moderator of this session today. So I welcome you all to this session of abdominal and pelvic trauma at PAK Traumacon 2024 or conference. As we all know, abdominal and pelvic trauma are complex and challenging to manage, requiring multidisciplinary approach for optimal patient care. Today, we will hear from distinguished panels of experts who will share the insight and their views and the practical strategies in managing the critical trauma patients. So to start with, first I would like to introduce the chairs. I'm pleased to introduce the session chair, Dr. Khurshid Akhtar, a general surgeon from UK with more than 30 years of experience in the field of surgery. He is known for his upper GI surgery. And also, I would like to invite Dr. Rahil, a respected figure in our field of general surgery with extensive experience in trauma management. They will guide us through today's session. Please join me in welcoming Dr. Akhtar and Dr. Rahil to the stage to kick off our session. A big hand for both. Thank you. So through this session, we will cover various aspects, including operative versus non-operative management protocols and importance of intervention radiology. Our aim is to equip you with the knowledge that will apply in your practice to save lives. So I won't take long. I would first like to start our presentation. That's the role of IR in abdominal trauma. So I would like to invite the talk of Dr. Irfanullah. It is a recorded session, so we will provide it here. Dr. Asadullah, yes.
Assalamu alaikum, bismillahir-rahmanir-rahim. Hope everybody is well. I was hoping to be in person for this talk, but unfortunately, we plan and Allah plans, and Allah is the best of planners. I missed my flight due to a delayed connection. So I'm recording this video talk, not as good obviously as being there in person, but inshallah, hopefully people and audience will benefit from this, and I will share my email address at the end, so I can take questions and answer questions. I know that Dr. Yusuf Merman is also in the crowd, in the audience. Yusuf and I have worked together on many cases, and he is fully capable of answering all these questions since he's worked at a trauma center. And I would also like to thank the committee for inviting me for this talk. Inshallah, next time I will make it in person. Let's get started here. I'm going to share my screen here.
This is Professor Akhtar.
So obviously
we are not able
topic
to
today
hear you
is the trauma
clearly.
conference, and
We are not
the
able
topic
to,
is role of
we are not
interventional
able to hear you
radiology in
clearly.
abdominal trauma. I spent
It's
the first
recorded.
25 years of my life in
So
Karachi.
can
so
they
I'm
not
well
make it
familiar
any
with
better?
Karachi and kind of city with a population. We have how significant trauma is.
All right.
Presentation
So
goals are simple.
let somebody
You know,
explain to everybody
the
that.
target audience, I was told, are a lot of
Can
surgeons,
someone explain to them why its quality is so
trainees,
poor?
radiologists as well.
come
And I
on.
will try to hopefully make this presentation beneficial for everybody
I can't
in
say
the
anything,
audience.
hear anything.
All trauma workup at our hospital, so I work at a level 1 trauma center in the US. I've been working there for 20 years. It's a significant aspect of my everyday life. And what has revolutionized our IR in the trauma world is abdominal CT and the easy access of abdominal CT. any trauma center has to have a good quality CT scanner that is easily accessible for the ER surgeons and the for the ER physicians and the trauma surgeons. So we need a well-working CT scanner that's easily accessible, and then we also need to have an interventional radiology team as part of the trauma algorithm. And then also, I'm hoping that the audience here, especially the trainees and the surgeons and the ER doctors, can understand when to activate us for a trauma and how we can be beneficial to the trauma team. It's just a little slide. Living in America is not as enjoyable as it used to be. I put this out there with the caption, let the trauma begin. The way things are heading in the U.S. is unfortunate. So the next step right now is to let us know when to perform a CT scan. So a trauma patient comes to the emergency department. We generally get a CT scan in a patient with severe injuries who are, even if they're hemodynamically stable, CT scan now I think is just an entry into the ER often for most of our patients. Another indication would be a physical exam that cannot be performed due to altered mental status. Anybody with pelvic fractures, you want to get a scan. And if you're not sure, basically CT is the entry into the ED for any trauma patient, at least in the US. We are somewhat imaging happy over here and have very low thresholds to perform scans. I'll take some time on this, and this is a critical tool for us, especially radiologists, and if you have a scanner, how to perform a trauma scan. Oral contrast we really don't give anymore for our abdominal CT scans. Not really needed, doesn't really help us, and adds time. I'll focus on intravenous contrast. So all trauma scans should be given IV contrast, and at our institution we actually use a double bolus technique. So we inject the contrast at 70 seconds, and then we do a second bolus at 35 seconds, and then we scan. So this is called the dual bolus technique. So when we scan, we get a opacification of the arterial system, as well as with a delayed 70-second scan, we get portal venous opacification and parenchymal opacification as well. So some places will do a non-contrast followed by arterial phase followed by a portal venous phase. So we kind of put those together and combine them in order to save radiation for the patient and also save time. If there is any concern for pelvic injury, we will get a delayed scan to see how the pelvis is and to see if there's any renal or urethral injury. So I can talk more about this later, but it's important to give IV contrast and time the bolus such that we have optimal opacification. At our institution, if anybody comes into the emergency department with any remote concern for trauma, they will get a CT scan. If they see the word active extravasation, they will call interventional radiology. Even if it's like a small subcutaneous bleed, they will just call us and then we will evaluate the images and give our input. So as an interventional radiologist, our contribution to the trauma team is first to evaluate the patient, look at the imaging available, and then formulate a recommendation to the emergency medicine doctors and the trauma surgeons. So we first diagnose and see if the patient is actively bleeding, and then hopefully we can offer our services to stop that bleeding. So the goal here obviously is to avoid open surgery. I'll start off with a simple case. This patient came in last month at our institution. A 32-year-old male. He had a fall, fell about 30 feet, so his fast exam was positive. A little tachycardic, but normotensive. So given these parameters, a decent history of trauma, we did get a CT scan, and I'm going to play the scan here. So as you can see, there is splenic injury, there is a hemoperitoneum, and the scan kind of goes pretty fast, but there is active extravasation in the spleen. So based on the imaging and the clinical parameters, interventional radiology was activated. I was called in. I was going to poll the audience if I was in person as to what the next management step will be. So does this patient go straight to the operating room? Do we watch and wait since he's somewhat stable, or do we send this patient to IR for catheter angiography? Since this is an IR talk, obviously the answer is go for catheter angiography. So for all trauma cases, probably the most frequent intervention that I do is splenic angiography. The spleen is the most frequently injured organ, the parenchymal organ. Uh, and it is critical for the IR provider to look at the imaging, grade the injury, and come up with a management plan. This is for the radiology resident trainees. You should all be familiar with this grading scale for trauma. I'll go through it very fast. You guys can all look this up in your various textbooks. When you are reporting a CT scan for trauma, you want to grade it. So then when I'm or a surgeon is talking to you, we can kind of visualize what kind of injury it is. IR gets involved in grade 4, where there's active extravasation, but it's still retained within the capsule, and grade 5, which is shattered spleen. Historically, grade 5 injuries would go to the OR or for splenectomy, but more and more of these are now coming to us, and we can manage these, with interventional radiology. So this is the case that I showed earlier. This was, showed that there's hemoperitoneum, subcapsular hematoma with the splenic bleed. We did go to catheter angiography, so right groin access, 5 French sheath, source select catheter or cobra catheter for the radiologists in the crowd. Just a little bit more technical. You're going to the splenic artery. And you can see there is an area of active extravasation or blush in the upper pole correlating with the CT. There's avascularity to the upper pole as well. The vessels are clamped down, which is common in trauma patients because of their hypotension. In a normal person, the splenic artery would be bigger than that, and you can see delayed boom or blush in the venous phase. You take a microcatheter and embolic, and these coils are our friends. These are little platinum coils that are fibered that promote thrombosis and stop flow within the vessel. Followed by that, I did a more proximal embolization. These are detachable coils that we use. The splenic artery is a high flow vessel. Unfortunately, some of these coils went distally, but there were no ill implications from this. This is a CT scan 1 month later demonstrating that the hemoperitoneum has resolved and the spleen is enhancing, so through collateral channels. Just a quick note here, I'll go to the slide presentation here. Initially when I started this 20 years ago, I would just do distal embolization. Now, if there is significant bleed, I will combine my distal target embolization with a more proximal coil pack. And the goal here is to kind of place the coil pack between the pancreatic magna artery to preserve collateral flow to the pancreas, and also to preserve collateral flow to the spleen. This is the biggest study. Not all procedures have complications, so this is a little high rate than I normally see, but post-embolization, you'll see some splenic infarcts. Most of them are small. Some patients will continue to bleed, which is why, if possible, we use distal embolization followed by proximal embolization. A small percentage will continue to bleed and require splenectomy, but for most part, splenic embolization is a well-recognized procedure and helps, reduce the mortality and morbidity of a patient needing a splenectomy. These are some of the pearls over the years that I would, recommend my other radiology colleagues and surgeons to kind of think about. So splenic artery embolization indicated for grade 4 and 5 injury. If the patient is unstable, you need to act really quickly. So if the patient is unstable, I would just go do a proximal embolization and be done within 20 minutes. These patients are clamped down, so you want to oversize your coils a little bit, but 20% in the splenic artery. Detachable coils, if possible and available, they're kind of expensive, and I understand resources are fairly limited, having worked in Pakistan for a few years and also worked at the trauma center with Dr. Yusuf as well. So obviously, equipment availability can be challenging as well. This is another case that a colleague of mine did. There you can see there's active extravasation in the spleen. He did a really dense coil pack proximally, and this was a scan 2 weeks later. The spleen completely infarcted. So not ideal, but complications do happen. And this did not get infected, but you want to watch for infections in this scenario. In a resource-poor setting where coils are not available and you are in a rush, a gel foam slurry can also be injected. I've done a lot of gel foam injections into the splenic artery earlier in my career. Gel foam has been associated with a slightly increased risk of delayed infection, just to keep that in mind. The other parenchymal organ that can be injured after the spleen is the liver. Again, the grading system for the liver, you should all be familiar with this. I'll go through this really fast. Grade 4 again is active bleeding, and greater than 75% parenchymal destruction is grade 5. This is a case that I did last month. The patient came in with a subcapsular large hematoma, a small focus of bleeding in the liver, and also splenic bleed. I went for the liver first, same access, right groin, put a catheter, microcatheter, inject, vessels are really clamped down, you see an active area of bleeding, and you coil it. And then splenic artery was also embolized. Unlike the spleen in the liver, I typically prefer to get as subselective as possible. If you can get distally and identify the bleed, put some coils in. If the patient's unstable and you can't get the distal, I will use gel foam. Sometimes patients with liver injury have significant other injuries as well, so the surgeon might just decide to take them to the OR. Sometimes there's venous bleeding as well, so they'll take them to the OR, back them, and if they continue to bleed, they'll come back to us. Post-liver complications, again, every procedure has complications: bile leak, hepatic necrosis, abscess, gallbladder infarcts. All of these can often be managed non-operatively by interventional radiology, by putting drains in, by biliary drains in, or gallbladder drains if needed. The kidney is probably the least frequently injured organ. Mostly we see it in penetrating trauma. This is a case actually I did almost 15 years ago. A young female that was stabbed. You can see there is a pseudoaneurysm with a retroperitoneal hematoma coming off the right renal artery. The surgeons did not want to operate, did not want to take this patient to the OR. Here's an angiogram showing a bilobe, splenic artery, pseudoaneurysm. Took me a while, but I was able to get into this branch, coil it out, and then use a stent graft. And the stent graft basically is a covered stent, and I took it right to this bifurcation vessel, trying to preserve as much splenic function as possible. And this was elegantly treated. This is actually a scan almost 10 years later, follow-up scan showing that kidney function is preserved and the renal artery flow is preserved. So successfully managed this case without surgical intervention. Another polytrauma case, stab wound, a large pseudoaneurysm with massive bleeding. As you can imagine, this patient was extremely unstable. This again, here's some measurements. We did the right groin access, put a 6-French sheath in, this is an 8-French sheath, followed by a stent graft, which is a covered stent, and we were able to control this bleeding. This is, where interventional radiology is so useful. The most rewarding procedure that I do within the trauma landscape is probably, pelvic intervention. Pelvic trauma these are also young patients that fall off their motorbikes. This is one case where I will probably forego a CT scan. So if a patient has pelvic trauma and they're unstable, I just take them straight for angiography. Time is critical in these patients, and it is amazing how actively these arteries bleed. The sooner you get them in, the faster you can treat these patients. If the patient is stable, I will get a CT scan. Another point here, in older patients, especially with pelvic bleeds, you want to be even more aggressive because it is there.
Thank you so much. It was a wonderful presentation by Dr. Asad Irfadullah. So he has guided us about how to manage the injuries of liver and spleen and pelvic trauma. Now moving forward to our panel discussion. I would like to invite on stage Dr. Hasnan Zafar. He is a trauma surgeon from AKUH and a very prominent figure when we talk about general surgery. He has an expertise in his field. He is an associated professor of surgery in Aga Khan, and obviously with FRCS and trauma fellowship FACS. So he specialized in trauma surgery, that laparoscopic surgery, and also in hernia surgery. So he is a professor of surgery. Next, Dr. Yusuf Mahmood will be joining him. Dr. Yusuf Maiman is the head of the Department of Intervention Radiology, Endovascular Surgical Specialties, and Intervention Radiology at SMBBIT. So he is an expert in his field, and I have seen many patients getting recovered just because of getting in time due to his intervention radiology specialty. Next, I would like to invite on stage Dr. Mohammad Faisal Khan. He is trauma intensivist, and he is also associated with Aga Khan University Hospital and Chair Hospital Resuscitation Committee, Section Head of Critical Care, Assistant Professor from Department of Anesthesiology. Please join us on this stage and let's have a panel discussion on penetrating abdominal trauma injuries. That's a real-time scenario. Over to Dr. Sohaib. So he will lead the session.
Assalamu alaikum everyone. So welcome you all in this session. I am Dr. Sohaib Najam, currently fellow in general surgery and trauma at AKUH. So basically I'm going to be presenting the real-time scenarios that we face. I have selected 2 cases in which I'm going to be discussing about the injuries, their resuscitation, and some sort of operative management and some role of intervention radiology as well. It's going to be a little bit of interactive session. So let's start. All right, so the first case is actually a 27-year-old male brought to emergency department by his family members on 8th of December 2022 at 7 p.m. The mechanism of injury was actually blunt abdominal trauma. He was attacked by a mob of 40 to 50 people around 2 hours prior, and he was brought to our ER. So on his primary survey, his airway was intact, the collar was applied for suspected C-spine injury, the respiratory rate was 28 to 32 breaths per minute, the saturations were 89 to 90%, and he was on 10 liters of face mask. On circulation, the heart rate was 130 to 145 beats per minute, the blood pressures were 70-40, and his GCS was 12 out of 15. There was bruising at the right flank, and there was no open wound, and there was generalized tenderness over the abdomen. So what do you think? What's happening with the patient? Anyone? Yeah, that's a fair point. So the patient is actually in grade 3 to 4 shock, warranting immediate resuscitation and intervention. So talking about resuscitation, what do you think? How many of you think that in this patient we should give blood, and how many of you think that we should go for some IV fluids before blood? What are your... so you can raise hands. How many of you say that we should start with blood? Okay, that's a very few people. And what about the fluids? What about our panel members? What do you say?
So if you see the case and you know the details in the primary survey, so there is no doubt on it that this patient is in shock. But most importantly, you know, whenever we see this case, apart from treating the physiology, there should be a trauma team, and they need to call in and they start to see the patient and start managing. Apart from, of course, we do the ABC, the airway, breathing, and circulation. His blood pressure is low, his tachycardic, his GCS low. It means that he is hypoperfused. So he may require intubation, but and he may require, you know, to improve the circulating volume, that you give volume. But of course, the blood is not available, you know, most of the time. So the basic thing would be how you can get perfused to him, and the best thing would be, we all know that the fluid. But whenever we see this type of patient in the, you know, in the ED or somewhere, we all, you know, see one of the most important thing, which is the damage control resuscitation. And the damage control resuscitation mean that, of course, you need to avoid the overzealous fluid. You need to balance the hemostatic resuscitation. You may think about the permissive hypotension. You may think about the damage control surgery. But rather than thinking about the surgery at this time, he may need a good circulating volume to treat this abnormal physiology. And of course, then your team would arrive, and you may have a team leader and discuss the other things.
Question was, what would you give?
Okay, so
I don't know, I'm chairing the session, but I don't have an idea how it is going to happen. Can we, in the beginning, explain how much time we have with the speakers and how we're going to manage? So that you're asking what will be the first intervention?
Yeah.
And can we,
So the
would you give?
yeah. So let's we have to make two decisions. One is does he require to go to OR? Is he bleeding enough? If he's bleeding enough, he needs to go to OR. And then the second question is your resuscitation. How much would you give? The answer in this day and age is permissive hypotension. Enough to keep him alive, to keep his brain perfusing before you fix the bleeding. That's the most difficult question to answer in ER setting. So we are sitting here in retrospect, but at the time, the team which is managing, because a blunt trauma mostly requires lots of investigations. But here you are looking at the patient. So the person at the site would start with IV fluids, because that is available, make a decision that he's a responder versus non-responder, and then make a quick decision to take him to surgery to fix. So his resuscitation may include surgery.
All right. Thank you. So, coming to this point, for a patient with isolated severe abdominal trauma with hypotension upon arrival in the emergency, the probability of death increases every 3 minutes by approximately 1%. So what's next? Exploration versus investigation. Any idea? Who will go for exploration and who will go for investigation in this? Investigations? Okay, so it's basically you guys are okay. So you pointed out as well which investigations. So any idea about the concept of eFast? That's what's happening around the world. Not sure if it's available everywhere in Pakistan, but that's what's happening. So we took the patient for surgical exploration actually. We did a midline laparotomy. There was gross hemoperitoneum, and there was approximately 1.5 liters of blood in the abdominal cavity. We found a grade 4 liver injury, and there was an expanding retroperitoneal hematoma. So during surgery for grade 4 liver trauma, the bleeding was controlled with ligar clips and electrocautery, but the bleeding did not stop completely. So we packed the liver mostly, and upon exploration of the retroperitoneum, the right kidney was shattered. So we took the control of the hilum and took the kidney out. So this was a picture taken of the shattered kidney at that time. So during this time, a total of 5 PCVs, 3 cryos, 3 FFPs, and 3 platelets were transfused to this patient. The abdominal cavity was packed, midline wound was temporarily closed with Bogota bag and towel clips, and the patient was shifted to surgical ICU for further management. Now the idea comes of damage control. So damage control is basically, it is required for a severe trauma victim, and it is basically the correction of physiology as well as the anatomy simultaneously. And the role of surgeon as well as the anesthesiologist that is taking care of the patient is very much important in this. So as pointed out, depends on pluridisciplinary team decision making. So Dr. Faisal, you're our intensivist here. If you want to comment something about the damage control strategy.
So that's what I mentioned about that. The most important thing that you get in a problem with the overzealous resuscitation, and this overzealous means that you give a lot of fluids, you give a lot of products, you try to keep the blood pressures high, more than 100 systolic. So that sometime when the patient comes to the ICU, that usually they have very much swelled, the lungs are wet. So at this time, the primary focus is, to keep the blood pressures how much that it can easily be perfused, like the MAP is more than 60 or 65, not beyond that. You may give massive transfusion protocol if you think that the patient is still bleeding. And you know, at this time you may think about the point of care or the goal-directed coagulation management. So the idea behind is that you try to avoid the overzealous transfusion issues which comes up with the multi-organ failures, the compartment syndromes, and all these things.
All right, thank you. So the lethal triad in such situations is very important, which is hypothermia, acidosis, and coagulopathy. So it's a cascade. It is very difficult to break this vicious cycle, but conversely, it is very easy to fall into it. So we took the patient for reloc laparotomy after 24 hours. PAKs were removed. There was minimal bleeding of the liver. We searched for any other missed injuries. We placed the abdominal drains. We did a permanent closure, and the patient was shifted back to ICU. He was extubated the next day and got well afterwards. So in conclusion, for a damage control strategy, the patient selection followed by primary emergency survey surgically, followed by intensive care, the definitive surgery, and then the permanent abdominal closure. Okay. Moving on to the next case.
Any comment on this case from the participant? Is there anyone from the other center, trauma center here? Would you like to comment on this management of this patient? Sorry, please introduce yourself.
Just want to add, damage control, when you're trying to decide about the packing, it has to be decided early on. So what has happened is that you have tried your best to stop the bleeding over there, and then finally you decide to basically pack. This is a grave mistake we all commit, and we should avoid that, because you have to prevent yourself falling into the trap of DIC and lethal. So the situational awareness and decision making has to be taken early on. What are your sources? What is the condition of the patient? Whether, because based on the injury, would you be able to stop it? So decision to pack has to be at the start rather than at the end.
It's a very valid point. So for the audience, the decision to damage control is when you think about it, not when the criteria are met. So if the patient is hypothermic 32, DIC has set in, you have lost the battle. And therefore, it is very important that the surgeon, the anesthesiologist, and critical team work in unison, and they have to figure out what are the resources. Another thing is, Farooq, in our setting, it is resource dependent also. So one of the indications, at least there was once a time in our hospital where I ended up packing somebody because we were out of blood. And I realized that if we continue, we would lose him. It is better to pack him today and figure it out tomorrow. So the important point is, do it when you're thinking about it. Anesthesiologist is most critical. It is not the surgeon who should become the champion, that I would be making all those decisions. And then you look at your own local resources, and based on that, you should do it. In this patient, the concept of permissive hypotension is also important, because in emergency room, if you were chasing normal blood pressures with fluid resuscitation, by the time he's in OR, he is already in DIC. Again, extremely critical decision, require very high level thinking.
Any other questions? Okay, so moving on to the next presentation.
Just a question. You did not share the results of your fast, and would that have influenced your management in this patient at that time?
So it wouldn't have changed any management plan, but yes, the fast that was done right away, that was positive for blood in the abdomen.
About the solid viscera that you saw there? Did they tell you anything about the kidney, the shattered kidney, which was?
So it wasn't a formal fast, that it was done by the emergency team at that moment, not by the radiologist.
They just looked at the blood in the abdomen,
yes.
and nothing
They
else.
they just saw the blood in the abdomen, and we took the patient to the OR.
Okay.
May I ask you what sort of resuscitation taken place before the patient was taken to theatre?
So basically, in this situation, as we talked about permissive hypertension, we should have given blood as well as fluids, but in such a way that the patient does not bleed more. So it's very difficult to assess how much of the blood or crystalloid or any fluids that you're giving. You can't quantify it, but you have to maintain it at some point that the patient does not bleed more.
Okay, of course, you know, severe blunt abdominal trauma management is a decision-making process where you have team of people, but one of the decision-making is, can we use all our resources to manage it in a different way than what we did? And was any of the resources retrospectively you could think that you may have used to change the management, or you are retrospectively very happy with where everything went? Because that's the whole process we are doing here.
So in retrospect, it's very easy to judge ourselves.
I'm not asking easy or not. Just tell me, did you think that retrospectively analysis, would you have done anything different?
Okay. Professor Khurshid is alluding to the fact that could you have used interventional radiology instead of taking him to the OR, or doing a CT scan before taking him to the OR. So what is the answer to that question?
So I wouldn't have taken this patient to radiology. I would have taken, that's what we did.
Why?
We took the patient to OR, and the patient was unstable.
So,
Unstable, yes.
Can I add something here? We have some hybrid system. I don't know in which hospital we have availability of this system. In Gambut we have that we have hybrid OT with cath lab inside, and all equipments required like ultrasound or gadgets for the embolizations. So we do operate in this scenario, these kinds of facility for the patient.
So in order to be very clear about this, the answer is, in the emergency room, you stand by the side of the patient, you give them fluid, and you see the response. If giving 1.5 liter fluid shows that they have become stable, you have time, you should take them to CT scan. But if you give 1.5 liter and nothing is happening, then this is a pretty bad situation. And this patient should not. So if there's a fluid non-responder or person becoming worse on fluids, then you have to, unfortunately, take them to the OR, which is against our grit now, because we are so used to testing people before we do a laparotomy. So even for us, it's an unknown territory when we take our patient, blunt trauma patients without imaging. It's a very rare situation, but it is going to happen. And if you take this patient to radiology, this person will die.
I'll add something here, that in modern cath lab angiography, there is always availability of DynaCT inside it. So you can do DynaCT, you can do ultrasound in the hybrid OT system, and then you can, if you want to operate it, you can operate it, or you want to intervene by interventional radiology, you can intervene it. So it will be very much easy that site of injury is what and where, so that you can be very much targeted.
Yeah, I wanted to raise that point because this is a discussion and it's a learning experience. So the learning experience we can have only by critically looking at what we did and can we do it again next time better. So as been pointed out, I think every patient with blunt trauma, initial resuscitation, pre-hospital resuscitation, in a resuscitation, and then the decision making based on the availability of equipment and resources. So if you have got everything you have, you use it. If you don't, then you use your clinical judgment, and you have to see whether there is time available. And I'm sure resource becomes one of the main issue, especially for city like Karachi even. So I don't know what resources you have, but I'm sure you will be using all those to make a decision.
But I will say to my consultants like radiologists or or the in charges of the OT or surgeons, that they should demand these things in their facility with the administration, so that with plus minus a few million rupees they can add it.
Yeah, of course, that's very true, very true.
Panel members. So actually the time is up and we're running short of time. So I'm not going to be discussing the second case. So we'll move on with the session further. Thank you.
Thank you so much, all the panelists, for sharing your advices. It was a very informative session. Thank you.
Thank you.
Now let's move to our next session. That's a debate. It's on duodenopancreatic injuries in blunt abdominal trauma. For this, I would like to introduce our speaker, Dr. Abubakar Hafiz Bhatti. He is a Director, Transplant Program, Shifa International Hospital, Islamabad. Please come for your presentation. He will introduce the topic and then go forward.
Okay, Assalamu alaikum and good morning. So I'm Dr. Abubakar Hafiz and I work at Shifa International Hospital, Islamabad. So first of all, thank you very much to the organizing committee for their kind invitation, in particular Dr. Sajda Qureshi. So the topic that I have been assigned to speak on is blunt abdominal trauma and a little bit about introduction and controversies related to pancreaticorenal injuries. I've been assigned 10 minutes and I think that's a lot of time for me to share everything that I know about this topic with you. So I have no conflicts of interests. And traumatic injury is the leading cause of death under the age of 44 years. Blunt abdominal trauma is in the top 3 categories for preventable injuries. So injury to the pancreas and duodenum is not very common, but the rates of complications are very high. These are some of the common mechanisms of blunt abdominal trauma, and they are self-explanatory, so I'm not going to go through them. So before we kind of get into the management of abdominal trauma, I think there are some administrative aspects of trauma management that we must have a look at. So for example, the initial phase should be managed by trauma surgeons or general surgeons. As HBB surgeons, we are not really well equipped to manage these patients. We are not prepared to deal with emergencies. But once the acute phase is over, then probably the HBB surgeons should be involved. It is also important to recognize that while we deal with these patients in the acute setting, we must have the end in mind. So sometimes the surgeries that we do in the acute setting, they have an outcome in the long term. These patients can have complications because of those surgeries. So it's better to have that in mind as well. A good trauma center is not only about trauma surgeons and trauma anesthesiologists, but you also need a very good interventional radiology and gastroenterology department. Now, this is also important because now we're kind of expanding the role of non-operative management in these patients. So that is why it is good to have good gastroenterology and IR services. Transition care is extremely important. These are polytrauma patients, and sometimes one specialty has to give the patient over to the other specialty, and so there should be no delays. It should be seamless, and all relevant information should be passed on because this has an eventual bearing on the outcome of patients. So for the purpose of trauma, the pancreas is divided into distal pancreas, that is to the left of superior mesenteric vein, and into the proximal pancreas, which is on the right side of the superior mesenteric vein. So injuries to the distal pancreas are relatively more straightforward. They are relatively milder, but injuries to the proximal pancreas are more severe. This is the AAST grading of pancreatic injury, and essentially it depends upon the location and whether the duct is involved or not. So grade 1, grade 2, and grade 3 injuries are injuries to the distal pancreas, and when the duct is involved, it is grade 3 injury. Grade 4 and grade 5 injuries are injuries to the proximal pancreas, and in particular in grade 5 injury, there is massive disruption of the pancreatic head. In contrast, when we talk about duodenal injuries, it's about the extent of perforation and whether the D2 is involved or not. So if second part of the duodenum is involved, then you have more extensive injury. In particular, when we talk about grade 5 injuries, these are injuries where there is massive disruption of the duodeno-pancreatic complex and there is devascularization of the duodenum. Now, this is a very busy management protocol. This has been proposed by the WSES and AAST, and I'm not going to go through it, but really the summary of this protocol is that if you have a stable patient and the injury is early AAST grade, then probably non-operative management is a good option. On the other hand, if the patient is unstable, advanced grade, there is peritonitis or there is bowel evisceration, then probably operative management should be done in these patients. So what about the controversies related to this topic? And there are certain controversies about non-operative management, and then there are others that are about surgery. So for example, what about ERCP? Should we do ERCP in these patients? Well, majority of these patients, if you do a CT scan, you would be able to diagnose pancreatic injury and whether the duct is involved or not. But sometimes it is not clear. And if you do not do ERCP in these patients, then you might miss out on these injuries. So should we do it? Because ERCP in itself has certain complications. And what should be the timing of ERCP in these patients? Then the role of non-operative management in grade 3 and 4 pancreatic injuries. So grade 3 injury is actually injury to the distal pancreas. You can just explore the patient, do a distal pancreatectomy, and it's over. But now there is a role of non-operative management as well. But which patients are going to benefit from non-operative management is not clear. Probably our next speaker is going to enlighten us a bit more about that. Then grade 4 injuries, which are actually injuries to the proximal pancreas. So essentially when you think about proximal pancreas, you're thinking about surgery, but now there is some role of non-operative management even in these patients. And there are a lot of controversies about surgical management as we've just witnessed in the previous section. So for example, laparoscopy. Would you do a laparoscopy in patients with blunt abdominal trauma? What about patients who have suspected pancreaticoduodenal complex injury? You know, you need a different skill set for laparoscopic mobilization of the pancreas and the duodenum. So should we do it, and what should be the timing? Pyloric exclusion with or without gastrojejunostomy? What are the indications? What technique should be used? And then the role of pancreaticoduodenectomy in AAST grade 4 and 5 injuries. Now, pancreaticoduodenectomy is a complex procedure in itself, but sometimes we have to do it in trauma settings. So would you do it? And if you do it, would you do a simultaneous reconstruction, or would you prefer a staged reconstruction in these patients? And then obviously different surgical techniques that can be used for grade 3, 4, and 5 duodenal injuries. So there are a lot of controversies. We don't really have clear answers to these questions. So just to highlight the controversies, I'm going to go over to studies quickly. So this is a multi-center European study that was recently published. So out of 165 patients, 106 patients had surgery. And on the x-axis, you have the pancreatic injury scale. So it is obvious that grade 1 and 2 injuries were predominantly managed in a conservative fashion. And patients with grade 3 and 4 injuries had pancreatic surgery. But there is a lot of overlap. So some patients with early injuries had surgery, and some patients with more advanced injuries also had conservative management. So you really have to decide and pick and choose which patient is going to benefit from which intervention. What about duodenal injuries? So this is a study from the Pan American Trauma Society, and they included more than 350 patients. So primary repair was the most common surgical technique that was used to manage duodenal injury. But the other common indications or surgical techniques were pyloric exclusion with gastrojejunostomy, pyloric exclusion without gastrojejunostomy, and primary repair with drainage. So these are all the different options, but interestingly, the duodenal leak rate was lowest with primary repair. And we can argue that probably these patients had early grades of injury, but that's not true, because a lot of these patients had grade 3 and 4 and 5 injuries. Despite that, primary repair had a very low leak rate. So I would like to conclude here by saying that pancreaticoduodenal trauma is uncommon, but associated with high rates of complications. General and trauma surgeons should take the lead during the initial phase, but definitive management should involve HPB surgeons. Usually, but not always, high-grade injuries require operative management, and there is evolving role of ERCP and non-operative management for high-grade stable injuries. With regards to operative management, the definitive role of laparoscopy, bypass procedures, and pancreaticoduodenectomy remains to be defined. Okay, so this is a picture that is almost 15 years old. That's when I completed my training from Surgical 4, Civil Hospital, Karachi. And Dr. Sajda is here, so she's one of my mentors as well. So very happy to see that I've been given the chance to speak here today. So thank you very much for listening to me patiently.
Thank you so much, Dr. Abu Bakr, for a wonderful presentation. Without further ado, let's dive into next presentation on early operative management in blunt abdominal trauma. So please join me in welcoming Dr. Rizwan Khan. He is Professor of Surgery and Associated Dean, Postgraduate Medical Education from Aga Khan University Hospital, Karachi. Over to you.
Assalamu alaikum, good morning, thank you very much. Thank you, Abu Bakr, for doing this. You have made my job really easy. I just need to talk about some of the controversies here. But just to remind you that I'm going to talk about the blunt trauma, and the focus is on early operative management, right? That's where I am. First of all, why is this topic important? I was just wondering. Is it because of the vascularity? Is it because the seniors told us duodenum and pancreas are serious organs, don't touch them? Or is it because a lot of fluids going through this tract? Why is this important to discuss? I think the answer is everything. All of this is important. That is what makes this area really a challenging area for the surgeons, gastroenterologists, and radiologists. And you can just look at the vascularity. It's a huge number of named vessels all around, both arteries and veins, which make this area really serious, a challenging area for us. Similarly, the organs. I might go through quickly because I'm mindful of time, but I'll try to emphasize on the important issues here, especially the surgical issues. So the questions or the challenges in the early operative management of duodenal pancreatic injuries are these, and I'm going to touch on them one by one. First of all, can we make an early and definitive diagnosis, especially in the setting of a blunt trauma situation? Do we have sensitive specific tools? And even if yes, do we know when to intervene? So maybe I'll discuss this question first. So first of all, clinical diagnosis may be a challenge. So first you must suspect that there may be an injury, because up to 30% injury may be missed at initial assessment. And the last line is important. If there is a delay, the mortality goes high significantly. That is why you must suspect, you must make every effort to diagnose, especially in a blunt trauma situation. Some situations are really easy. For example, patient requiring exploration for massive bleeding, peritonitis, or evisceration. That is where you should look for erythroperitoneal hematoma, bile staining, air. Must do full mobilization. That will give you some idea of the injury, and you must do all that if you suspect an injury. And then there are certain clinical suspicion areas, just mentioned there. Abu Bakr also highlighted those situations. Is there a role of EFAST? We talked about the EFAST a few minutes ago. Is there a role of EFAST in this region? The answer is that EFAST is not very sensitive, not recommended routinely to diagnose pancreatic and duodenal injuries, so that's very clear. X-rays, not really helpful. So what do we do? So are the enzymes helpful? Not just one set of enzymes. It's the increasing level after certain hours that might indicate for more investigation. Again, not really diagnostic that you have an injury in the pancreas or duodenum. And also not necessarily some correlation with the level and severity of injury. So what do? I think the CT scan with the IV contrast is the best modality in this situation, and there are a number of findings that can help you diagnose or suspect duodenal pancreatic injuries. Some of them are fairly straightforward, for example, free air, pneumatosis. But some of them, for example, duodenal wall hematoma, may not be very sensitive. Again, pancreatic injury, retroperitoneal fluid. If you have a clear-cut ductal injury or disruption, that is where you know that you have the injury, but otherwise it's a gray area. But if you are not sure, you can repeat the scan within the next 12 to 24 hours. That might give you a better idea. And again, this last line is important. Laparoscopy, not really a definitive role. You must have sufficient experience to explore this area in a trauma situation. So I would say not really an acute situation. That's where I am. But if you are suspecting duodenal injuries and your patient is deteriorating, even if there is no evidence, there is no harm in exploration, because otherwise you may miss a serious injury. That's what my message here for the trainees is. I will not go much into severity and grade because Abu Bakr has done all that job. The critical point for duodenal injury is the presence of number one, bowel wall injury, number two, the ampulla, whether it's involved or not. And for pancreatic injury, the main issue is whether the duct is involved or not. These are the 2 or 3 main questions for the management of surgical problems. So just going through them one by one, early injuries, duodenum is essentially hematoma, or maybe partial thickness laceration, which may need repair, but for the early injury, for blunt trauma patients, is essentially non-operative. Not much to do for hematoma. You can wait for up to 2 weeks. Similarly, grade 2, more than one wall hematoma. You can wait. But if there is a circumferential full thickness laceration, of course, this will need repair in almost any situation in a trauma patient. And the best technique is primary repair, just mentioned in the figure down below. The difficult part is 3 and beyond. For the duodenal injuries, grade 3, some sort of repair needs to be done. And it will depend on which part is involved. And all these techniques are really described. You can do primary repair if the ends can be brought together easily. You can do a duodenojejunostomy. You can do a duodenodudenostomy. So depending on which part is involved, and this will need complete mobilization of the duodenum to look at the extent of injury. Again, the question may be how to find the ampulla, and there are different methods which are described. Moving on to grade pancreatic injury, early grade, I would think non-operative, no question about it. But the grade 3, if you can find preoperative, I think the best option is to go and take the distal pancreas out. That's what my suggestion would be for all this situation. And I know Jahanzeb is going to debate this, but that's where I am. Again, exploration, I will not go into the technique because of the limitation of the time, but complete mobilization, look all around the duodenum pancreas. Don't miss if you're exploring a patient in a difficult situation. Complete exploration is the key here. Distal pancreatectomy, fairly easy operation, not really technically demanding. Issue is when this is more complex problem. Again, the question is whether ampulla is involved or not, and whether there's a complete disruption of the duodenal pancreatic complex. This is where it's indication of severe trauma. You must think of a damage control, which means control hemorrhage, control contamination, and then in the first stage, you can wait. Of course, control contamination means you do the repair of the duodenum. Do not leave the duodenum fluid going out and bile going out. But you can wait, you can pack, you can resuscitate, you can come back again with a friend. And friend means a hepatobiliary surgeon, of course, all of you have those friends, right? So that is where the management of complex pancreatic injuries is important. These are the procedures described in literature. When do you apply that? For example, diverticalization, mostly described for complex injury presenting late, not really early injury. And early situations, again, this is also one of the described techniques, the triple tube technique. This is again for delayed presentations. For early, mostly you do primary repair if possible, and drain, drain, and drain. That is what the recommendation is. What about the role of pyloric exclusion? Again, if you are not sure about your repair, you might consider this, not as a primary technique. And there are different methods to do it. Whatever you do, this is a serious problem. Some people will have an outcome which is not what you want, which means high morbidity, high mortality, which is multifactorial. And the complication, again, all these abscesses, leak, fistula, biliary leak, these are all serious challenges where, of course, your intervention colleagues will help. And also, similarly, the pancreatic injuries. So, summary. My focus was essentially on operative strategies. I did not compare the two because I'm sure we have a next talk where you can find some of the comparison. But severe injuries remain a challenge and usually associated with hemodynamic instability. So you must resuscitate the patient. If you explore, must do a thorough exploration, must find the injury, must try to address it there and then. But in most of the difficult situations, you will need a second exploration, and you should not be shy of this. So thank you very much. I'll stop there.
Thanks, Dr. Rizwan Khan, for the wonderful presentation. Next presentation is on non-operative management. For this, I would like to call upon the stage Dr. Jazeb Haider. He is Associate Professor and Consultant Liver Transplant and Hepatopancreatobiliary Surgery from Dow University of Health Sciences. Please, Dr. Rizwan.
Assalamu alaikum and good morning. And I'm very much thankful to scientific committee and especially to Dr. Saja for inviting me for this talk. And I am very grateful to my contemporary colleagues who have already made my presentation easy for this point of time. So my talk is related to the non-operative management of duodenopancreatic blunt and trauma. I also have no conflicts, no disclosures so far. Duodenopancreatic abdominal injuries are considered to be a transitional lesion because the treatment may vary according to the time and it may involve more than one organs. Ideally, the approach should be the multidisciplinary, although the initial phase is best managed by the emergency and the trauma surgeons as damage control surgery is necessitated at that time. But later, where the reconstructive surgeries are required, HPB surgeon should be involved in the team. In addition to this, interventional radiology services as well as gastroenterology services should be included in the management of the trauma because to improve the success of non-operative management associated with various complications and to demonstrate the early and the late complications. So the transition of treatment strategy that Dr. Abu Bakr said is utmost important and should be quite rapidly and as seamlessly as possible to avoid the later mortalities and morbidity associated with those traumas. I will not like to go into the detail as most of us are aware about mechanism of the blood abdominal injuries, but I would like to say that the high velocity injuries are most commonly associated with blunt abdominal injuries followed by direct flow and the fall. So most commonly involved organs are the spleen and liver, but duodenum and the pancreas is in the range of the 3.7 or 1% to up to the 11% in all abdominal trauma. But accompanied with the associated injuries are present in 86% of cases. So the combined or the isolated duodenopancreatic injuries, this is a very small portion which we came across with blunt abdominal trauma is only 4.7%. And my talk is particularly related to the smaller portion of that one is a non-operative one. So let's define the learning objective regarding to that presentation that one should be able to identify the clinical parameters, diagnostic protocols in identification, recognize the indications, and implement and monitor the non-operative management protocols, and to address the complication as well because it is quite frequent with that, and identify when the surgery is needed. This is very much more important. So let's do a quick review of the classification of duodenopancreatic injury. We all know about the AST and the WSS guidelines, and all we know about there is the grading from minority to the severe in both in the duodenum and the pancreatic injuries. So the WSES classify the classifications or grade the injuries and make the management more ease in 4 categories. Grade 4 is any type of injury in whom the hemodynamics are unstable. It should not be the candidate for a non-operative. However, grade 1 and 2 pancreatic injury in which there is zone ductal involvement and the grade 1 duodenal injuries are considered to be a minor grades of the West. However, grade 3 pancreatic injuries and grade 2 duodenal injuries are the moderate, which can be managed up to certain extent with a non-operative, which we will discuss in the slides. So initial assessment again related to the primary survey and ATLS protocols, and after that one should give attention to the abdominal symptoms, particularly to the hemodynamics. I will highlight it with red color because this is very much important. And according diagnostic modalities is a multidimensional CT scanning. IV contrast is the gold standard. So these two things should be kept in the mind. So what do you mean by hemodynamic instability? It has already been defined that in the ATLS protocol, although in the WSS guideline, if the systolic blood pressure is more than 90 millimeter of mercury with no signs of vasoconstriction, and there is no altered level of consciousness or shortness of breath, or if the blood pressure doesn't require any vasopressor supports or admission-based access is less than -5, or if there is no or the less PRBC transfusion within 24 hours of admission, so those are the patients who qualify the criteria of hemodynamic least responders, and those patients should be undergo diagnostic settings, and non-operative management can be done on that. So the CT scan is the gold standard, and as you can show that there is a retroperitoneal fluid collection, air focuses, or there is a peripancreatic collection, hematoma, laceration, or with or without duct involvement. These are the cardinal findings which one can find in a stable patient in a duodenal pancreatic injuries. So I would not go into the detail of that detailed diagnostic modalities, as the serum biomarkers are not very specific and sensitive for the duodenal. But if you have a patient who have a suspicion of the pancreatic injury and primary CT doesn't exclude that, then the serial amylase and lipase can be helpful in diagnosing the blunt pancreatic injuries. There is no role of fast in the duodenal pancreatic injury, that Dr. Rizwan already told that. CT scan is a gold standard, and it will not only delineate, but is also involve the extent of the injuries as well. And you can find the associated injuries as well. However, there is no role of oral contrast. MRCP can be done as a second line of management to identify the ductal injuries, but not as a primary one. So the indications of the non-operative protocol, one should have a very clear about that patient must be a hemodynamically stable, and there should not be no other primary injuries. Now go on the particular detail in the presence of hemodynamic stability and the absence of other abdominal surgery. So grade 1 duodenal injury can be easily managed and successfully managed with the non-operative manager. However, in a selected group of a patient in which there is a contained or retained minimal retropancreatic duodenal fluid, they can be managed effectively with non-operative tools. However, grade 1 and 2 pancreatic injury can be successfully managed. 3 is again, Dr. Abu Bakr and Dr. Rafzan both told that it depends on the location. If there is a distal pancreatic injury, so one should go for a distal splenectomy. I am in favor of a distal pancreatectomy. However, if it is proximal, or if it's proximal grade 4, these are the controversials. There must be a high volume trauma center who have a 24/7 IR and the endoscopy services are available, then these type of patients should be managed over there. So non-operative operative management protocols include again a fluid hydration, maintenance, invasive vital monitoring, urine output, serial amylase levels if there is a suspicion, frequent abdominal examination, and the serial CT scan. The CT scan should be done within 12 to 24 hours after injury to demonstrate the extent of the injuries or to clarify the primary injury. Supportive care can be added like parenteral nutrition, antibiotic, analgesia should be given in all those patients. So there is two things. One is serial imaging, and second one is the serial examination. So there are certain complications which include a localized sepsis in 7 to 25%. Most of the patient who are being dealt with the non-operative management, there is a pseudocyst formation, there is a pancreatic fistula in 30 to 35%, but it's the data which is related to the operative rather than a non-operative one. Post-traumatic pancreatitis is present in 17% of patients. So when you would suggest there is a surgery is needed or not, when there is a hemodynamic instability, there is an uncontrolled sepsis, increasing abdominal symptoms, or increasing imaging showing worsening injuries, and hematomas which was initially treated non-operatively, but after 14 days it doesn't resolve. I'm not going to detail into that busy algorithm. We already know about that. Now, I would like to discuss few more cases. First of our case, which is the failure of the non-operative management, a 36-year-old male sustained a direct injury, blunt abdominal trauma. He was conscious and oriented, vitally stable, abdomen was distended, and laboratory parameter shows the high amylase and lipase levels. So the initial CT shows a contusion of the pancreatic area. Okay, thank you. आपने तो बंद ही कर दिया. चलें.
Thank you, Dr. Jazeb Haider, for informative talk on non-operative management in blunt abdominal trauma. These blunt abdominal injuries are always a challenge. However, insights shared by our speakers will guide us in decision making. Now let's move forward to our talk on unveiling the silent threat, exploration of renal trauma. I would like to invite Dr. Shaullah. He's a consultant urologist at SIUT.
Okay, thank you. Assalamu alaikum everyone. I'm Dr. Shah and I'm assistant professor at the Department of Urology, SIUT. And today I'll be discussing about the renal trauma after this whole discussion from the peritoneal cavity. We are sitting right behind your peritoneal cavity. So it will be equally important. So this is basically approximately 10% of all the abdominal trauma. And if we talk about specifically about the renal trauma, this is the 5%. And of those 5%, 80% are the blunt. As we know, the children are more prone because of the larger size with the less coverage from the rib. So the mode of injury is more or less the same. It's a direct blow or the rapid acceleration, deceleration injuries. And we talk about the penetrating, we know we are a vulnerable population with the gunshot injuries and the stave injuries. So if you look at the grading one, it is very good for the prediction for the intervention as well as predicts the morbidity and mortality. That's I would just quickly remind all my junior colleagues about the grades. The grade 1 is, you can appreciate there's a tiny hematoma there, and the grade 2 is a tiny hematoma with a small laceration which should be less than 1 centimeter. For the grade 3, you can appreciate the hematoma with the laceration which is more than 1 centimeter. Grade 4 and 5 are very important to know that you can appreciate the laceration is involving the pelvic lysyl system. So you must be seeing a lot of urinomas or urinary extravasation in such cases. Apart from this extravasation of the pelvic lysyl system, you can also see minor vascular injuries in grade 4, like the segmental or the lobar or the interlobar arteries might be damaged. For the grade 5, it's the shattered kidneys, the main hilum is injured, or if it's utero-pelvic junction might be the reason. So on presentation, patient might have a microscopic or the gross hematuria. It may have tenderness or chymosis over the flanks, or it might be presenting like an acute abdomen, or it might be presenting with the famous Gray Turner sign. And for evaluation or assessment, you have to do the basics, which has already been discussed here. I will skip. This is the Gray Turner sign you must be familiar with. So for imaging of a patient, you're suspecting a renal trauma, the indications are quite simple. The patient might be presenting with a visible hematuria, or they might be non-visible hematuria with a single episode of hypertension, or the mode of injury is rapid deacceleration injury and significant associated injuries, or it will be penetrating trauma, or there may be clinical signs of trauma like flank pain, abrasion, bruises, fractured rib. So basically the mode of injury is suspected for the renal trauma. And for pediatric population, if it's the microscopic hematuria, you have to go for imaging. So our imaging is a multiphasic. The rest of the things is quite similar to the abdominal trauma. The most important one is the last one, the delayed phase. We need the delayed phase to rule out the ureteric injuries and the pelvic lysyl system injuries. So most patients can be managed non-operatively. So we talk about the non-operative, the first and the foremost thing is the center, where you have the specialized facilities available to deal with the lot of things associated with the kidneys and the ureteric trauma. For example, if we talk about serial monitoring or the protocol, this is quite simple, that you have to be strict on your vitals, then the serial HB monitoring and the hematocrit levels, then bed rest till hematuria resolves, regular observation, and re-imaging in 72 hours if everything remains good. But if you have a fever, flank pain, dropping hematocrit, or increasing hematuria, you have to re-image earlier. And the failure of non-operative is as high as 20% of the cases. When we talk about the non-operative management, there are certain tools which must be aware from my general surgery colleague as well, that these are the modalities quite widely available throughout the world and that can do good for the patient. Like this is a ureteric stent. If you are suspecting a pelvic lysyl system, you can just put a stent there and it can prevent the urinary extravasation, ultimately decreasing the chances of the collection and the abscess formation, and ultimately a patient landing into the sepsis and those complications. And this is another. This is a simple percutaneous tube where the system is hydronephrotic. This hydronephrotic might be secondary to some compression from urinoma or a hematoma. So you can easily drain the kidney, and this can help in the healing phase of the kidney. Others are the percutaneous drain, and another important aspect is the angioembolization. It is discussed by Dr. Yusuf Mehman and Dr. Asadullah Irfan initially, that this is a very important tool in non-operative management. And this thing relies on the stability of the patient. So this is one of the case where you can appreciate the bleeder was quite adequately managed via a non-operative management through angioembolization. For angioembolization, you might need a repeated session of angioembolization in case of the renal trauma somehow. And there is as high as 30% rate of failure in angioembolization when the injuries are in the major vessels. By major vessels, I mean the main artery or the segmental artery. Right here, the injuries is likely in the lobar artery. So if we talk about the operative management of for the closed renal trauma, there are some absolute indications, like if there is a hemodynamic instability or expanding or pulsatile hematoma in ours, like zone 2 of the abdomen, and the suspected renal vascular pedicle, or you are expecting a hyaline injury, or pelvic-ureteric junction or disruption. There are some relative indications for if you are managing patient non-operatively and you are seeing no good outcome or progress in the hematuria or the other signs of the patient, you can always go for the exploration. So overall, most of our cases are basically started from our general surgery colleague who, as patient's presentation is most of the time is unstable. So the transperitoneal, it's even otherwise preferable approach for the exploration of the kidney. For just a quick review for the transperitoneal approach, the key is quite simple. You have to get the control of the hilum first. Literature said that if you get the control of the hilum first, there are 30% less chances that you will end up having a nephrectomy of the patient. So for us, the saving every nephron is very important, and literature proves that these saved nephrons helps in the life in the long run. So just have to eviscerate the bowel and then palpate the aorta, and then you have to open the posterior peritoneum right above the aorta. And if there is a masking of the aorta via some hematoma or anything like this, you can always use an inferior mesenteric vein as your marker. Right, jumping upon the kidney or just opening the line of Todd and directly opening up the hematoma is never advisable, because it is ultimately ending up you're having a nephrectomy rather than saving any nephron. But definitely, the patient life is more important than the kidney. In such scenario where the vitals of the patients and the situation demands it, you can always go for nephrectomy. And okay, so this is algorithm provided by the European guideline. The algorithm is very simple. For grade 1 to 3 injuries, if the patient is stable, the non-operative management is the standard of care. For unstable patients, For grade 4 and 5, the patient is stable. The management is like you can go for non-operative and the operative as well. But for unstable patient, definitely management is surgical. I would quickly go through the 3 cases here. The first one was a 14-year-old boy. He presented in ER with a history of RTA. It was actually hit by a bike while crossing the road. His abdomen was distended and tender. He was having vomiting and hematuria. After resuscitation, ultrasound was done, which showed subcapsular hematoma of 150-200 ml. So patient was vitally stable on presentation. So we go for the staging of the trauma, and we found that this was the CT films. The coronal view of the city. And you can appreciate here on the right side, there is a parenchyma of the kidney, and the upper pole of the kidney is well there at that place, but you can't appreciate the lower pole of the kidney, and there is a large hematoma there. But we can, the good thing about this, we can still appreciate the renal artery, which is there. Okay. In this particular film, you can appreciate the hematoma is there, but you can also appreciate the contralateral kidney is good, and it is taking up the contrast. I mean, he has a normal contralateral kidney. So if you look at the reconstructive images, so he was a lucky guy who is having early division of the renal artery, and the main segmental arteries were very intact, and they were providing good perfusion to the upper and the mid pole. So we planned for exploration. This was another view. So before planning for exploration of the renal trauma, one must be having a good experience and be knowing the other techniques to save the renal unit rather than just going and removing the kidney. So for renal reconstruction, there are few basic requirements, like you must be having a complete renal exposure. I mean, you have to completely immobilize the kidney from the upper pole, lower pole, and the hilum. The kidney should only be hanging up on the artery and vein or ureter while proceeding for these reconstructive surgeries. For debridement of the non-viable tissue and the hemostasis of individual ligation of bleeding vessels, then watertight closure of the collecting system. Most of the time, this watertight closure of the collecting system is not possible, and just approximation of the parenchyma is enough, but you have to provide some drainage in the form of stent or PCN tube in such cases. And you must be using liberal uses of drain, because in such scenario, you must be expecting a working drain for a day or two, and this is pretty normal. You can bear with this. So this was the case which I mentioned. It is a 14-year-old boy, whose CT was just shown to you. So on exploration, you can appreciate there's the upper pole and the lower pole, and there's a large defect in between where there's a hematoma there. And now these are further pictures, and when we dig down to see that how deep the defect is. And this is after we have removed the hematoma, and we have reapproximated the upper and the lower pole, as the damage was only the early division of the artery while the segmental were intact. And we have covered this with the omental flap. So this was another case where there was a history of the stab wound to the 32-year-old male, and he was vitally stable on the presentation. This was the wound. It was likely a junction of the lumbar and the iliac region on the left side. So on exploration, you can appreciate there is a deep stab on the kidney, which is actually lacerating the kidney from the mid to the mid into lower pole. On further examining, it was deep enough, and it was unfortunately extending into the hilum region. You can appreciate this in these pictures. Okay, and so it has to be removed because the main vessels were not intact. So this was the kidney. So the last one was basically a history of RTA, 45-year-old male with a complaint of the gross hematuria, and he was vitally unstable on presentation, and he was explored by our general surgery colleague, and call was given for a retroperitoneal hematoma. So patient was explored by a urologist, and on exploration, we can appreciate there is a lower pole of the kidneys having a damaged part, likely just about 30% of the kidney. And this was the damaged part or devitalized part of the kidney. So this was removed, and the rest part was reapproximated. You can appreciate this here. And then it was covered with a omental. So this is how you can manage a lot of these cases with the minimal, by not just removing the kidney and just repairing it and saving the nephron for the rest of his life. Obviously, there will be complication like early period, you need a good monitoring. It could be bleeding, infection, because you are repairing. One important aspect I would like to highlight, the vascular repair is usually not recommended in cases of the renal trauma because it's seldom useful. But cases where you are dealing with like patient doesn't have a other kidney, he's a solitary kidney, or his other kidney is non-functioning. So this is a solitary functioning. Those are the cases where you can definitely go and try for vascular repair as well. So for follow-up, you need a BP monitoring, you need a serum creatinine, and you can go for a nuclear scan to see that the nephron you left behind after repairing it, how much useful these are for the patients. That's all. Thank you, everyone.
Thank you so much, Dr. Ashawallah, for the wonderful presentation. Now, let's move forward to our next segment on question and answers. So for that, I would like to ask the audience if you have any questions, especially regarding the debate which we just had on the non-operative and operative management of pancreatoduodenal injuries. So then we can have a better understanding of all these things. Any question?
All right. Nice talks about pancreas and duodenum. My name is Professor Farooq Afzal. I am from Lahore. Now, yesterday I was talking about motorcycle injuries, and I just named them as free corridor injuries, right? Where the motorcyclist becomes a missile, right? He's thrown against multiple things, and the injury pattern I have never seen before. So especially in duodenum, where we're talking of the primary closures, there's a lot of non-viable duodenal wall. And the primary closure is not possible all the time, right? Because we have to, even in the blunt trauma, we have to resect or excise that dead duodenum. And in that situation, still we like to do a primary repair, and we usually use the jejunum as a side patch. So I think serosal patch using jejunum instead of just trying to close it tightly is a very good option in such situations primarily. Penetrating pancreaticoduodenal injuries are very lethal ones, and despite we are right at the road, Firozpur Road, where are 3 hospitals, if the patients are hit, I think the mortality is very, very high. Just wanted to add this. Thank you.
Thank you for your comment. Anyone want to add on that? That the question is that primary closure is always a good one, but at the same time controversial. So let's see any comment from anybody else.
So I think one has to look at the extent of injury. Primary repair is the first option if possible. And of course, there is a devitalized tissue that must be debrided. And that will leave some defect. And then you have to make your decision whether you want to use a serosal patch, as you suggested, which is a valid option, or you want to use jejunum to make an anastomosis there, depending on the size of the hole that you will find. So all these options are there. I don't think they are in competition with each other. You will have to use your judgment depending on the situation, which is the best option in a given situation.
May I ask one other thing which is important always for primary repair, is the timing, when up to what time you would consider. Is there anything specific in pancreatic or duodenopancreatic injury for primary repair? Time span, is it important?
So I would think that, so my focus was mainly on early presentation within the first few hours. So if the patient is stable enough and the contamination is limited and the bowel is viable, and the first, which means maybe up to 6 hours, you would probably consider a primary repair. Beyond 6 hours, I think there'll be some degree of contamination, and you need to reconsider what are your other options. Still, I would think a patient is stable, there is not much tension, and you can control the contamination, I would probably still go for primary repair. But if this, maybe the gap is bigger, that there's tension on the repair, then you might want to use other options. That's what my preference would be.
Anyone else?
Hasnain Zafar, I'm trauma surgeon at Aga Khan Hospital. One of the my
my comment, and I would like to hear, is we have published a series of about 30 patients. In our context, 63% of the patients presented late.
Yes, that's it.
And you have to put it in perspective, because everybody who's probably seriously injured is dead at the scene. So in our context, this has to be modified. Then none of these injuries are isolated. I have almost never seen a pancreatic injury without a colon injury, without a liver injury, without a spleen. So decision making is individualized. In our series, everybody, our complication rate was about 80%. So a lot of them were sick with complications for very long, and our mortality was around 23%. And we have found out that conservative treatment versus surgical intervention both have their sets of complication, and everything has got to do with timing. So early cases, maybe some kind of intervention, later conservative. We've delayed complete pancreatic transactions for very, very long. They developed pseudocysts, drained them non-operatively. And some of the fancier stuffs like putting stents across pancreas, etc., does not work.
Thank you very much. Anything on renal injury? Anyone here to comment? We must hear something on renal. Yeah.
Is there any role of ERCP in pancreatic injury grade 3 especially? Can we save the patient from surgical intervention?
These are the fancy things, ERCP in doing grade 3 distal. As I already told, and Dr. Rizwan already said about that, it should be ideal to go for a distal pancreatectomy straightforwardly. When you can manage it by a ERCP means, but what can you do with the remaining part of the pancreas? How can you drain that pancreatic secretions, the part which is transected? How can you do that? You can place the ERCP stent. You can think about that there might be some drainage from the pancreatic PD stenting, and but the transected portion is going to leak. It will either develop a pseudocyst. You would be lucky enough to have a pseudocyst in those type of patients. Otherwise, you will get into a lethal sepsis. So it's better to deal grade 3 distal pancreatic injuries with this distal pancreatectomy straightforward, upfront. But there is a role, as I already said, that if you have a very sound IR guys, if you have a very sound gastroenterology services, you have a very good critical care unit, then you can think about in a selected group of a patient as well.
So the message is that distal pancreatectomy, if is indicated, then you probably should consider that as a first option. Obviously, in a specialist center and with a specialist input, you may be able to save some of that. But one of the reasons is that distal most of our patients can survive well following this distal pancreatectomy. So that's the safest option. Yes.
Yeah, so I mean, I actually had two comments. One was about distal pancreatectomy and distal pancreatic injury. So I'm actually following 3 patients who had a distal pancreatic injury. They were operated somewhere else, and then drains were placed. A distal pancreatectomy was not done in these patients. And they've come to me later on, they're severely malnourished and they're not doing well. And now even a distal pancreatectomy is not possible because their belly is a mess now. So I think once you have explored a patient who had a distal pancreatic injury, you must do a distal pancreatectomy, if the patient is stable, obviously. So that was one thing. And about duodenum, yes, you have to be selective. It is obviously individualistic. But I think the message was that sometimes surgeons are a little worried of the duodenal leak. And so even when a primary repair is possible because the tissue is healthy, the patient is relatively stable, but they would probably still go for a gastrojejunostomy and pyloric exclusion. That is not required. But obviously if you have dead tissue, there's no question you cannot do a primary repair. Thank you.
Yeah, thank you so much. Now I would like to request our chair, Professor Khurshid Akhtar and Professor Rahil, for their closing remarks.
Can I help? Can you hear me? We had a very good session today with presentation from radiologists, surgeons, especially operative and non-operative measures. And it has brought up a lot of questions from the whole audience and to mine as well. And I congratulate the whole team to produce such a subject. I had a few questions which I'm leaving open for most people to think of at some stage. What is the ideal investigation for somebody who has a duodenopancreatic injury? Who should be operating on them? Should it be the primary trauma surgeon or should it be a hepatobiliary surgeon? What investigation, as I've said? And one thing that comes to mind is when you have a renal trauma, how do you evaluate ureteric injuries in the penetrating, especially penetrating and blunt trauma as well? So these are questions that will still need to be answered at a later stage, but I congratulate all the speakers for the excellent presentation and hope we tend to see them and hear from them in the next future. Thank you.
Well, I second all the things that have been said about the organizing the events like this. I think trauma management has gone through many changes across the world. I think experience in countries like Pakistan is accumulating, unfortunately, because of the various things that's happening, and the people here have got immense experience. And I think it is important that you share that and maybe add to the overall understanding of these issues, because most of the understanding of management of trauma has come from the negative aspect of our life, like war or accidents. And unfortunately, these are the things which helps us to organize further management. So good to organize all these. And my point would be that collect as much data and as much possible and share with everybody else so that we all can learn. Thank you very much. And obviously there are lots of other questions.
Yeah. I'd like to extend a heartfelt thank you for chairing our session, Dr. Akhtar and Dr. Rahil. Your contribution is valuable. Thank you once again for your participation. Now, I look forward to ongoing discussion throughout the conference. Please join us for a tea break, for a short tea break. I would say it is for the 10 minutes. Thanks, everyone.
Hello, Assalamu alaikum. Welcome back. I'm Dr. Kailash, working as a consultant radiologist at SMBBIT, and I'm going to moderate the session that is mass casualties and trauma in the special situation. So, I would like to invite the chairs at the stage, Mr. Syed Salman Shah, the Director General, Province Disaster Management Authority, Government Office. Sir, please come on the stage. Dr. Abid Jalaluddin Sheikh, co-founder, Director General, Sindh Emergency and Rescue Services 1122. Sir, please join. And we have the speakers. First of all, I would like to invite Professor Sohail Ilyas, the head of department of the surgery, CMS Rawalpindi, and talk on the civilian versus combat injury, the difference is the mechanism and the management. Sir, please.
Well, Assalamu alaikum, ladies and gentlemen. First of all, I'm really privileged to be speaking on the podium from the most premier institute of trauma that we have perhaps in the country. So I'm very much privileged. Now, I would be in the next few minutes, I would be cruising you through the predicaments and challenges faced by a combat medic. Yesterday, taking cue from yesterday's presentation where one of our colleague speakers described polytrauma as a battlefield. Now, I was wondering what should a polytrauma in a real battlefield be called for? So really it's up to your imagination. But in the next few minutes, I would be cruising you through the predicaments, challenges faced by combat medical services that we have in the army, in the armed forces. So yes, some of you might argue that combat trauma is trauma, whether combat or civilian. We have to care for whether we are putting on whatever uniform. We have to care for trauma as per the guidelines. However, there are certain peculiarities, certain challenges which are peculiar to the combat environment, and I should be dwelling upon it in detail in the ensuing few slides. No doubt, no doubt, our common objective remains the casualty survival. Now, yes, you can argue that in some rural and austere environments, in the civil setup also, trauma is akin to military trauma. Yes, to a certain degree, but the challenges faced may be of a lesser degree, maybe more amenable, maybe you can get help from around yourself, around the urban population, and the urban facilities available to you. Okay. Just in a nutshell, the management of trauma patient in a military setup differs from a civil setup in basically two contexts. One is the context of the injury, and the other is the logistical restrictions that we may have, the logistical narrow horizon that we have. Hence, because of these logistic issues and logistical constraints that we have, hence you hear the jargons of pre-hospital trauma life support, and the tactical combat casualty care, and the asset course, and so on and so forth. Now, even the ATLS has developed a subset for the operational environment that is called ATLS-OE. So we'll be touching upon that as well. As regards the context, I know the war on terror has somewhat foggied the distinction between civil and military trauma. However, in the civil setup, you are either faced with a predominantly blunt trauma or predominantly penetrating trauma. The situation is quite different in the military. It's mostly a polytrauma with a polymechanism. Multiple mechanisms acting at the same time. Most of us are faced with blast injuries. Now, I know in civil setup, in the war against terror, we are facing the similar kind of setups and blast injuries. However, the poundage, the quantum is less and perhaps more amenable, and perhaps you could have more facilities, more on-call people rushing to you. Just a word about blast injuries. You know, blast injuries always have multiple mechanisms, that is supersonic pressure waves, secondary flying fragments, tertiary impact with objects that leading to blunt trauma, and of course, complexity increases when we have burns and crusting and infections, and to top it all with the chemical or nuclear biological warfare scenarios. So yes, when we have these gruesome presentations, whether to stay and play or to scoop and run is a big question. So in the gruesome injuries with gruesome environment, it's a predicament. All right. Just a reflection that these figures are taken from the French authorities. In the military combat zone, they are faced with about 60% of blast injuries. Our figures are, although similar, but they are still showing 22% preliminary. These are very preliminary figures. These are showing only 22% of blast injuries, followed by penetrating injuries, which high velocity penetrating injuries, which might be having a blast in the background. They may be shrapnel, they may be grenades, but they have a shrapnel or high velocity penetrating injuries due to some kind of blast. Okay, so the challenges that we face in the operational environment is that the hostile environment is there, harsh climate is there, austere environment begins right at the battlefront. No matter which army we are talking about, which battlefield we are talking about, and a military environment per se is an austere environment. So this multidimensional polytrauma that I just discussed, we start with mass casualty realm at the very start. Right at the front line, we start with the mass casualty realm. And communication is jeopardized. Just imagine having no day in your workplace without a mobile phone, and you will come to know the predicament that we face. Transportation, very, very contingency based. Next facility is dubious. We don't know whether what we planned for last evening still exists or not, and whether there is a safe corridor to that or not. Own safety. Yes, our medic, our paramedic has to rise above the basic instinct of self-preservation and self-survival, has to rise above that basic instinct and has to focus on the survival of the casualty. Okay, so what do we do? What do? We adapt and overcome. We have our strategy is to mitigate the challenges, adapt and overcome the challenges. How do we do that? Well, right starting at the triage, as I said, we focus on who can make it out of the fire zone, who can make it to the safer zone. So our basic aim is mass casualty realm even at the front line. A rucksack having provisions for 2 cannot cater for 4. For that person, even 4 is a mass casualty realm. All right, so triage priorities for you, it is perhaps best possible care for the maximum possible. For us, it starts with maximum chances of survival. Who can make it? When anybody who can make it has to be, short assessment and life support triage, and off he goes. Well, you may be having some facility of online, ambulances. We are rather not sure whether we can, if we have the proper provisions for everybody, if we manage every casualties in the proper fashion, it would jeopardize the survival of those others waiting in line. So we are in the mass casualty realm. Our evacuation, maybe you are quite current with whom to and where to transfer. You have a trauma center, you have Jinnah. In Rawalpindi, Islamabad, we know PIMS. PIMS is the premier institute where trauma can be handled. For us, it can be very, very challenging that is there a corridor existing to the next available facility or not, or is the corridor of the next available facility still exists or not. So that is an ongoing challenge. Hence, the chain of evacuation is not just a chain of evacuation, it is a tactical issue. And you have to be in perseverance hence you hear these jargons of tactical combat care, care under fire, tactical field care, and tactical evacuation. And then we have point of field care from which we may be able to evacuate to an intermediate hospital after the de-optimization. Maybe suboptimally we have to evacuate, and then to the base hospital. The idea of all this chain is to reach the point of definitive care, be it in the field, be it in the intermediate vicinity, or in the base hospital. All right, so care under fire, we are now teaching our paramedics that under fire you cannot go to A, B, C, D, E properly. There's hardly anything you can do to the airway when you are under fire. So even the ATLS has now recognized this limitation and has given us the luxury of having an XABCD, where we have to control the torrential, the exsanguinating hemorrhage first, and then go anywhere else, maybe on the left little position with an oropharyngeal airway. All we do, we teach our medics or the buddy combats that whatever we do in the field has to just apply a hasty application of tourniquet and have the wound packed with combat gauze. That is all you can do in the field when you are under fire. While we are in the civil, we might be carrying out a detailed primary survey. Here we have only the facility of a XABCD and X main reason. So there is a concept of zero survey. Zero survey is an implied survey where you take stock of the things available to you and whatever you can do to the patient, and how can you optimize the patient and have him transferred. So while we are applying ABC and adjuncts in a civil setup, what we are doing here is taking stock of the situation. When can I evacuate him? Is he in the safer zone now? And we apply a deliberate application of tourniquet and start the evacuation process. Tactical field care to a point of field care or an advanced dressing station or a aid post where this is a casualty collection post. Our emphasis is after deliberate application of tourniquet, yes, you can place the casualty in a lateral position with an oropharyngeal airway. If your needle is available, you can decompress, and there is judicious resuscitation and pain control. This is all we can do once we are at the casualty collection point. Okay, so we have the mnemonics like MARCH, massive hemorrhage control, and massive hemorrhage control. Even the ATLS, after a lot of debate in the European war zones, it has come to give us the leverage of controlling the exsanguinating hemorrhage first. So highly debatable issues of transport. Sometimes we have a non-pressurized cabin. We cannot fly over 8,000 feet. So we have to improvise. We have to improvise certain things. All right. So during the tactical evacuation, yes, we can splint things. We can dress the wounds. We can have pain control. And our reliance on oral fluids, if the patient is conscious, we highly rely on oral fluids. It's not moving. Okay, so once we are at a place where there is some kind of serenity prevalent, we can have a frugal environment. We can have our primary survey done with simple maneuvers. Next, please. Okay, improvisations that we use is a side position with oropharyngeal airway. Surgical airway is preferred over definitive airway. Rolled blankets and boots for cervical spine. Person's own weapon as a splint. Hamlick, even this is luxury. We just do it with a syringe and a cut-off gloved finger. Once we reach a point of care, that may be a tented, that may be a dugout environment, it is here that we do the damage control. It is here that we do the damage control, and in a very austere environment where the supplies are limited, it is here that we do the damage control. Blood transfusion may be available, and tube thoracostomy may be available at this stage. Delayed secondary survey and definitive management is the preference at this time. All right. Sometimes we reach a point of field care where other than damage control surgery, resuscitative thoracotomy may be present. So this is kind of an environment where the frontier has been there for a long time, and we are well established and well dug out. So these are the facilities available there. Damage control concepts, you all know, it's a naval concept where the boat is damaged but not wrecked, and we plug the hole and we try to stay afloat and we try to reach the land. So it is restoring physiology more than anatomy at this stage. So we rely heavily on damage control. Next. All right. So as the hemorrhage is the #1 cause of death, it has been now proven beyond doubt that hemorrhage is #1 cause of death in the battlefield. The concept of using fresh whole blood or low titer O blood, fresh O blood, is now in vogue. And we have a concept of walking blood banks. That means the non-combatants around in the area, they have their known blood groups and they can be bled, or those who have been injured minorly. For example, they have been shot in the foot, they can be used as a walking blood bank or a buddy blood bank. All right, so these are some of the things that are All right. So the ATLS has, simplified us, has given us the some destination points, some checkpoints that we can have a zero survey, which is an implied survey that is for the paramedics in the field. Then we can have a primary survey with an X first. Then we can have a secondary survey, tertiary survey, and then a quaternary survey, because most of the time the patient has to be evacuated right after the damage control surgery. So quaternary survey is an ongoing survey. Whenever you want to transfer the patient, you have a suboptimal degree of optimization, and you may have to transfer in a suboptimal manner. For instance, just for when the patient has been seen in the field by a surgeon, any kind of trauma surgeon or a field surgeon, when he transfers the patient to a point of hospital or a tertiary care or a intermediate hospital, it is the onus of safe transfer lies on the surgeon. So my instructions to all of them are that if you have a 99 pulse and if you have a systolic blood pressure of 1995, use that window to transfer, not before that. Okay. Once we are in the base hospital or a tertiary care hospital, then there's a multidisciplinary approach. Sometimes we cannot reach the base hospital in one go, so there has to be an intermediate hospital. And the intermediate hospital, we have the facility of a general surgeon and a basic orthopedic who can apply an X-fixator by a general surgeon, and the basic ITC care. So, in a nutshell, yes, we are following a mass casualty realm right from the frontier to the base hospital. We follow mass casualty realm. We rely heavily on damage control surgery. We are talking about walking blood banks, blood earlier rather than later. And yes, we do look for a window on which even a suboptimal transfer is called for. We do look for that window, and a suboptimal transfer is sometimes encountered. Most of the time, it is suboptimal transfer once we are in the field. Thank you very much. Thank you.
Thank you so much, sir. Very nice talk and well informative. And our next speaker is Dr. Feroz Sidwa, and he is an acute critical and trauma surgeon and working as a general surgery residency program director at Saint Jacqueline Hospital. And I think he is available on the Zoom. So recorded speech is there. So I would please play.
I'm a trauma and critical care surgeon in Northern California in the United States. I worked in the Gaza Strip from March 25th to April 8th, providing trauma and other services at a European hospital in the southeastern edge of Khan Yunis. And we'll just go over two cases that I dealt with while I was there. But first, we just have to talk about what the Gaza Strip is. Even before October 7th, the Gaza Strip was a total humanitarian disaster. It had been under blockade, Israeli and U.S. blockade, for almost 17 years at that point. Had been under Israeli occupation for almost 60 years. Had been under Egyptian military occupation before that, so quite a devastated society. But since October 7th, it's gotten far, far worse. According to the International Rescue Committee, Gaza is the deadliest place in the world for both civilians and aid workers. Actually, just yesterday, the Palestinian Ministry of Health in Gaza released an updated list of medical workers, healthcare workers who've been killed in Gaza. The previously known number was 500. It's now more than 1,100 healthcare workers who've been killed. It's more than 1 out of every 20. 5% of Gaza's healthcare workforce has actually been killed in this war. The Gaza Strip is once again today the most dangerous place in the world to be a child. That's according to UNICEF, and you can see that they say once again. Basically, every major Israeli attack on Gaza, Operation Cast Lead in 2008 and 2009 and Operation Protective Edge in 2014, both of those made Gaza the deadliest place in the world to be a child. And now Gaza is the deadliest place in the world to be a child once again. The scale of killing of children in Gaza is not well appreciated in the even in the world press, certainly not in the American press. If you compare the rate of children being killed in Ukraine during the first year of the Russian invasion in 2022 to the first year of the genocide in Gaza, the rate of killing is actually 600 times higher in Gaza than it is in Ukraine. Just an absolutely outrageous differential. There's nothing like this anywhere else in the world. It's also the deadliest period for journalists since the Committee for the Protection of Journalists, an American group, began gathering data in 1992. Almost 160 journalists at this point have been killed, and the practice continues. Gaza has been physically destroyed worse than Aleppo in Syria, Mariupol in Ukraine, or even Dresden and Rotterdam during the carpet bombing of World War II by the US and Britain. The level of destruction was beyond anything I've ever seen, even in pictures. Gaza is the thirstiest place in the world by an enormous margin. If you are interested in the details, this Oxfam report that I've cited, it's called Water War Crimes, is really necessary reading. There is nowhere on Earth that is as deprived of water as the Gaza Strip is right now, and by maybe an order of magnitude. Gaza is also the hungriest place in the history of the modern world, and that's quite a shocking statement. So let me just point out, the worst food crisis on record in the modern period is Somalia in 2011. At that point, 490,000 people were found by the Integrated Food Security Phase Classification. That's the technical group that monitors these things. 490,000 people were found to be in the worst phase of food insecurity, what's called the catastrophe phase. The phase at which the rate of death from starvation-related causes is 2 per 10,000 people per day. In Gaza, that same number is 495,000, so 5,000 more. But you have to remember, Somalia is much, much larger than Gaza. There has never been a place where a quarter of the population was in the catastrophe phase of food insecurity, and it's having major effects. Gaza is also probably the most wounded place in the world. I can't find comparative statistics, but certainly Gaza has the largest pediatric amputee population in the world. Probably has the largest number of people with open wounds in the world right now. And on a percentage basis of the population, it's astronomical. There's nothing that would even come close. And Gaza has also suffered the most direct and sustained attack on a healthcare system that has ever taken place in the history of modern warfare. Again, comparing to Ukraine, which was until Gaza the worst place in the world for attacks on healthcare under the Russian invasion. The rate of attacks on healthcare in Gaza is 26 times higher than it is in Ukraine. So we'll talk about 2 cases, and these will illustrate the complex interrelation of all these different factors. The first case is a 9-year-old girl named Juri. She was injured in an explosion, probably an airstrike on her house, but it's always difficult to tell these things. Her injury was 2 weeks prior to me meeting her. At that time, her left femur had an external fixator placed across it, and the serious soft tissue injuries she had been closed primarily. This is Juri. You can see the temporal wasting on the right side of her head and also the puffiness of her face, indicating that she actually has kwashiorkor. You can see the non-healing wounds on her face from the explosion, and you can see the puffiness and skin denting of her hand on the left, again indicating fluid overload and protein calorie malnutrition. This is what she looked like when we found her. She was mentally altered. She had a heart rate of about 150. Her blood pressure was quite low. She actually just showed up in the preoperative area, and one of the nurses asked me and my colleague, Dr. Mark Perlmutter, to operate on her. We said, well, we don't know who she is, so we can't operate on her. And but when we took a look at her and examined her, it was clear she was dying of septic shock, and it was clear that she was badly wounded, so we knew we needed to look at her wounds. So we anesthetized her. Thankfully, that went well. And once we turned her on her side, we saw these really quite severe injuries that you can see here. This picture was taken after we cleaned all of the maggots off of the bed. They had infested all of these wounds, which actually is probably the only reason she didn't die of sepsis before we found her. You can see the totally necrotic flap on her left buttock. The right buttock is not much better, actually. And then you can see the necrosis of skin on the left lower extremity. Her left femur, I wish I had x-rays to show you, unfortunately I don't. Her left femur is missing 2 inches. Her sciatic nerve has been destroyed. A large part of her quadriceps and hamstrings are missing. I actually don't really understand how her legs stayed attached to her, how her SFA wasn't destroyed, or her superficial femoral artery wasn't destroyed, and just how physically the leg was not severed. But nevertheless, it wasn't. And like I said, the injury was 2 weeks prior to us meeting her. So we extensively debrided these wounds. And this is not right after the first operation. This is, I think, after her third or fourth bring back to the operating room. You can see that we have shortened her femur on the left. You can see the leg length discrepancy at the end of the picture on the top left, and also here. We extensively debrided her wounds. The buttock wound on the left was so deep that it went down to her inferior pubic ramus. Unclear if her nerves in the posterior part of her thigh were preserved or not. We gave her a colostomy for obvious reasons, and once she was actually able to recover from the necrotic burden of tissue, her mental status was able to improve. She was actually able to start eating again, and of course, Gaza's a land under forced starvation, so she really only had the occasional can of vegetables and the occasional pita bread to eat. But nevertheless, even that in this 9-year-old child was enough to start forming healthy granulation tissue, as you can see. Now, to definitively deal with these problems, of course, she needs free flap, at least to the left lower extremity, probably to the left buttock as well. Those may have to be latissimus free flaps. These would be completely impossible to do in the Gaza Strip. It'd be a fool's errand. Thankfully, Jure has been evacuated to Egypt. Unfortunately, Egypt also doesn't really have the capacity to do these things. What she really needs is to be evacuated either to the U.S. or the EU somewhere, or to Qatar, which is accepting Palestinian children and does have a hospital with these advanced modalities of care, where most of the European surgeons have been doing the care actually. The second case was a case of a 29-year-old man who suffered a gunshot wound and subsequent neglect and torture by the Israeli army. His initial injury was in late November of 2023 when Israel raided the Indonesian hospital in northern Gaza. When we found him, he was suffering from osteomyelitis with persistent sepsis and also persistent non-union of his right tibia, his ruptured right globe, and severe acute protein calorie malnutrition. So this is his name is Tamer. This is him. He was operating in Indonesian hospital. He was an orthopedic surgical nurse. He was operating at Indonesian hospital with the ortho team in November of 2023, 1 month after the beginning of the war. And an Israeli soldier came into the operating room and demanded that he leave. He said, "No, I'm finishing this operation. I can't just leave." And he was shot in the tibia. His own team picked him up from the floor, put an external fixator on him, and he was admitted to the hospital. And you can see in this picture, he's obviously shaken and traumatized, but this is not the kind of thing that most people can recover from. This is not the kind of thing that most people can't recover from. If he's given, if his leg heals appropriately, if his life can go on as normal, he'll certainly recover and improve and return to his normal life. However, after this picture was taken, the Israelis raided the hospital again. This time they took Tamer from his room. He doesn't know where, but most likely to the Sedateum and torture chamber that Israel's running in the Negev desert. He was strapped to a table for 45 days, so tightly that when he came to the hospital, when I met him, he had a bed sore on the back of his head. His leg was neglected. He was fed a juice box every day or every other day, and he was beaten so badly that his right eye was destroyed. This is what he looked like when he returned to Palestine and was brought to the to the European hospital where I found him. And again, I'm just going to flip back and forth from here to here in 1 month, 45 days actually. You can see his enucleated right eye. You can see that the external fixator has been removed because it was he had pin site infections all throughout it. And this is what he looked like when I met him. That's Dr. Mark Perlmutter on the left with the betadine in his hand, cleaning his pen site. When we met him, he was again altered, septic, hypotensive, tachycardic, and the only source for this that we could find were the infected osteomyelitic pin sites of his right lower extremity. So we debrided those aggressively and extensively. We could not find operating room time because there's 200 or 300 people just like him in the hospital. So we would do this under ketamine in the PACU. Nevertheless, it was successful. We were able to give him some of the antibiotics that we brought with us. The hospital didn't really have what he needed, and his sepsis did in fact improve. with the debridement, the antibiotics, and the continued care. And this is what he looked like on the day that we left. You can see the severe protein calorie malnutrition. You can see his enucleated right eye. His right leg will take months to heal if it ever does. And just to illustrate how dramatically he has changed in the past 2 months because of what was done to him. The man in this picture is actually only 29 years old. He looks like he's 70. So what do these cases illustrate? Well, the healthcare system in Gaza is massively overwhelmed, both by enormous needs for sure, but it's also being undermined by direct attacks on healthcare workers and facilities. The number of Palestinian physicians alone who have been killed was just reported by the Ministry of Health as being 162, if I remember the number exactly correctly. That is probably more physicians than have even volunteered from abroad in Gaza since October 7th. So the assault on the healthcare system is absolutely devastating. Malnutrition, destruction of the water and sanitation and hygiene infrastructure, and overcrowding are making surgical success nearly impossible. Every wound that we made in Gaza that we closed got infected, so we really just stopped closing wounds. But with malnutrition, the wounds aren't healing anyway. Now, again, a 9-year-old child like Juri is extremely physically robust and able to, but someone like Tamer, even at only 29 years old, with what he has suffered and the degree to which he's been neglected and abused and tortured, it's going to be very difficult for him to actually heal as he needs to heal, especially if the social and societal circumstances are not improved. And finally, it was possible to provide advanced care in a resource-poor setting at the level of individuals. But you have to remember, well over 100,000 people are severely injured in Gaza. Like I said, it's the most injured population in the world. And again, the healthcare system has been so severely degraded that it's virtually impossible to provide the care that's needed, even to the people that are already in hospitals. Just to illustrate this, I organized a wound care team when I arrived at European Hospital. We rounded and I found about 200 people in the hospital who needed daily operative wound care. There's only 4 operating rooms at Gaza European Hospital. How is this going to work? Actually, I started just doing debridements on the floor with ketamine, like I showed. But that's obviously entirely suboptimal, completely ridiculous. And we did what we had to do, I suppose, but nevertheless, it should not be tolerated.
Thank you, Dr. Feroz, for a nice talk and share the views on the difficult situation at Gaza, and they are still providing the healthcare facilities there. So we are going to invite the panel discussion members. First of all, I will invite the Dr. Azhar Sheikh, the head of emergency department, SMBB Trauma. Sir, please welcome the stage and join the panel. And already Professor Dr. Sohail Ilyas has joined the panel at the stage, and now I invite the Professor Mohammad Farooq Afzal, and he's a professor and head of surgery department, PGMI Lahore General Hospital. And yes. So panel discussion is basically done in the limited resources situation. We have the discussion, the case, and that is seen in the periphery in the Tolka hospital, and we have difficult situation to manage the patient at that site when there is deficiencies of the healthcare system and equipment. So next. So we have a patient who is 25-year-old involved in the RTA, road traffic accident, coming to the emergency department, seen by the doctor available in the emergency. The initial assessment, the patient had no C-spine stabilization, and he has decreased the level of consciousness. So vitals at that time, the BP 110/65, pulse 90, and saturation is 98%. Sir, in this situation when there is a non-availability of cervical collar, so how will any doctor or periphery health management system can stabilize the cervical trauma? Dr. Azhar, please.
Hello. Right. Thank you very much for inviting in this panel discussion. The topic is really applicable to Pakistan because not all the hospitals in the emergency department would have the facilities. But having said that, there are simple maneuvers which can save the life, and I think this is what we are reflecting here as a panel discussion. So I will go back to the scenario that he's a young patient involved in road traffic accident. He's been brought in by ambulance or whoever, and he is in emergency department. His C-spine is not being stabilized. That's the main issue, because when we look, his vital signs looks okay to me for now, and his conscious level is decreased. So that would be worrying as well for this patient, because maybe he's got head injury, which may have caused the low conscious level. But the approach should be as per ATLS protocols or any standard trauma protocols, that you should secure the airway while you stabilizing the C-spine. So I would take it as that airway at the moment, okay, we need to comment on the cervical spine. So if we have a collar, cervical collar, then fair enough, we can apply the cervical collar. But in low resource hospitals or the facilities where the cervical collar, Philadelphia collar, different names it comes with, if it's not available, then simply a trained doctor or a trained nurse can hold the neck to do the inline immobilization. And that's how you can secure simply. And there are no rocket science to do that. You just need to train, and it will take maybe 10-15 minutes of training for any doctor or for any staff to teach them how to stabilize the inline immobilization of the cervical spine. Put them on the couch or the trolley or the whatever the bed is available. Make sure that they are straight, flat on their back, and then stabilize the cervical spine. So that would be my approach.
Okay, thank you. Now, yes.
We are quite used to improvising things, and so 2 IV fluid bags on the side of the shoulders, and you tape the head along with the 2 bags. That can be an improvisation to stabilize the collar. Otherwise, if you are on a spine board, you can even fix the head, tape the head to the spine board, and put some rose gauze or cotton bundles on the side, and you tape them along with the spine board. That would fix or stabilize the spine to a great extent. Thank you.
So, thank you, sir. Now proceed further this case. We have just approached for the C-spine stability. Now proceed with the same case. Now we stabilize the C-spine, and patient started snoring, saturation started to drop, manage airway without advanced equipment. So Dr. Azhar, please tell me about.
Okay, Dr. Farooq. All right, so first of all, you need to remember the primary principles of primary survey, A, B, C, D, E, right? So this patient, if this patient fails the 10-second assessment test, right? And what is the 10-second? Because there are a lot of students sitting behind. What is the 10-second assessment? And that is that you ask the patient, what is your name, right? Where are you? What happened? If he can answer these, this means his A, B, C, D, E is absolutely fine. If he fails this test, right? So not everybody needs everything which you mentioned. So if he fails this test, now onus responsibility is on the patient to first look after the physician or the surgeon who's taking care, to look after, first of all, the A. All right, so before C, I think this patient needs to look after the A. And since A is connected with C, what we use nowadays is a CSI, means cervical spine immobilization. The term is to just restrict the movement while you're trying to put the airway, as well as you are not sure this patient might have a cervical spine injury, so protection is more important than detection. Now, in this patient, there are very simple maneuvers just to make sure that the tongue does not fall back, right? So we'll start with either a simple chin lift, making sure that there are no movements, or just a jaw thrust. So usually a slight chin lift would be helpful in this patient in just bringing the tongue out. And if he can tolerate, and this depends on his conscious level obviously, if he can tolerate a nasopharyngeal or oropharyngeal airway, that would be the next step in such patients.
Okay. So we have maintaining the airway. Now we reassessing the patient for A, B, C, D. Now we have found that patient is proceeding with getting blood pressure is low and pulse rate is slightly raised to 110, and on examination we have found the bruises on the left side of abdomen, and we have also noticed he has bleeding from the wound on the thigh with a deformity. So Professor Dr. Sohail Ilyas, please give the expert opinion regarding the management of the bleeding stoppage.
We go on to C and we make a purposeful halt on C because that is very critical in this patient. So he's bleeding. We just noticed that he's bleeding from his wound on the thigh with a deformity. So most likely is when there's a deformity of the thigh, most likely the femur has fractured. So as you all know, application of a Thomas splint is part of the primary survey, is part of the C component of the primary survey. So we must stabilize this limb. If there is more than an ooze, if there is a spurt, you ask your assistant to put pressure, you ask your assistant to put roll gauze, and you proceed with, if you have already secured the 2 IV lines in the periphery, you proceed with applying a Thomas splint. Now it has multiple advantages. Number one, it can stabilize a sharp fragment so that it doesn't cause more injury and more bleeding. It can unkink, or it can sort out the kinking of a major vessel, and it can release, without disturbing the tamponade effect of already formed hematoma, it can reduce the deformity, and it's part of the C that you secure the bleeding process in the thigh.
I just want to add something. As sir said, apply the Thomas splint, but we are here in a low resource setting.
Situation.
So Thomas splint probably not available in all emergency departments. So in that case, I would ask you, sir, that what would be the approach if the Thomas splint is not available?
So there can be improvisation, right? So if you have a cardboard, you can make a sheet out of it, a longitudinal sheet, and you can straighten out inline, in anatomical inline immobilization, straight out, and you apply as a back slab, you apply a cardboard. If you don't have a cardboard, if you have a Kramer wire splint, you can straighten it out, the Kramer wire splint. You can use 2 Kramer wire splints to support the leg, and you apply the bandaging in and around the knee, and you fix the ankle with the board on the Kramer wire splint or the board. So there can be improvisations. As I said, in the field, we often use the soldier's own weapon to be used as a splint.
Sir,
just want to add here. In ATLS, we use this F4 with a blood on the floor and 4 places more, right? So you see external hemorrhage, you try to stop the hemorrhage, to apply skin traction. In this situation, you don't have a Thomas splint. But whenever you apply a neck collar or something for neck immobilization, you always remember the pelvis. So you simultaneously do immobilization of the pelvis with a splint as well. Right? These are 2 important. Remember, this patient should have been transferred on a long spine board. This patient still is not on a long spine board. So you have to also look after that his spine is also being protected. Not only the cervical spine, but rest of the spine, because you still have to detect that.
And sir, we have noticed bruises on the left hypochondrium. We have no any ultrasound facilities at that periphery. So how would we tackle this situation of the abdominal trauma and surgical point of view in limited resources situation? Yeah, left hypochondrium.
Sound is very important. Blood in the peritoneum irritates and the blood, as a reactionary measure, the gut goes into ileus. The gut stops moving. So if there are no gut sounds and if there are signs of peritoneal irritation, yes, you are likely to be having blood in the abdomen. So it better rush the patient, secure the IV lines, start resuscitating, get blood if possible, and rush the patient to the nearest surgical facility.
Okay, can I add that? Now, I just said that the blood on the floor in 4 places more. So the patient can have bleeding inside the abdomen, he can have bleeding in the chest, he can't bleed from this, or he can bleed from the retroperitoneum or pelvis, right? In this situation, you don't have the ultrasound available, and the patient's hypotensive, right?
Yes.
Diagnostic peritoneal lavage is still the standard of care, though we omit it because most of the centers now have ultrasound. But if you do not have the ultrasound and a fast scan or e-fast scan available, I think you still can use diagnostic peritoneal lavage. And this is doable by any emergency physician.
Okay. Sir, now
can I add something, Dr.
Yeah.
Kailash? I think there was something more in your scenario that the patient had a bleed from the limb. So I just want to talk about a little bit more that in emergency department with the low resource, how can we stop the bleeding if the bleeding does not stop by applying the pressure only, as sir said? That what are the other options? Because I've got 2 seniors here, I would like them to give some more input.
Eliasa would comment on this amputated limb, right? In our civilian setup, you got an amputated limb, we just apply the tourniquets, right? Tourniquets are very, very effective for the amputated limbs. For the non-amputated limbs, bleeding is not a problem. You just apply pressure and you just apply bandages. I think that is, even for the junctional packing and pressures are the 2 things. We hardly need to use these tourniquets. Yes, but for the amputated limbs, they're bleeding. Tourniquets, either the upper limb or the lower limb, they are very effective.
Okay.
Tourniquets are very much back in fashion, and yes, we do apply it in the field. As I mentioned, it's the first line of management in the field is application of tourniquet for a torrential or a exsanguinating hemorrhage. However, as Professor Farooq Afzal has said, there's no bleed other than the aorta, which cannot be stopped by applying direct pressure. But it has to be an intelligent application. It has to be on the point. You go on PAK, you go on having layers of gauze, and then you apply a bandage so that it only pressurizes the point of bleed. Other than that, yes, in the West we have now junctional tourniquet, and torso tourniquet is coming up, which they say junctional tourniquet is less than 300 mm of mercury pressure at the junctions, at the groin and the axilla. They are very effective. And in the torso, they have a torso plate on which you can apply direct pressure through your knee, or you can apply direct pressure through an inflatable device. And they say that 30% more survival they have figured it out in the battlefield, that if you apply a torso tourniquet, there's 30% more survival.
Sir,
just I want to add a little bit more, because it's a very interesting case. Sir already mentioned that do the resuscitation. If you have a blood, then give blood. If you don't have blood, then give crystalloids. Yesterday we discussed about that how much resuscitation is required, but this is very, very common in our day-to-day practice, that in emergency department, low resource emergency department, if you don't have enough supply of blood, then you give crystalloids. Then is there any time window you have in your mind as a surgeon or a trauma surgeon that the patient should wait? Because resuscitation is a very broader term, and I think it's been used and abused in different ways by surgeons, emergency department, and all the others. But is there any timeline which would you say, because the patient is unstable, don't you think we should just take him into the theater and secure whatever is happening inside?
Yeah, it depends upon where is the bleeding. So first of all, when the patient comes to do, the first question is this patient in shock? And if this shock is because of hypovolemia caused by hemorrhage, right? And most likely it is the hemorrhage which is causing the hypovolemic shock, right? Then the next question is where is the C bleeding from, right? Obvious bleeding externally is easily recognizable, but bleeding into the abdomen, the retroperitoneum, the pelvis, they are not easily recognizable. Chest, I mean, you have the facility of chest. Every patient, as a part of the primary survey, should have an X-ray chest and an X-ray pelvis right on the table, right? And I think many of these emergency services, they have this facility. So unstable patients are the one which you have to be very, very careful. If your X-ray room is away, if it is not there on the resuscitation table, or if the machine cannot be brought, that you have to be very, very careful, that you have to have an IV access available, fluids going on, before you transfer such patients, because location of where is he bleeding from, you take him directly to theater without knowing where is he bleeding from is a disaster, right? So you have to know. And these X-rays take a very little time. With the advent of these ultrasounds, EFAST, we have a huge facility. But unfortunately, maybe we are talking of any circumstance where such things are not available, then this facility already has exceeded, this patient has exceeded the requirement of the facility. This patient should be transported to the nearest possible facility where such things are available.
Okay, Dr. Abid Jalaluddin Sheikh Saab, please give the remarks regarding the transportation of such type of patient from periphery to tertiary care trauma hospitals, and how will you manage in this situation?
Thank you so much. First of all, thank you so much for having me in this very important session. Actually, before going on a pre-hospital care, I just wanted to ask a question from the seniors, because already we have, and it's a very typical case that has been discussed over here. So you have mentioned the patient is already shifted to the emergency care in the Dalka hospital, but we have not discussed that how it was shifted and how the pre-hospital care was provided. So for example, if it's in a scenario and we have seen the patient is properly shifted and the airway of the patient is properly managed and proper fluids have been given and the patient has been shifted to this proper spine board. But for example, because we have also talked about the challenges as well, because it's a very low resource emergency department at that facility. And if this case may not be properly handled, so what are the protocols to shift that patient to the distant area of the hospital? Because in the current scenario, in the current real scenario, if because most of the cases are shifted to the metropolitan city and the distance is more than 5 hours, 6 hours, or 7 hours, and we don't have the proper, the condition of the roads. No doubt we have the proper ambulances with the complete equipment available. But what are the protocols if the patient is not properly handled in that low resource emergency department? So can you please let us know about that protocols, and is it good, and how you see the risk level when we are shifting this critical patient to the distant area of hospital?
So that, please. Right. So remember, this is very, very important for you to understand where are you and what are your resources. And ATLS teaches transfer to a facility where definitive care can be provided as the basic step of primary survey. It is not where you have to identify in the secondary survey. You have to identify the need for a transfer to a definitive facility where definitive care can be given right in the primary survey. So if a patient comes to you and you are a trained person, maybe ATLS or any early trauma management course, you assess the airway, you provide protection to the airway, you try to secure the airway, you look for the breathing, you try to support that breathing, you look for the bleeding, and at the same time get access, and then see what is the GCS of this patient and pupils and stuff. And then fully expose the patient, keeping the temperature in mind for both log roll back, so that you don't miss the injury at the back, because front is 50% and 50% in the back of the patient. So once you have done that, now you have a real quick assessment of this patient, whether this patient falls into my purview or not. If this patient does not fall into purview, he should be transferred with whatever stability you can provide. I think every station can provide some sort of facility by just providing cervical collar, maybe an airway, right? Or if you have skill of endotracheal, if there's not skill of endotracheal tube available in some place, this should be closed. This facility should be closed, because IV access and endotracheal tubes are the two facilities, two skills which are very basic for a medical doctor. But in any case, even if you basically put an airway and an IV access, provided this patient responds to fluid, this patient should be transported as early as possible, right? External hemorrhages can be stopped. This is about the internal hemorrhage. Abdomen is such a cavity where, because of the expanding blood pressure, the intracompartmental pressure rises, and most of it will provide a tamponade, right, for you to transport that. Obviously, there are situations where this tamponade is broken up, but mostly you can transport these patients to a nearby facility. 5-6 hours transfer, I cannot imagine, at least in my setup, that the patient would need a 5-6 hours. If there's a 5-6 hours of, then I think I don't have any answer to this.
So, yeah.
A good physician is that who knows his limitation. An intelligent person is that who knows his limitations. So if he's entangled at C of the primary survey, he may decide even at the C without, let alone secondary survey, he may decide at C that this patient needs transfer, he's beyond me, beyond the capacity of this facility, so earlier transfer. 5-6 hours, sir, you're right, is a long journey, but any place where he can be opened up and at least damage control can be offered.
Yes, sir. Yes.
Dr. Farooq, you said there is no any solution which you find, then how we will design a solution or find out?
This is governmental level. I think providing facility, at least I'm from Punjab, so I know that. There is no facility which is maybe less than half an hour to 1 hour. That's the maximum time, right? But 5-6 hours, maybe the government can provide you some helicopter or something where this distance can be reduced. But not to my knowledge that 5-6 hours unstable patient can be transported 5-6 hours.
Yes.
It
cannot happen.
But so one thing which is in my mind that we always on one page that the ATLS is the type of the workshop where that lessens the degree of mortality. So it should be recommended that every doctor should take this ATLS course before he is taking the degree after the final year MBBS. It should be mandatory. When we are talking about a small town in the primary care, every doctor, because why they shifted to the bigger hospitals and why they shifted to the tertiary care, because they always afraid of not putting their hands in such type of the patients, because they fear doctors, because they are not trained. And second thing is, only the thing is that when they work on the ATLS, they can initially handle these patients at the primary level. So it should be, the solution is that every doctor should have a mandatory workshop on the ATLS. And until unless he is not having this ATLS course, he should not be awarded with the PMDC degree.
Yes.
Does not
Thank you.
Yes.
Yes.
No, that has to be very clear point, because there are a lot of students here. ATLS does not teaches you definitive care. So you have to be a surgeon, right, to control the bleeding into the abdomen, right? ATLS teaches you the basic life-saving maneuvers which are essential initially. But if somebody is bleeding from inside the abdomen, right, it is a general surgeon job. Right? If he's not a general surgeon, it's not advise him that, because this 2-3 hour days course would not teach you definite surgery. You need a lot of training, 4 years training before you become a surgeon.
I just want to add something. Okay. It's very good approach, as you mentioned, to have a ATLS for all, but that's a bit of luxury in Pakistan. ATLS is very expensive. Secondly, if you apply today, you will have to wait for 10 months to 12 months to get into it. So ATLS is a good, standardized, worldwide recognized, but don't we think we should have another basic trauma life support course, which is Pakistani version, which goes side by side, so we can educate more junior doctors as you looking for.
Okay, thank you so much. Thank you so much, panelists, Dr. Jalaluddin, Professors Sohail Ilyas, Dr. Azhar, and Dr. Farooq. Thank you so much. Nice talk and well information. And coming to the next section. Thank you.
Assalamu alaikum. Ladies and gentlemen, honored guests and esteemed colleagues, on behalf of Department of Neurosurgery, SMBB Institute of Trauma, Dow University of Health Sciences, Civil Hospital Karachi, and organizing team of 2nd PAK Traumacon, I, Dr. Muhammad Adil Khatri, welcome you to the session dedicated to neurospinal trauma. Since traumatic brain injury remains the leading cause of in-hospital mortality in trauma patients, preventive measures for head injury and management of injury to the neurological system is a vital component in any trauma patient. As we explore the complexities of trauma, we recognize the critical role neurosurgeons play in managing head and spine trauma and associated neurological complications. Since the establishment of Trauma Center in 2016, we have seen a rise in the number of neurosurgical emergencies being referred to our setup. While our specialty remains to be known for its grim outcomes, there have been countless happy stories which give us the strength to continue giving our best. Whatever you're seeing in the background is just a glimpse of the fruitful outcomes of our collective efforts with different specialties, including emergency department, ICU team, physiotherapy and rehab, and helpful administration. Our commitment to innovation, collaboration, and excellence in patient care drives us to share insights, research, and breakthroughs with you. We look forward to inspiring presentations and the opportunity to strengthen our collective efforts in improving outcomes for trauma patients. We are especially thankful to our guest faculty who took their time out to attend this session and make this conference a transformative experience for PAK Traumacon. Now I invite the chairs for this session. Is Dr. Rashid Juma here? I think he is on the way. Next, I would like to invite Dr. Gohar Javed, who is Associate Professor of Neurosurgery at Aga Khan University Hospital, to come on the stage, please. I would invite Dr. Amir Sagir, who is also an Associate Professor of Neurosurgery at Liaquat National Hospital, to join us on the stage. Now, for our first talk, I would like to invite Dr. Naveed Ashraf, who is Professor of Neurosurgery at National Medical Hospital, Lahore, for his presentation on multimodal neuromonitoring, current standard of care in traumatic brain injury. Thank you.
Bismillah ar-Rahman ar-Rahim, and thank you very much. First of all, I would express my gratitude to the organizers of the PAK Trauma Conference, and especially professors who have invited me to this talk, Professor Atiq and Professor Imran. I'll be talking about a very important aspect of the current top of the tier management for patients of severe traumatic brain injury. We are going to keep it as simple as possible so that the core concepts are absorbed by the residents and the non-neurosurgery audience. I'll be talking about two very important principles related to brain functioning. One of them is related to the physics and other to the chemistry. And as I was sitting over here, I was told that this is just a 10-minute talk, so I was brainstorming how to reduce it within 10 minutes, so you might find certain gaps because I have to slip on so many things. So people like Alexander Monroe had the vision to let us know more than a century and a half ago that any increase in the constituents of the intracranial volume must be compensated by a reciprocal decrease in the other. And the famous Monroe-Kelly doctrine states that the intracranial volume is in a state of equilibrium because of its contents, blood, brain, and CSF. And any increase in one of them needs to be compensated by a reciprocal decrease in the other, the limits of which, once achieved, can only be further compensated by opening the rigid skull case. We all know that once the primary injury has occurred, the aim is to prevent the secondary injury. And the raised intracranial pressure and the secondary insults produce ischemia, and this leads to the destructive, inflammatory, and biochemical cascade. The worst aspect is that this is self-perpetuating. So we focus on the principles of physics related to the intracranial pressure. What happens when the intracranial pressure is raised? The complex interplay of various events leads to an overall increase of the intracranial volume, which would then result in intracranial hypertension, and this produces not only brain herniations and a decrease in the cerebral perfusion pressure, but it also results in neurological injuries as a result of the medical injury or ischemia. The worst part is that it leads to a vicious circle which is self-perpetuating and comes back to us again and again. As you can see clearly from this slide, that there are 3 stages of the volume compliance curve. Stage 1 is the stage of equilibrium, whereas the stage 2 is the stage of compensation, and stage 3 is when this is the uncompensated stage, when the volume rises and the intracranial pressure rises exponentially and the compliance starts to decrease. But what we really want to, the problem is that how do we present these stages which we are talking in terms of physics, to the treating clinician? And what we have done is that we change them, these graphs, into numbers and graphs by monitoring the intracranial pressure, and this is how the normal and the abnormal pressure waves look like. The normal pressure wave has 3 components, P1, P2, and P3, whereas the relationship of these waves changes when the cranium becomes non-compliant and the pressure is high, as the P2 then becomes the tallest and the highest wave, which is normally lower than the P1. Now, just a quick few words about how to manage intracranial hypertension. We divide this into 3 compartments: the CSF, blood, and brain. The CSF is managed with the help of drugs and by egressing the CSF out of the compartment by external ventricular drainage or internal drainages, the blood by hyperventilation, elevation of the head or barbiturates, and the brain is managed by certain protocols. And if this all doesn't prevent and the intracranial pressure remains refractory to this treatment, then we perform surgical evacuations of the mass lesion or we perform surgical decompressions. Now, as I earlier said, that we were talking about 2 things. This is the physics related to the intracranial pressure, and the chemistry is related to the neuromonitoring. And today we have reached a stage where we can detect early biochemical changes prelusive to secondary brain injury, and we can intervene based on this information to prevent further damages. Now, cerebral microdialysis is the latest addition to this horizon to quench our thirst for the information to strategize our management. And the brain energy generation, we all know, depends on the brain glucose, which gets deranged once there is lack of oxygen or the tissue is deprived of oxygen, because the cellular respiration in the aerobic form then gets converted into the anaerobic form, which produces certain degrees of metabolites which are detrimental for the brain health. And cerebral microdialysis is all about detecting these metabolic changes earlier on, before the onset of the secondary brain injury. The normal values for various metabolites you can see on the slide. We commonly measure glucose, lactate, pyruvate, glycerol, and glutamate. And the lactate-pyruvate ratio tells us about the onset, if it is normal, and if it increases to 25. 20 is the normal, and if it increases to 25, this means that there is metabolic crisis occurring, and we need to deal with this metabolic crisis. So the clinical applications of cerebral microdialysis is in acute brain injuries, in hypoglycemia of the brain. We can apply it to the non-metabolic treatments and drug therapies. And this sort of multimodal neuromonitoring snapshot shows you that how by putting in a couple of catheters, we can monitor the physics and chemistry of the brain and turn the life-threatening situation into a life-saving situation. This is a very complex sort of a brain-rattling information I had been pouring in because of I had to cut down my presentation. And this video probably might simplify things and help you in understanding what we really want to do with monitoring. We monitor with the help of a parenchymal catheter. Sorry. Can we just start the video, please? Because I'm unable to control from here. Yes, this is a patient who has a CT scan shows right temporal and bifrontal contusions, which has aggravated on the next CT scan. So we plan to monitor this patient with the help of intracranial pressure. And we put in an intracranial pressure catheter into this patient. These are the superficial sensors showing us the oxygenation of individual hemispheres of the brain. We put the catheter into the frontal region, normally anterior to the motor area, unless otherwise indicated. So these are the various accoutrements of the drilling. And this is the catheter which houses the transducer in the metallic casing. A close-up shows this transducer. This is what we put into the brain in the frontal region normally, unless indicated otherwise. Now, this is a catheter which is connected to the intracranial pressure monitor, the lead of the intracranial pressure monitor. And we just give a small nick, separate the pericranium, and then start drilling it. This is the burr guard, which prevents the burr penetrating a certain distance. Now the bolt screw is uncapped and then fixed in the screwing in tool. It is snugly fit by pulling back the ring. And then we fix it into the skull. The self-cutting threads engage the screw into the drill, into the pilot hole that has already been drilled. And now the catheter will be passed after the screw has been capped. Can you fast forward it? The catheter is put into the desired place along the trajectory, and you can see that there are centimeter markings on the catheter. And you see that the pressure is abnormally high. It is pathological. It is 33 millimeters of mercury. And now we institute the, you can see those waves which are abnormal. And these abnormal waves represent the pathological situation, which is the stage 3 of the intracranial pressure. We now institute the therapy after we have fixed the catheter to the scalp. It is slightly looped so that it provides a strain gauge for protection against an inadvertent pulling, and then fix it to the scalp with the help of a butterfly. And then we manage the CSF and the blood and the brain compartment. We rush the mannitol, we elevate the head just to find out the effect on the intracranial pressure. And you see that it started to drop. It's 29, 28, but it's still pathological. We are not very much satisfied. The compliance has started to become normal. The saturations are okay, but the pressure is pathological. It's hovering around 25 millimeters of mercury. We want to bring it down below 20. The waves, they remain the same. They are still pathological. So what to do? As I had already said, that when we exhaust our medical means, then we move on to the decompressions. And in this case, we decide that we need to do a surgical decompression by doing a decompressive craniotomy. You need to secure your catheter and maneuver your incision in such a fashion that it remains secured. So we do a bifrontal decompression craniectomy and a right temporal craniectomy for this very patient. And you will see that after we have done the durotomy, once the durotomy is performed and the brain pouts out, the pressure would then plummet down. As is seen on the screen, you can see that it's 10.6, and now we are very happy it's a normal pressure. And this is how we have turned a life-threatening situation into a life-saving situation. And thank you very much for bearing with me.
Thank you, sir. We will be taking questions after the session, if time allows us. Dr. Naveed, would you kindly join us on the stage as a chair? Now I would like to invite Dr. Riaz Ahmed Raja, who is Professor of Neurosurgery at Liaquat University of Medical and Health Sciences, for updates on traumatic brain injury.
Bismillahirrahmanirrahim. Thank you so much, organizing team, especially my friend Dr. Atiq and Dr. Imran, and see the many colleagues and friends here. So today the topic of my presentation is updates on traumatic brain injury, which is a little bit correlated with the Dr. Naveed Ashraf. He is also our senior and a wonderful personality, and he is taught presented much more about this topic of updates on the neurosurgery. So we all are the researchers, and what we see in the department, we research it, find out the problems in the head injury. For example, few years back, when we saw a thing that if the patient is fully conscious and he comes to you with a mild head injury, and we get a first CT scan, and there was no any protocol to send the patient for the second CT scan after 12 hours or the 24 hours. Then we saw after the 1 day or 2 days, the patient deteriorated. And when we got the CT scan, we found the either very small contusion or small injury abruptly blown up. And that was the problem of the deterioration of the patient and sometimes the mortality. So we have made the protocol of having a second CT scan. So nowadays, we have the protocol of a second CT scan in every patient of the mild head injury, and we got a true picture of the head injury. How it works? So this is my institute, Liaquat University of Medical Health Sciences, Jamshoro. So traumatic brain injury is a significant healthcare burden and reported in the 190 deaths per day in United States, disabling far more, and there are billions of the dollars expenditure per year. They are divided into the primary and secondary. I think most of you people will be related to the neurosurgeons or sometimes the other, maybe other field. So everybody knows about that. There are two types of the injury, the primary and secondary. The primary is the direct injury at the time of the incident, and secondary injury always involves after the few hours to few days. The goal is to predict the harmful physiological events before irreversible damage. So first, as a neurosurgeon,
we believe that if there is a mass effect of the trauma, we have to remove it to decrease the ICP and get the patient benefited of the raised ICP. But if the patient is having a diffuse axonal injury on the mild trauma, then there are a lot of the procedures, as Dr. Naveed has described, the ICP monitoring and the microvascular dialysis and the other things, which shows that if the patient is in the ICU care and he needs any ICP, the management is totally different in that very case. So when I was talking about the thinking, the researchers, then when we work in the department, how we think. So this was the first CT scan of a patient which was having the very small contusion on the left-sided temporoparietal region, but and this was the PICS. I exactly don't know how much the time left, and after that the second CT scan was carried out, but this is my department's case, so I took those pictures, and you can see the first CT scan and the second CT scan shows the abrupt blown up of that contusion, and there is a significant midline shift. So this is the standardized case of doing the surgery, but the patient is at the GCS of the 3 or 4. So sometimes you keep this patient with the other problems like the polytrauma, and the chest is very much disturbed. So in that very cases, you keep the patient in ICU, and now there is the role of the other methods of monitoring the ICP so that you can control it, and if the patient has the life expectancy, then you can proceed for the surgery. Otherwise, there is a very gloomy situation here to do the surgery. So current medical therapies are improve the hemodynamics by altering the blood pressure and intracranial volume to optimize the cerebral perfusion pressure and the intracranial pressure. The brain oxygenation is important. Hypoxia is known to be independently associated with the mortality in patients with the TBI. Hypoxia is common in patients with a severe traumatic brain injury and is independent of the ICP elevation. Researchers propose that direct measurement of the partial pressure of the oxygen in the brain as a means to improve via intracranial probes. Whether this pressure measurement is a better predictor of the TBI is still not determined. Ideal location of the probes is either in the injured brain, adjacent to the injured brain, or remote from the injury or the injured side is still currently unknown. The American College of Surgeons Trauma recommend that assessment of the cerebral autoregulation is important, which is the cerebrovascular pressure reactivity index, cerebral blood flow evolution, and transcranial Doppler monitoring. They all determine autoregulation. In patients with the poor cerebral autoregulation, advanced techniques such as evolution of the brain tissue oxygen and jugular venous oxygen saturation may be utilized. Intracranial pressure monitoring. Measurement of the ICP is essential to determine the CPP. Normal ICP in supine position is 5 to 15 millimeter of mercury in adults. The invasive methods measures the global ICP with additional advantages of the periodic external calibration, therapeutic cerebrospinal fluid drainage, and installation of the drugs or antibiotics. Management of the raised ICP is an integral part of the neurointensive practice care practice. The development of the gauges and an external transducer revolutionized the ICP monitoring techniques. The intraventricular technique remains the gold standard of the ICP measurement. Placement of catheter may be difficult in cases of the severe brain injury and swelling, and also runs the risk of the infection. Currently, catheter tip transducers are widely used. Non-invasive methods of measuring the ICP such as the transcranial Doppler, ultrasonography, tympanic membrane displacement, optic nerve sheath diameter, and transcranial color Doppler duplex sonography are present. Non-invasive techniques lack the accuracy of their invasive counterparts, thus they cannot be used as an alternative to invasive techniques. Cerebral oxygen monitoring depends on the jugular venous oximetry. Cannulation of the jugular bulb also allows the assessment of the global oxygenation status of the brain and adequacy of the cerebral blood flow. Normal jugular venous oxygen ranges in between 55 to 75%. The ischemic threshold has been reported to be a pressure of less than 50% for at least 10 minutes. Low oxygen, jugular venous oxygen indicates either an increase in the oxygen demand or reduction in the oxygen delivery, like the vasospasm or hypotension. Brain Trauma Foundation guidelines recommend maintenance of the jugular venous oxygen pressure greater than 50%. Brain tissue oxygen monitoring is useful in various clinical situations where there is a risk of the cerebral ischemia. Currently, only the Lecoq system is available commercially to monitor the partial pressure of oxygen in the brain. A value of less than 10 millimeter of mercury should be corrected within the 30 minutes to prevent the poor outcome. In patients with the TBI, the partial pressure of the oxygen in the brain has been shown to be a good indicator of the treatment effects and correlates well with the clinical outcome measures. ICP and CPP and partial pressure of oxygen in the brain based therapy is associated with the better outcome after the severe TBI than ICP and CPP based therapy alone. The change in the trend of the partial pressure of the oxygen in the brain values is helpful in detecting the secondary insult and guiding the specific therapy. Disadvantages of this monitor gives a local measure of the partial pressure of oxygen in the brain and is invasive. Near-infrared spectroscopy is a non-invasive method based on reflectance oximetry, measure the light reflected from the chromophores in the brain to drive the regional oxygen saturation of oxygen. Two types of leave that. Cerebral microdialysis is one of the promising bedside neuromonitors which provide the analysis of the biochemical markers for hypoxia or ischemia identifying impending secondary injury. It is used and recommendation in the severe cases of the traumatic brain injury. What happened? Time khatam ho gaya? जी So, मैं conclusion करता अभी थोड़ा सा और था चलें Okay, it's all right. Okay, it's all right. So, to conclude, the new updates in traumatic brain injury always is an evolving topic. Sometimes there are the researchers that are two types. We as a clinicians, we are depending on the improvement on the clinical side, the surgical side, and one is the researchers in the lab which are continuously evolving into the micronutrients and those things which can improve the hemodynamics of the brain so that we can improve. Well, that depends on the ICP monitoring and also the other techniques like the microvascular dialysis. Thank you so much.
Thank you, sir, for the updates. We have a slight change in our schedule. We first are going for the panel session on the 50th anniversary of Glasgow Coma Scale and impact on head injury care. For that, I would like to invite Dr. Rashid Juma, who is a professor of neurosurgery at the Kidney Center, Karachi, to please come on the stage. We will also have our panelists on Zoom with us, Dr. Terence Hope, who is a professor of neurosurgery in Nottingham, UK, and Dr. Vedantam Rajeshkar, professor of neurosurgery, Christian Medical College, Vellore, India. And Thank you, our chairs, for the session. We will resume the session again.
Thank you for that. I'm sorry to have interrupted the last session, Riaz Saab and the moderators. It's just that we've got the guests online because we thought we'd be sticking to time. And we're ready to speak to you, the panelists, which is Terence Hope from Nottingham, Professor Ved from Bangalore in India, and I'm keeping Professor Naveed Ashraf with me. We're all senior neurosurgeons. In fact, all of us are retired, semi-retired, or whatever. And the reason that we're together is that because we want to talk about how it is that all the things that my friend Riaz Raja was telling you about came about. Because all of this started about 50 years ago. And we want to reflect on that now because it's 50 years today that the Glasgow Coma scale was introduced to the world in a landmark publication in the Lancet in July 1974. And in that, there was a revolutionary step because a group of people driven by these new thoughts were concentrating their efforts on a traumatic brain injury. To give you an example, working with Brian Jeanette and Graham Teasdale, who devised this scheme, and you'll hear about that more from the panelists in a moment, were also two neuropathologists, Dr. Hume Adams and Dr. David Graham. And their substantial analysis of traumatized brains in the neuropathology laboratory introduced totally new concepts. Nobody before this had thought about a diffuse axonal injury. Nobody had thought about subependymal hemorrhages. Nobody had really had a good understanding of polar contusions. And this all came about at that time. And that then led to a complete reorientation of neurosurgeons who realized that there is a lot about head injury that we don't know and we could know more. People then moved on to doing all sorts of things that could help understand, like the introduction of cerebral blood flow that Riaz was talking about. So this was really a golden age, and this golden age was ushered in by two really major events. One is, of course, the introduction of the CT scanner, and I want to remind you that the first CT scanner was installed in 1973, and the first CT scanner was sold in 1974. And that was the time. So this was really almost ground zero. This was the big bang of neurotrauma. The other thing that came about, of course, is that Brian Jeanette, who really was the intellectual drive behind this, also devised the Glasgow outcomes score at that time. And both of these then gave us a common language and a common framework that was replicable and easily, accurately done around the world in all sorts of levels of setting of healthcare. And so with those words, I want to first turn to Dr. Ved, who's Dr. Ved is, I call him Ved, but actually his name is Professor Rajshekar. And Dr. Ved is a very distinguished, well-published, and extremely thoughtful neurosurgeon who spent a very illustrious career in the first neurosurgical unit of India, which was in Bangalore. Ved, I hope I've got that right.
It's at Vellore.
At Vellore, I beg your pardon. At Vellore. I'm so sorry. So it was the first unit?
It was the first actually, not only in India, but whole of South and East Asia.
Yes, but your predecessor, Professor Jacob Chandy, was really the first proper neurosurgeon in the Indian subcontinent.
That's right. That's right.
Yeah. So, please, over to you, sir.
Okay. Good afternoon, and thank you, Professor Juma. As I call him Rashid, because we go back several decades, I guess. Known each other for maybe 30 or 35 or 40 years. So thank you once again for asking me to be on this panel. Young neurosurgeons, not only young, actually contemporary neurosurgeons may wonder as to how we managed patients with altered sensorium 50 years ago. I came into neurosurgery in 1982, so that's a little over 40 years ago. And even at that time, the Glasgow Coma Score, although it had been introduced it had been published in 1974, was not being utilized by clinicians on a day-to-day basis. So what tools did we as neurosurgeons have at that time? The tool that we used to use is a small book published in 1967 by two authors, namely Plum and Posner. I don't know whether that book is even referred to by any neurosurgeon of the present era, but that actually very nicely documented and illustrated the clinical consequences of brain herniation due to raised intracranial pressure, both in the supratentorial and in the infratentorial compartment. And these authors, of course, base their observations or their clinical findings on the famous experiments of Charles Sherrington, which happened in the early part of the 20th century. But the problem with the Plum and Posner schema of patients with raised intracranial pressure undergoing various or manifesting various clinical symptoms and signs was that it only captured the patients who we presently would recognize as those with a GCS of less than 8. These were the patients who were called who were said to be in coma. So what happens to the patients who had a GCS now of between 15 and 8? We really had no good tools to find out whether these patients were worsening, improving, or were stable as far as their level of consciousness was concerned. And therefore, you can imagine that several patients did not get prompt treatment in alleviating the raised intracranial pressure that was building up in their heads, and possibly they were salvageable patients. And this is an unfortunate truth. All of us who were there at that time know that we would be called into the ER or into the ICU by the nurses saying, this patient was, fully awake just a few minutes ago and now is having problem breathing. We used to wonder, how did this happen? Obviously, it didn't happen, suddenly. There was a sequence of events which were missed because we didn't have the tools to monitor these patients. So when I came into neurosurgery in 1982, even at that time, we were not using the GCS to assess patients with head injury, leave alone patients with subarachnoid hemorrhage or other forms of other conditions which cause raised intracranial pressure. But fortunately, by the time I finished my neurosurgical residency, that was in 1987, GCS had been established as the norm for assessment of patients with altered sensorium of any nature, or even those who were at risk for having altered sensorium, such as those with head injury and subarachnoid hemorrhage. But remember, for subarachnoid hemorrhage, the scale that was used was the Hunt and Hess scale, which again was very subjective, and it didn't have the GCS built into it. It was only with the WFNS scale that was introduced in 1988 that the GCS became part of assessment of patients with subarachnoid hemorrhage. Unfortunately, our colleagues who were in the business of managing patients with altered sensorium, such as neurologists, general physicians, and pediatricians, did not jump onto this bandwagon of GCS early. Actually, I think they took their time about it, and it was probably only by the 90s that neurologists and the other clinicians recognized the importance of GCS and the value of GCS in managing these patients. Just let me give you a small example. All of you probably are aware of patients who have tuberculous meningitis with or without hydrocephalus, and the scale that was used, or it is used even now by several neurologists, is the MRC, the Medical Research Council of UK scale, which did not have the GCS as a part of its, of the grades right until 2005 when it was modified. So it was still subjective. Stuporous, altered, stuporous, drowsy, coma, those kinds of difficult to arouse, non-arousable, those kinds of words were used, and they meant different things to different clinicians and nurses. And when we introduced the Vellore grade for tuberculous meningitis with hydrocephalus in 1991 in the Journal of Neurosurgery, we incorporated the GCS. So even in 1991, we recognized that GCS works not only for patients with head injury and subarachnoid hemorrhage, but for conditions where altered sensorium is a possibility, and it gives you not only it not only tells you what to do based on the GCS, but also is a prognostic indicator. It tells you how this patient is going to behave, what the outcome is going to be at the end of the therapy. So please understand that where you stand right now, that is, I'm talking to the young neurosurgeons, was not where we stood always. And we need to be grateful to the pioneers who had the wisdom to recognize that things could be better. And the solution that they offered, the GCS, is not something high-tech. It's a bedside tool. And I marvel at the thought process that went into this, the numbers that were used, and the fact that it has stood the test of time. I think that is the true value of any tool, any technique, is has it remained valuable over several years, decades, and I dare say that GCS is going to be here to stay even probably throughout this century, if not even longer. So with those words, I want to end my brief sort of perspective on how I got introduced to the GCS and its value in management of patients, both neurological and neurosurgical, mind you. I think I'm grateful to the people in Glasgow who revolutionized the management of sick patients with neurological and neurosurgical conditions. Thank you.
Thank you very much for that. So, can I introduce Mr. Terence Hope from Nottingham? And Terence was also in practice when the scale was introduced. And he recently went up to Glasgow in July because Graham Teasdale and his younger colleagues had got together to not celebrate but commemorate and mark the event of its introduction, and they had some interesting discussions that he was telling me about. But Terry, over to you.
Good afternoon, everybody, and it's a privilege to be allowed to talk. First of all, can you hear me quite well? Can you hear me?
Yes, we can.
Good. As my friend Rashid has said a few weeks ago, it seems only a few weeks ago, but actually now we're in September, I was invited along with others to go back to Glasgow and to meet about 100 neurosurgeons and nurses and various other neuro-orientated people to look at the 50 years that have passed. My goodness, how quickly things go. And what was actually happening then and now. I just want to reiterate a few things that you, Rashid, and you, Raj, have said. I qualified in 1970. In 1972, I had my first experience as a young so-called senior house officer in Cambridge. And of course, that was 2 years before the Glasgow Coma Score paper came out in the Lancet. And in those days, what were we concerned about? And remember also, we didn't have the CT scanner. And indeed, even when the paper came out in 74, the so-called EMI scanner, which was the first CT scanner, was still a dream. So what we were doing was just looking at the skull X-ray, the pupils, and the type of head injury. We had no sort of guideline as to what to do. And sometimes the patient had only deteriorated beyond redemption when we would open the head with a craniotomy or burr hole. So we came from very primitive times. In 1976-7, I started to become a proper neurosurgical trainee. And by this time, 77, 3 years after the coma paper, a lot of people were still not using it. At the meeting a few weeks ago, it was emphasized by Graham Teasdale, who gave a very good 20 minutes talk, that in the early days of the Glasgow Coma score itself, scale and score, it was partially invented as a research tool. But he said quickly by 76, 2 years after the paper, particularly after a paper published in the Journal of Neurosurgery by Tom Langford, emphasizing how neurosurgeons around the world should take this scale on board. And he emphasized that at that meeting a few weeks ago. The other thing that he emphasized was that the scale had to be simple, it had to be reliable with reasonable observer error, and also it had to have some purpose in intervention. So that was the three aspects of it. At that meeting a few weeks ago was a senior nurse who actually did a very important thing, because of course in our units around the world, it is the nursing staff who actually are measuring the Glasgow Coma score. And interesting enough, at that meeting a few weeks ago in Glasgow, she actually had done some work in investigating around the world, say in Vellore versus Karachi versus a unit in Great Britain, inter-observer problems. And even today, we have to constantly train our nurses, our young nurses in the wards and in the intensive care unit, how to use the Glasgow Coma score. There is no point in having the score unless we are competent in training our nurses how to use it. And that's still a problem even today. And that was emphasized at that meeting a few weeks ago. The other thing that Raj, you mentioned very wisely is that gradually, of course, the Glasgow Coma score has been applied to other aspects of neurology and neurosurgery. You mentioned meningitis. And I gave a joint paper a few weeks ago reviewing some work I did with a man called Professor David Mendelow, looking at 2 units over 5 years of intake of subarachnoid hemorrhage. And the core aspect of our paper, which got into the Journal of Neurosurgery, was the Glasgow Coma score. So what is important to realize is that the original idea of Brian Jeanette and Graham Teasdale and his colleagues for a trauma aspect has now become far more utilitarian. The Glasgow outcome score of course, which is something completely different, had again a look back, as it were, to the Glasgow scale of the patient when they came in, and indeed when they were about to be discharged from the intensive care unit. But I want to end by saying, given my age, I have seen a tremendous change for the better. Of course, the CT scanner becoming used, as Rashid said, was an amazing advance. But we must not forget there's no point in having the scanner unless hour by hour we're able to observe our patients competently, and that requires the nursing staff to be trained and be able to use the Glasgow Coma scale and apply it sensibly, and telephoning us when patients are deteriorating. I think that's all I want to say, because it'd be useful to have all of us in discussion. Thank you.
Terry, thank you very
Perhaps
much indeed.
You could come in and discuss.
But Terry, I just wanted to make the point that, it has extended its arms in various directions. And one of the things to think about, and this merits serious thought, is that we live in an age of practice guidelines. The practice guidelines are ubiquitous, you can't avoid them. The first surgical specialty practice guidelines were head injury guidelines. And in the head injury guidelines, central to them was the Glasgow Coma scale. And everything else that we do with, as Ved is saying, that relates to alteration of consciousness, whatever the disease process, is first of all quantified by the Glasgow Coma scale. And the second is that when we think about guidelines for practice, whichever the disease condition, they will always incorporate, as was being said with the subarachnoid hemorrhage WFNS scale, the Glasgow Coma scale. Now, I want to ask you gentlemen, in the time that we have left, we have about 15 minutes left, what do you understand? First, you, Terry, and then Rajshekhar, what do you understand as the fundamental or the conceptual difference between the Glasgow Coma scale and the Glasgow Coma score? Terry, you first.
Okay, well, that's a very interesting question. Graham Teasdale said a few weeks ago that he never intended to use the sum, the 15, the magic 15, to be absolutely so-called normal. But in fact, what we are well aware is that in terms of dissecting the scale, the motor aspect is probably one of the most important aspects of the three eyes, verbal and motor. So I think that that's an important point. The other thing, of course, is that we must remember that many of our patients have problems with in terms of the nurse being able to give you the score. I mean, if the eyes are swollen, how do you put the eyes? So you have to document that. If the patient is intubated, you have to document that. So there are problems still. And of course, the other thing that is very much the case in our country, I hope it's not so in Pakistan, being essentially a Muslim country, alcohol. So many of our patients come in to our accident emergency units inebriated. And it's very wrong to say that the patient's Glasgow Coma score is low because of alcohol. And that is a danger point. Okay? So those are some comments I would make. Okay, Rashid, could you come back on me on that?
Yeah, Raj, do you want to say something on that?
Yeah, so that's an interesting kind of debate between the scale and the score. I agree with Terry that I think the motor component is, of course, we all recognize that the motor component is the most important and the most reliable in different circumstances, as Terry mentioned about, patients who have consumed alcohol and so on and so forth, swollen eyes, etc., or even aphasic patients. But the point is that the categorization of the the levels, the grading, whether it be head injury or subarachnoid hemorrhage, or for in our situation the velour grade of tuberculous meningitis, is based on the score. What you categorize as mild, moderate, and severe head injury is based on the composite score. So there is a bit of a dichotomy there, so which we cannot sort of run away from, in the sense that we still need to recognize that the score is a crucial sort of a figure that guides us as to the management and the prognosis of these patients. So just as an aside, I would insist on all my residents giving me the score. Of course, if the patient is intubated, they would say, 340 by 15 or, 60 by 15 and so on and so forth. But I was loath to sit there and start calculating, or adding up E, M, and V while I am on rounds in the ICU. But that's just a personal preference, because like I said, at the end of the day, I needed to make up my mind whether this patient had mild, moderate, or severe head injury, and similarly for the other conditions with the WFNS score or the velour grading for tuberculous meningitis. So I think both have their place. So I think that's how it's going to continue to remain, because whether we like it or not, the score, the composite score, has been incorporated into the grading of the various conditions.
So, Raj, I want to share with you that Brian Jeanette once wrote I can't remember whether it was an article or a book chapter, and quite honestly, I don't remember the contents, but I remember the title. And the title was Numeracy and the Neurosurgeon, in which he made the point that neurosurgeons are not usually very facile with numbers. Terry, I don't know whether you've ever come across that article or book chapter by him. And in that, and therein hangs the tale, and that is that you're right, a single score is helpful, but when that single score is about so if it's like 15 or 14, that's fine. If it's 3 or 4, that's fine. When you're in the 9 zone, then you've got a problem. And you really, as the attending, you need to have a better understanding. And that better understanding of the patient, that is, will come from a description of all 3 parameters. Terry, you want to come in?
Yes, I agree entirely. I just want to add something that suddenly occurred to me. In the United Kingdom, we rely heavily upon the ambulance drivers. And what has happened in the last 4 or 5 years is that we've insisted in head injury management from the roadside or from the house to the hospital that the Glasgow Coma score is carefully documented by the first person seeing the patient. That's a very useful thing, because of course, increasingly we have patients who are intubated, say at the motorway, the Autobahn, and we want to know as neurosurgeons, what was the Glasgow Coma score when the ambulance driver saw the patient or the paramedic intubated the patient? That's one thing. That's a thing I've seen in the last 5 years. The second thing I want to say is that our population in the United Kingdom is aging like me. And many older patients are taking, say, an antiplatelet drug like aspirin or dipyridamole or whatever, percent. So we have seen a change, Raj, in the last few years, that older patients with, say, a Glasgow Coma score of only 13 will be going into the scanner, which I never saw before. And that is because we're worried about the patient developing, say, a chronic subdural hematoma or even a subacute hematoma in the next few days. So we are seeing the Glasgow Coma Score used more in a different way. Thank you.
Right. Raj, did you want to say something?
No, I agree with Terry with regard to the last point he made. I again also believe that in head injured patients, more CTs are better than less CTs. Yeah, I know that it's going to consume more resources, but if you really want to save the odd patient, may not be the odd patient, maybe even a lot of patients, you have to have a high index of suspicion. And of course, that is based on judgment. But like Terry said, even a patient who's 13, don't just dismiss off this patient as saying, it's just mild or early moderate, that kind of a thing. Just let's look at the patient as a whole and think about the risks. Yes.
That's absolutely true, Raj. If you look at now, the head injury trials that are coming out now are very large numbers, 3,000, 4,000 patients. I'm thinking of things like the CRASH 3. And when you look at that data set, you realize that people with mild head injury do die. There's a certain number of people with mild head injury and will perish. And so it's actually quite a responsibility. I just wanted to ask you gentlemen, and while I'm asking this question, Dr. Talha, if you're in the room, and if you can carry a microphone around, if any member of the audience would like to ask a question of the panelists, that'd be great. If Talha, if that's possible. If you can just take the thing, and so if you can just stand somewhere in the aisle in the middle, and if anybody wants to ask a question, yeah. So, right. Madam, please go ahead.
Hello, my name is Dr. Anila Darbar, and I'm a mid-career neurosurgeon. And for me, GCS was like from the medical school, you learned GCS. You always take it for granted that GCS is just a part of neurosurgery you learned. Never understood the importance and historical perspective of how GCS had come into being. So thank you very much for this enlightening talk. What I wanted to say is just a comment with what Dr. Ved said as well, that the GCS is now not just used for trauma, but for everything. For example, meningitis, hydrocephalus, even brain tumors. When we have to communicate with our residents or with our trainees, the first thing we ask is, what's the GCS, no matter if it's a brain tumor that we had operated on. Initially, I used to get upset because I thought, GCS is a score for trauma. It's a prognosticating factor for trauma, not for brain tumor, and I would always insist on that. But later on, I just realized that GCS is actually just a communication tool of a resident, a neurosurgeon, or communicating to somebody else at what is the neurological status at that time. So I think GCS has gone far and beyond. Probably the one who invented GCS did not think that after 51 years, the fourth generation would be still using the GCS. I think GCS, maybe, as we said, that GCS may need a GCS2 now.
So what's your question?
I don't have a question, it's just a comment. This is just a comment. I didn't have a question, I just was commenting because I really enjoyed the talk.
Right,
thank you.
So I'm reminded of one thing, and that is that, Talha, 1 second. I'm reminded of one thing, and that is that, for the people on this panel, the three of us in the panel will all of us will tell you if you ask us one by one. When the first man landed on the moon, we were completely blown away. Like this was the greatest thing that we had ever heard about. But today, you grab a young person and say, hey, do you know who went to the moon so many years ago? They'll say, what moon, who went where? I mean, it's really astonishing. So it's a bit like that. Your comment is interesting because, you're right, because it's there all the time and you never question. And what Terry will tell you, and I hope you got that when they gathered for their 50th anniversary, Teasdale was there. And he obviously, and Jeanette has died, But Teasdale obviously expressed great satisfaction at the fact that their work was now widely recognized and widely adopted. And what's interesting is that they're looking to the future. Like, one of the things that's happening is attempts by people to integrate the pupillary score into GCS. So you have a GCSP, which people feel may actually be more sensitive in identifying those people who are going to have trouble.
But that was exactly my question, and this is what I was asking. My name is Professor Farooq Afzal. I'm a professor of surgery, general surgery, and I teach a lot of trauma, so that's the reason I'm asking. What is the importance of pupillary dilatation, I mean, vis-a-vis this GCS?
Right. So, you know, as I said, it's of critical importance. So let's forget about the scale. Let's just concentrate on the fact that the strongest and the best localizing sign of intracranial mischief is a unilateral pupillary dilatation. Every neurosurgeon will tell you that. So that's critically important. And that's why I think that it's very likely that as we go forward, pupil will be integrated with GCS. Terry, was there any talk about this in Glasgow when you were there?
Oh, yes. And Professor Teasdale, who was in good form, by the way, stood up and said, look, do not change the Glasgow Coma scale. It works. The pupil is an add-on aspect. And this was actually something that made him very angry. He said that if it's work, why change it? Okay.
Right.
I wanted to say something else, though, that our lady colleague who stood up reminded me that in medical school teaching of medical students, it is very important for we doctors to train our students about the Glasgow Coma scale and how to do it. We involve that in our exams in Nottingham, would you believe? We have actors and actresses who can pretend to be, let's call it Glasgow unconscious. And it's really remarkable how very badly students do assess the Glasgow Coma scale. Okay?
Sorry.
One question.
No, Neera's comment actually reminds me of a couple of things. I just want to integrate them. We're left with a very little bit of time. She has grown up in an environment where GCS was common. It was a given thing. And when we were practicing, we used to come across these adjectives, obtunded, unconscious, semi-comatose, and we won't understand. But let me tell you something, that the seminal paper on the Glasgow Coma scale, the authors, they said that we don't want to replace the niceties of the neurological examination, and by listening to you, I can see that now it has almost replaced the niceties of the neurological exam. It's half of the neurological examination, as when you do an MRI, it is almost a neurological examination.
Thank you very much.
Thanks for that comment.
One question. Sorry, I just wanted to ask one question with the panel. First of all, I would like to thank Professor Juma, Professor Terry, and Professor Rajeshkar. It's really a without any compulsion, I must say that this is a commendable discussion here, and we learn a lot from you guys. My question is that the numerical representation of a Glasgow score in comparison to the narrative, because this is a problem where Professor Juma was asking about between 9 and 12. It's difficult to assess by different assessors of Glasgow Coma score if numerically they wrote 9 or 10 or 11, and the other guy who come again and he can misinterpret with the numbers. So what's your take on this, whether the Glasgow Coma score will be represented with numerical presentation or narrative, like flexor response, if you are describing the motor response like he's localizing or flexor, should we write this or we go for numbers?
Terry, do you want to take that? So should it just be a single number, or should we be more descriptive?
I'm afraid the answer is both. I want to know when I'm on the telephone and I'm speaking to somebody, if I'm on call, I want to know what is the Glasgow Coma score, And how did you make that score up? I want more information. And the other thing that we haven't mentioned is, I also want to know what are the blood gases? So the referring hospital, have they, with an unconscious comatose patient, have they done the blood gases? You know, these are questions that are also important, not just I think someone talked about the whole of the patient, and the Glasgow Coma scoring and the scale is part of the whole of the patient, not the whole in the patient.
So in the last minute, Raz, quickly, very quickly.
We are short of time. If we can just wrap this
just a
session
minute. It's still 1 minute to go.
Dr. Juma,
please, Riaz, Bol.
Sir, as you said, even the mild head injury patients die.
Yes.
So initially, I think when the CT scan was not popular, not present in every center. So we have seen in our residency that the few patients came who had the normal CT, who had the head injury, but they went away at home, and on the second day they came in the hospital, and when we were just going to the CT scan and we saw the CT scan, and there was a huge hematoma and they were decerebrating at that time, and they expired. But now we are not relying more on the GCS, but everywhere. It is my concept that if the patient comes with a mild trauma, I always advise for the CT scan to get the full information regarding the intracranial things.
Yeah, sure. And I think that one of the things that's most important, the most important thing that hasn't been said, and I want this to be our last word, if you don't mind, before we move on. I promised them we'd finish on time. And that is that in head injury management, the single most important thing is watching the trend of the patient's conscious level. And nothing else has contributed, including CT scan, nothing else has contributed more to the detection of change in neurological status than the GCS. So let's give GCS a round of applause at its 50th birthday. Terry, thank you. Raj, thank you very much indeed. Appreciate it.
Thank you.
Well, now I can go and get my breakfast.
Right.
Bye.
Thank you all for joining us for the 50th anniversary of GCS. I am grateful to Dr. Anila and Dr. Nabila for accommodating the change in session. I would now invite Dr. Anila Darbar for her talk on management of dorsal-lumbar spinal fractures. She is consultant neurosurgeon at King's College Hospital, Dubai. I would like Dr. Amir Sagir and Dr. Gohar Javed to join us on the stage again.
Thank you. Assalamu alaikum. I'm Dr. Anila. I just want to thank you, the managing committee, the scientific committee chair, Dr. Sajida, Dr. Atiq and Dr. Imran for inviting me for this talk. And we're going to switch gears a little bit now. We've been talking about brain injuries, traumatic brain injuries, GCS score. And now I'm going to talk a little bit about traumatic dorsal lumbar spine fractures. Since I saw that there was no cervical talk, so I have also incorporated a few of the cervical injuries in it, so just to make it more comprehensive. How does this move? Excuse me, how does this move? Okay, sorry. These are the two institutes that I work at, the King's College Hospital in Dubai as well as Aga Khan Hospital, Karachi. Thank you, yeah, got it, thank you. So for all the non-neurosurgeons and for budding neurosurgeons or residents, the most important thing in spine is actually the classification system, because it actually helps you to understand whether this particular kind of fracture would require a conservative approach or whether it requires a surgical management. Now, there are many classifications of dorsal lumbar spine that had come up over the years, but the one that I'm using here is a AO spine, which actually is a little bit more comprehensive because it involves all the three status of the morphology of the injury, the neurological status, as well as the ligamentous integrity, as well as the comorbids of that patient. So it makes it quite comprehensive, and it just does not incorporate a single thing, like, for example, just the morphological feature or the neurological injury. So there was a Punjabi and white classification before, which was only for morphology, or an Asia scoring for spine, which is only for neurological status. The AO spine incorporates all three together. And this is the morphological classification. So basically, it is graded as AO, A1, A2, A3, and A4, depending on the more involvement of the dorsolumbar fracture, and it's given a score from 0, 1, 2, 3, 4. The B is more of a ligamentous and bony injury together, and again, it goes to like 6 and 7. And then C is a total fracture dislocation, which goes to 8. So this is how the scoring is done. And then, sorry, I have to go back. Okay, I'm just going to hurry up. So basically, the other thing is the neurological status, which I think this is going a little slow. So this is the neurological status in which there is no deficits, transient deficits, sign and symptoms, incomplete injury, a complete injury, or it cannot be assessed because there is a head trauma, intoxication, or sedation. And the last one is a modifier, which simply means that whether you have a ligamentous injury as well as any other comorbids, because for any kind of a surgical intervention in spine, which usually requires placement of screws and rods, osteoporosis becomes a big factor for neurosurgeons to understand if we can even do that. And this is the scoring. So if you have 0 to 3, you opt for conservative treatment. If you have 4 to 5, you do an operative or non-operative treatment, depending. And greater than 5 is usually a surgical intervention. So the three most causes of fracture that we see in Pakistan is, number 1, a road traffic accident. Number 2 is osteoporotic fractures, and number 3 is the gunshot injuries. So for the traumatic fractures, for example, due to road traffic accidents or fall or violence, the most common is the cervical, which is 51%. Thoracic is about 34.3, and lumbosacral is about 10.7. And these are the causes. We know RTA, falls, act of violence, recreational sports, adult fractures, and pediatric injuries, usually RTA, are most devastating because it usually disconnects the skull from the cervical spine, which is the atlanto-occipital dislocation. The management, again, I'm not going to go into it, but basically you need your A, B, C, D, E, skillful neurological examination, making sure that your C-spine is stabilized, your cervical spine is stabilized, your thoracolumbar is stabilized on a spine board, and then obtaining X-ray, CT scan to understand what kind of injury it is, so that you do not do a secondary injury to the spinal cord. Sorry, I'm just going to go back again. So do we need to decompress the patient with spinal cord injury right away? This is the question a surgeon has every single time. Now, it all depends on the pathology, whether it needs to be done or not. So for example, do you have any other, this is not working right actually. Either maybe the battery is low. Do you have anything else? So if you have a fracture like that, in which there is a total break of your C2 bone, it's a completely unstable injury, and as a result of which you need to fix it. If you have a fracture dislocation like that, yes, it's an unstable injury, and you need to fix it. But if you have something like that, now this comes into a yes or no zone. there is a fracture of one of the vertebral bodies of the spine. In this case, it's L3. And there is a little bit of a segment, which we call as a retrograde, retropulsion into the canal that's happening there. Now here, if depending on your AO spine classification, for example, if you only have this, it will be just an A4. Okay, so your surgical, non-surgical treatment is fine if you have no neurological deficits. But if you have a neurological deficit, then you become into 4 and 5, and you can choose if you want to operate or not. So this becomes the little gray zone. And then if you are opting for a conservative treatment, this is the right kind of brace that one should wear, and not this kind of brace which I usually see people wearing. This is for low back pain, degenerative spine, not for fractures in the spine. For fracture in the spine, you need a proper TLSO brace. And if you are opting for surgical management of the same problem, we can do a short segment fusion or a long segment fusion, and of course the neurosurgeons will understand it better. It simply means that if you have a fracture, you don't have to put too many screws. You can actually put a screw in the fractured segment, and the results of a short segment fracture fusion versus a long segment fusion, in which you actually leave the fractured segment but in fact put two levels above and below, are considered equal. The outcomes are exactly equal whether you do a short segment fusion or long segment fusion. And as you say, the long segment fusion, of course, will need more time, more comorbidities will occur because of infection, longer incision, etc., etc. But if you have this, now this is, if you can see, there's a modifier here, which is a osteoporosis. And you can see that not only one, but two bones are broken together with an osteoporotic. So you really have to understand what is the neurological deficit. Is this stable, unstable? And then you decide one of them is a chance fracture, one of them is a burst fracture. And then you decide whether you want to do. I personally thought it's an unstable fracture, and it cannot just be stabilized on a TLSO brace, and so it required a fusion, a long segment fusion, in fact. Now, the other reason in Pakistan that we see is gunshot injury, which also causes fractures in the spine. In Pakistan, you can see community violence, wedding celebrations, which cause a stray bullet to hit somebody, or an armed robbery. And if you have a fracture like this, question is, do you want to operate or not? In my head, no, because number one, the spine is completely stable. It's not fracturally dislocated, and the patient has complete spinal cord injury over at this level. So should we operate or not? I personally think does not need it, because even for rehabilitation, the spine is intact. But if you have something like that, do you want to operate on it? Do you want to go and take a bullet out when it's sitting in the spinal cord? I personally think no. Or if you have a bullet that's lodged just into the vertebral bone, not even going to the spinal cord, I think no. Now there is a big myth and belief in Pakistan about taking the bullet out. People think if you're going to take the bullet out, the spinal cord, sorry, I still had time. I understand, but I actually waited, half an hour to wait, and you guys are just going to stop my presentation. I think it's unfair because other people also had a few more minutes. Thank you. So the belief that you can have the bullet taken out and your spinal cord injury becomes better is total belief, because it doesn't work. And we had we actually did a paper in which we found out that if you leave the bullet in the body, even if you have a neurological injury, patients actually recover if it does not traverse the spinal cord. So the bullet does not have to come out. And if you have osteoporotic fracture, this I'm going to go very quickly, which is the third segment of dorsal-lumbar fractures, which has its own classification. And medical management is #1 choice, because usually happens in elderly, and if you can give a brace, zoledronic acid. And if you do a surgical management, it's usually in the form of kyphoplasty, vertebroplasty, or short segment fusion. And kyphoplasty or vertebroplasty simply means that you actually fill the bone with a cement, and that's usually done with the help of a needle. You can do at one level of the spine, and you can also do at a couple of levels of the spine. And last one is fracture dislocation. If you have an injury like that, usually the recovery from neurological status is not great, but it is required for rehabilitation. We're going to hear from Dr. Nabila Somra what is the rehabilitation of the spine in such fractures. So in the conclusion, I just want to say that you have to understand the classification. You have to customize as per the neurological status, morphology, and the modifiers. And not all spinal cord fracture requires surgical intervention. You also have to be cognizant about the cultural, financial, and personal issue and the expectation management, because we see in our clinic patients who have spinal cord injury for 5 years still going from doctor to doctor thinking that some doctor will do some miracle on them and they're going to get better. So this expectation should be managed, I believe, right from the get-go. Thank you so much. And thank you for giving me extra time.
Thank you. Now I would like to invite Dr. Nabila Najam Sumro for her talk on rehabilitation in spinal injury patients. She is a professor and executive director of Sindh Institute of Physical Medicine and Rehabilitation Center.
Bismillahirrahmanirrahim. Assalamu alaikum. Just a quick review of acute spinal cord injury here. But on 50th anniversary of GCS, I would also like to announce that finally, after great efforts, we'll soon have inpatient spinal cord, stroke, and post-TBI ward. So that's a news for. I think I'll like to skip this. We came into being when the first earthquake came in 2005. So historical background is that spinal cord injuries go back, spinal cord injury rehab goes back to 2600 BC. I don't even know how to pronounce it. And then first unit was built by Sir Ludwig Guttmann in 1944. So post-injury survival without rehab in First World War was 10% and Second World War was 90%. So I don't want my screen to shut off. So this is a functional scale to assess that which syndrome will make patient functional at what level. We usually use Asia impairment scale to decide which injury is complete and complete normal, and accordingly we move forward. So our expected functional outcome at the level of injuries, that at the end of rehab, who at which level will be functionally independent in all activities of daily living. So that includes our grooming, transfers, dressing. So this functional outcome scale will decide right at the beginning when the patient comes for inpatient rehab that which patient would be wheelchair bound or they'll be independent in which activities of daily living. And of course, these are few negative markers that spinal cord injury of same level will have different fate because of the negative markers. If they have an history of alcohol, anxiety, depression, and other negative markers. FIM is a major scale which we follow to assess the functional outcome. So we physiatrists or rehab physicians, if we want to exchange the outcome measures, so we use FIM scale for recovery and to measure the independence finally. Rehab medicine again is not a one-man show, it's a teamwork. So if it's a neurosurgeon, orthopedic surgeon, a rehab physician, and a team of people which belong to allied health services. This is a brochure which we've developed that at the end of the day, when they're discharged, how should we be educating them for being at home and when to reporting us and to you. I'm sorry, I just can't go into the detail. I don't want my screen to be shut when few slides are still left. So nutrition has a major role. So this chart we've developed to follow for our patients, that which patient should be given which nutritional support as per their symptoms. So of course our rehab starts first from range of motion to stretching and so on finally. So these are the pictorial pictures which of the journey they undergo. And then finally, transfer board again is a very important training for spinal cord injury patients. And then gradually weight bearing, gait training. So they basically rotate among our physical therapy, occupational therapy, and psychological and our neuropsychology floors, and then we assess them every 2 weeks. So the complication, of course, apart from a normal rehab, the complication on which we concentrate are basically pulmonary. So these are the steps we take in acute. Here I'm only today sharing with you the rehab measures we take for acute spinal cord injury, because for chronic, it's a really another topic. So for pneumonia, and these are the steps. I won't waste time because I have very few minutes left. I've put in all the steps. Just one sentence here, that the normal stockings which we usually give patients are just not the tubey grips. They are not, so no normal stockings should be given to the patient which are available in the market, because they are just extended socks. They don't exert that kind of pressure that they mobilize or they'll prevent DVT. So the other options I've just shared here. Autonomic dysreflexia, these are the steps we take. For orthostatic hypotension, so I've put everything here. So anyone interested can just take presentation home. And bladder, we have to categorize that it's failure to store or it's a combination. Similarly, bowel management, we just see the consistency of the stool, and then we make an individually tailored program. How should the patient be trained for bowel evacuation? Whether it's an upper motor neuron or it's a lower motor neuron. Pressure ulcers, again a major challenge. So these are few pictures of my patients. Osteoporosis and fractures while rehabilitating them, again a big challenge. But we have to mobilize them because 30 to 40% waste of muscles and bones if we don't mobilize them in time. So contractures, I think there's a... So contractures again are the major. Spasticity management, pain is very difficult to deal, so we use all pharmacological interventions. So for contractures, we do have, at the institute, we have a floor of orthotic supports, and then along with therapies, the orthotic support is just given to them. As Dr. Anila also mentioned, that for chronic spinal rehab, we do have different orthoses, and all are made at the first floor of the institute. Stones, tumors, UTI, we have to address accordingly through this long journey. So, sorry. These are just recent advances which I would just like to share, and we are heading towards it. So, advanced seating, advanced wheelchair, mobility options, battery operated scooters, body weight supported treadmill, which we currently, last year we finally got it, and then body weight supported treadmill, and then computerized control for for TBI and also for high spinal cord injury patients. So this is our plan for next 2 years, implanted electrical stimulators, and so these are newer technologies with breakthroughs. So I think I only have to. So these are sports activities, our spinal cord injury, post-TBI patients. Vocational rehab is a major portion of rehab. So these are scientific evidences. And I'm glad that I finished in time. Thank you. So I just will quote this, that this is the result of a proper multidisciplinary rehab. Thank you for time and patience.
Thank you all for joining us. Unfortunately, we are short of time, so we won't be able to take questions during the session. If anyone has any questions, they can ask from the experts during lunch. I would now conclude the session, and everyone should proceed for lunch.
Hello. Hello, check. Hello. Check one. Hello. Check. Hello.
आवाज़ आ रही है? अब आ रही है, yeah. Haji, Assalamu alaikum. I welcome you all to the session on pelvis and extremity trauma of our second PAK Traumacon meeting. We are starting a bit late. Apologies for that because the previous session ended a bit late. Slides lagaएं, please. Right. Next. Next. Right, my name is Dr. Sayyid Akmal Sultan. I'm heading the orthopedics department at the Shaheed Mohtharma Benazir Bhutto Institute of Trauma. That's an old picture of mine which hasn't been updated. I would like to invite we have got two chairs of this interesting session. I would like to invite Professor Anisadeen Bhatti to kindly come to the stage. He's a professor of orthopedics, previously from JPMC and now at the Ziauddin Medical University. Sir. I would like to invite our second chair, Professor Maratib Ali, to kindly come to the stage. He's a professor of orthopedics and was associated with DUHS and Civil Hospital, Karachi. Thank you. You're welcome. I would like to set a few ground rules for this session. Please switch your phones to the silent mode or switch them off as appropriate. We will be sticking to the timeline of all the presentations. You will hear a warning bell at 2 minutes, then at 30 seconds, and at 10 minutes the screen will go blank. This is all prefix in the system and we won't be able to give any extra time. So kindly keep your talks on time, please.
Variety different है ना, तो क्वेश्चन दो क्वेश्चन हर लेक्चर के साथ ले लें.
आखिर में नहीं लेना.
आखिर में सब डिस्कशन डिफरेंट हो जाएगी.
Okay.
तो पहले CW पूरे करके ले लो, दो ले ले.
Okay. Right, we'll be entertaining questions as per the region, so I will be just moderating that. I'd like to start with our first talk by Professor Intakhab Tawfiq. He'll be talking about the pelvic ring injuries and should they be fixed anteriorly or posteriorly.
दूसरा भी ऑन ही एक करना हो गया. अस्सलाम वालेकुम. I was just saying to Maratib, it looks like an LNH meeting. He was surrounded by all of us, all of our previous trainees, and we have got contemporaries, Anis, and it's time for us to now actually enjoy our जो कि हमने बोया है ना, वो हमारा टाइम शुरू हो गया है. My purpose of coming back to Pakistan has been served. In fact, मेरे पैदा होने का मकसद भी पूरा हो गया. इतना खुशी की बात है. सारे अकमल है, गज़नफ़र है, ये सारे इतने सारे I've got residents to मतलब cheer me up. It's so happy thing. And secondly, I must congratulate you. You have organized it very well. It was not only preparing the program. Actually, it was repeated reminders and repeated contacting us, which makes the thing a success. Chaliye ji, coming forward, my topic is more of my practice as well. So they are asking me where to approach first. So I thought I should lay down few rules. And first thing is that I'm going to talk about the pelvic ring, and then I would talk about the stability factors. Now, when I say pelvic rings, I means the anatomy, the circle, and the stability means ligaments. This is just a crude form of saying actually, but these are the two nominate bones, and these are the joints. Hip joint I'm not counting in the ring, and this is the ring, and I have divided a line here, more of the posterior, less of the anterior. This is the ring, okay? So next slide is that if you turn it sideways, the weight bearing is slightly anterior. For example, this is the weight bearing axis. This is going through the sacroiliac joint. This is tilted forward. Now there are compressive forces, linear forces, and all are converged into the sacroiliac joint. Just keep this in mind. Now, if a pelvis is broken at one place, it can be stable. If it's broken at two places, it can be unstable. Now look here, but if it is displaced, it is definitely unstable. Now, if it is broken and not displaced, you have to find out whether this is stable or unstable, because then it will decide upon whether you're going to fix it or not. Now, if the ring is stable, is there a deformity? If there is a deformity, you have to care about the posterior aspect. Now, yes, CT is good, and otherwise stress radiograph and C-arm in OR, which I've never done because I always get CT before operating. Look here. Now, it is broken, 1, 2, 3 maybe, but I'm worried about what is the posterior ring like. Posterior ring is perfect, right? There's no crack. There's no crack. I need not to fix it, so I leave it alone. So I am going to emphasize about the ring, the posterior ring, and what is the stable fracture? What is the definition of stability? It is defined as a fracture which can stand the normal physiological forces across the joint, without changing its anatomy. Now the stabilizing factor are, of course, bones which are not that strong, but the ligaments, they are the mainstay of the strength. Okay? Let's come to this another concept. Now, can you see these long hanging bridges? 6 lanes on each side. I have traveled into it. Now, there are 2 big pillars which take the tension, and these are the ropes and the cords, or the ligaments you call it, and the whole of the force is distributed and twined around these main metal rope. So the tension is distributed. So everywhere it's the same tension. Okay? So let's see this, the pelvis from the top. These are the 2 pillars, and all the tension, compression, and tensive forces are coming here, gathering here, and these are the ropes, these are the cords, these are the metal ropes, and these are taking the tension. But remember one thing, I'm putting this slide again and again because I want to stress about these strong ligaments. So most of them are posterior side. For example, the sacroiliac ligaments anterior and the posterior, and particularly iliolumbar ligament. When it's broken, it's unstable always. And the ischio-sacral ligament, the ischioiliac ligament, whatever, these all our ligaments are holding the pelvis, and most of them are posterior. Anteriorly, there's one ligament which is the pubis symphysis, which is considered to be relatively a weaker ligament. So these are the ligaments holding it like a fort. It's very strong from behind. And so if you say that the weight bearing is also from the posterior side, and the holding of the pelvis is from the posterior side as well, this can be well understandable that you have to take a special care from posteriorly. One thing more, the weight bearing in sitting in a standing position goes from the sacrum, sacroiliac joint posteriorly. It does not, this actually takes the conformity, this maintains the anatomy, but weight bearing takes place, load bearing takes place posteriorly. So, what would be the definition of instability? Loss of posterior ring integrity leads to instability. What about the anterior ring? Anterior ring integrity may suggest you that posterior injury is there. So you have to take care and you have to find out. And lastly, the tile classification, which is a language spoken between the surgeons to say that in the middle of the night, if my resident says tile B, so I say, okay, go, we have to fix it. And what is this classification? Don't sort of burden your memory. Tile A, tile B, tile C. And tile A is when the ring is stable. One place, maybe two places, but the main ligaments holding the posterior arch, posterior ring is stable. But if it's broken anteriorly and posteriorly, or the ligaments are open, rotationally they are unstable, then you have to take care of it, you have to fix it. And what is vertical instability? This is when somebody falls from the lift, from the ladder, from the roof, and this laterally it climbs up. This is tile C, it's very unstable, and you have to fix it again. This has got, the prognosis has to be sort of discussed, but this is not, is it 8 minutes? 2 minutes left. Sorry, bhai. Chalo, we have to go forward. So, it was 10 minutes, I thought. 8 minutes ho gaye. No. Weight bearing is through the posterior. Now look here. This fracture, this is the E face, the pubis is E face, and there's a crack here. So I need to fix it. This is an example. If you see the X-ray, this is wide open, something is wrong, you have to fix it. I fixed it anteriorly to get the anatomy, then reinforce it posteriorly so that the ring is formed. Okay, so this is the pubis brought together. Now look here, I drew a line, there's something not right, must be posteriorly, something is not right. We have to get the X-ray, we have to get the CT scan. Here's the CT scan, and I have to sort of fix it anteriorly. And he was overweight, so I put 2 plates, polytraumas to fix everything, and to secure my fixation, I have to get the anatomy right and secure it, and then put the screw back. Again, I am fixing it anteriorly, but to get the anatomy right posteriorly. So again, here, tile B, look here, is displaced, and CT scan, broken here, broken elsewhere, here and here. And again, this is the plate, and this is the instrumentation I use, and then I fix it. This is the instrumentation, and this is the plate, and this is the fixation. Again, anteriorly I'm saying that I'm fixing it to get the anatomy, then securing it posteriorly. So this is the young lady with a poor abdominal wall condition. There's a crack and turning up. This has to be fixed. This is open here. But what I did is that I sort of put a screw from posteriorly first, and I know this is broken here, so I would not be able to get the anatomy. Then securing my posterior ring, I closed it from the internal fixator interni. These are the X-rays. Now again, this is something twisted, and I would not care about this anterior thing. I just sort of put a screw, and then this is the X-ray post-op few months later. ठीक है जी. Sorry. Thank you.
Thank you, Dr. Intakhab. Apologies for having to stick to the time. Sorry. Right, I'd like to invite Professor Badruddin Seto to give his interesting talk on acetabular fractures, current management and updates. Dr. Badr.
Thank you very much, Akmal. It's always an honor to present in front of your teachers. So, Bhatti Sahab here, Maratib Sahab, definitely Intakhab Sahab, we've been inspired by him to learn the palace SCW fixations. So basically, SCW fractures nowadays we see every day in a single patient in our trauma center. We have seen rarely 1 patient, 2 patients, 3 patients, but right now, nowadays within the last 6 months, we every day see a single patient of Palace SCW in trauma center. And it's always key to learn what are the new concepts they are giving. And if you learn these, you will definitely have some idea how to deal with these complex problems. So this key is we always think This is the key, intra-articular fractures. We consider ICWM fractures as intra-articular fractures. So same tibal plate, if it is intra-articular, we always do 100% fixation. So key is to achieve 100% articulate fixation around the ICWM. This is the biggest concept. So we sometimes think we put a plate, ICWM doesn't reduce, it is acceptable, okay, we put the plate. This is not the problem. Key is to fix it 100%. So that's why the Mata put the classification for 1 to 3 mm gap, or 3 to 5, 5 to more than 5. So that's why they consider it as important to put fixation and absolute stability. So key is always learn. If you don't learn, definitely you will create a problem. So what advances so far this been created by these people who are working on this AO? And there have been advances in implants, some advances in instruments, and some advances in surgical technique as well. So implants so far we use routinely. I will show you some of the cases what we are doing, but recently they have introduced the spring plates. They are stiff, they are bulkier, but they have hooks around this distal part. Sometimes these posterior walls, which is the most common part of the ICWM fractures, doesn't hold with simple screws. So just put the hook here and leg it, and that will hold this. Sometimes posterior wall is comminuted. One plate is not that enough. You need more than one plate, so need 2 plates to fix it. And above that, you need to put some bridging plate. This is one. Second, we routinely see quadrilateral plate get broken every time, and we don't have a plate to put on a quadrilateral plate. If you go on medial side and quadrilateral plate, definitely you will put some screw inside the joint. So you need some special instrument or implant, so put on the quadrilateral plate. So this AO have sensitized this plates, and this part of the plate is lying over this pectinal, and this lying on the medial border of this quadrilateral plate. So this is how they designed these 2 plates. This is now commonly they are using only for quadrilateral plate fixation. So this is how it looks. If you put this around this pectinal line, so this will just hold to prevent this protrusion into the abdomen. So this is another advancement so far this people have done. This is another one. Sometimes they put angle guide wires. Some are there 2.5 mm offset. When you put some percutaneous screw from anterior to posterior, or when you open it and put the screw from anterior to posterior, you need some K wire to have some diversion. So to hold the fracture temporarily and then fix it. This is another advancement. This is key again. When you're operating on the pelvis, you need some retractors so that will guide you. That image should be clearly visible. So they design these carbon fibers retractors to put these all fixator and somewhere in the greater shading knob, lesser shading knob, with suction also attached on these. So these all are radiolucent, and that make this surgery more easier when you do the entry approaches. So this is the same. If you can put this here in the greater shading knob, somewhere, sometime in the lesser shading knob, with suction there, with the bleeding that you can continuously suck on this area. So this is how you can make your surgery easier. So this is another advance. This is collinear fixer. This is retractor. Now when you try to reduce posterior column through the entry approach, we sometimes we are unable to do it because we don't have this facility to go and fix it. So this is push-up system here. Put this part of the retractor into the greater shade notch and just hang on. So once you press it, so that will reduce the fracture by itself, and just hold it and hold with the K wire, and then you will just put the plate and hold with this K. So this is another luxury with this collinear. You have cannulated screws. This sleeve, you can put the sleeve inside and hold this, and you can put the cannulated screw as well. So this is another advancement so far that people have done in SMBBIT reconstruction. This is how you can put into the gradation knot. Okay, then you reduce it, and then from anterior to posterior column can be hold on the same approach if you have this facility. So this is another advancement in situ bender. Sometimes we put plate, but this doesn't fit into the cerebellum. So we need to bend it. So these are some small benders you need to put and bend on each C2. This is another one, like 2 screws, and they have hook inside, and that just help you to how you can bend. So another advances into the approaches. This Philip step cut osteotomy, when you need exposure, because step cut is somehow a stable fixation. If even you put simple 3.5 screw, that will be holding that osteotomy much easier. And some people are working on many approaches and percutaneous fixation. So another approach, when trained, we were looking for the Ilion approach, but nowadays everybody is doing modified stupa. Even both sides of the cerebellum fixation, pelvis combined can be treated with small incision around the entry abdominal wall and can do all fixation through this one single incision. So percutaneous fixation, I've seen few of cases with Professor Intagaf also, he was also doing it, but this is through this antegrade or sometimes retrograde and fixation when you do the undisplaced acetabular fracture with needing this total hip, so you can do fixation along with this fixation on the total hip replacement around this side. So I will show some of my cases. So this is posterior lip with hip dislocation. So we follow this conventional method. We just leg screw and put the plate. And that is the trick. We don't have at that time the spring plate. Still we don't have in Pakistan. Then we modified our technique when we saw there's one sometimes the screw was not that enough to hold it, and there was a failure of the dislocation later on. So we modified this 1/3 plate. We make the hook on the 1/3 plate, place it, put the leg screw here, and then bridge it. And again we modified. Sometimes we need a comminuted fracture here in the posterior wall. We put 2 plates first, and above 2 plates we put the bridging. So this is how you can use some conventional implants over this because we don't have facility for this. So see how it's united. So then in the posterior column fractures, again we are these all acetabular fracture are associated with some other complicated injuries as well. It's not a simple trauma. So this is all posterior column. Look at this all adolescent. And see this come after a few weeks and this was lying in the abdomen. So distal femur, same patient have a foot, same patient have a posterior column. And this is how he moves all his leg. But he still have a problem in the knee, the 90 degree, 100 degree and the flexion in the knee, but the hip is okay. So another patient with posterior wall, hip dislocation, some superior pubic rama here, some pubic rama here, posterior wall okay, mid-shaft comminuted fracture, distal fibula, segmental tibia, so almost everything broken on the side. So this is how the CT looks. So we did again simple conventional reduction by the residents and we just put the plate and nail it. So this is a very unusual case. So only 10 cases have been reported so far in the world with bilateral asymmetrical dislocation. One is posterior, one is posterior, one is anterior. And simultaneously same patient have the mid-shaft femur fracture as well. So resident did the good job in the emergency. They reduced both the hip joints in emergency. And we just went inside to put this was unstable. So we just went inside, put the plate and reduced this with the nail. So this is another patient bilateral asymmetrical hip dislocation with transverse fracture on right side, posterior wall, anterior dislocation on other side. So this is again the job was done by the resident. They did everything in emergency and after reduction they did the X-ray of the posterior wall and this all reduced, but this was posterior wall lying here. So we put this plate and see this conventional leg screw was there. So this is how he was walking. So this is another patient with a female. This is very rare to have female with acetabular fractures. So this is another entry wall with segmental femur fractures. And this is how we put the plate and put the retrograde nail in this case. We didn't fix the superior inferior pubic rama on this side. So bicolumnar fractures, again a difficult job. So we modify our technique. We were unable to reduce from the posterior, anterior to posterior. So we always use 2 approaches. One first the anterior side, then we put on the posterior side. We use both the approaches to fix it and get the 100% reduction on this side. So this is how he's walking and it's still 30 seconds. So this is another patient, the anterior wall, anterior column. This again is tricky with quadrilateral plate. So we put this 1/3 plate into the operator, this greater shearing notch and bend it. And above this we reduce this quadrilateral plate fracture and put the plate over the side. So this is again, reduction is excellent and this is how this guy is walking on this. So I must say advances in implants and instrument approaches are definitely, you need to learn with the time. And this is the key. If you want to learn, you must learn it. And this is what I feel everybody should do it. Because such an extensive trauma going on, nobody in our country is ready to follow the rules. And definitely you will have too many patients with this all disabling injuries. So I must say that everybody should around this, especially in Karachi, should know how to operate on acetabular fractures. Thank you very much.
Thank you, Dr. Badr, for a very interesting talk and talking about all the latest advances in the implants. Right, as suggested by our chairs, we're going to take a few questions for the pelvis and the acetabular part. So if there are any questions, please ask.
Yes, Nasir. Nasir.
Sir, it is not a question, a small comment. Badar Bhai has shown that there are a lot of advances going on all around, but without the advancements, we have produced this result, without using the advancing technique. If we will have all those advanced technique, what result we are going to produce? MashaAllah, these are extreme cases which Dr. Badar has shown, and I think it's very commendable, and we should learn and go out and learn these techniques and come and perform in our center. Thank you very much.
velocity.
Don't put arthroplasty. So I said we die early, so we have 60 years or more age. So we will put arthroplasty and fixation. Basically, avian is only related to the posterior wall dislocation. It's more, not with associated with the transverse fracture, not with the bicolumnar. Yes, arthritis is definitely there, so not the avian.
But you have to fix that, because to do a joint replacement, you need to have a good acetabulum bony contour to put a acetabulum cover. So they have to fix. There's no two things to that. But I was really worried because you should, at the time of surgery, should counsel them in detail that is going to happen in the long term.
Yes, we counsel always them. So we did more than 200 so far. So because that, this all is growing in a single day, we do 2. So this is how rapidly this trauma is basically progressing in the city. And everybody is referring, nobody can afford, this all free, nobody has paid a single penny in the civil hospital. It's all done free of cost, even the implant, everything is free. So people rush to the hospital where at least they got free treatment.
Right, thank you. Moving on, we're going to come to a topic which is a nightmare for every orthopedic surgeon at least. I'm going to start with Dr. Nasir Ahmed. He's going to be talking about fracture-related infections and their prevention.
Bismillahirrahmanirrahim. Assalamu alaikum. So I will quickly move on to the presentation. So I'm working in Liaquat National Hospital as a consultant orthopedic and arthroplasty surgeon. And obviously, my colleague said that obviously it's a nightmare, and everybody in our lifetime, every orthopedic surgeon is seeing infection. So what I'm going to talk about is what is recommended by the fracture-related infectious consensus group. I'm going to discuss about all that. So if we go about, so I'm going to go through the definition, how to establish a diagnosis, the importance of multidisciplinary team, the main treatment principles, and the factors which influence our decision-making in retaining the implant. So if we see a demographic, about more than 1/3 of the open fracture, tibia fracture patient, they get infected, and out of 3% going to be amputated. And because the fractures are mostly fixed in younger population, I mean, if they get amputated, it's going to be a loss to the society and a lot of socio-economic burden as well. As per definition, the AO Foundation and European Bone and Joint Infection Society propose a consensus definition for fracture-related infection. The definition is that as contrast to the CDC definition of SSI, or the PGI definition for prosthetic joint infection, the fracture-related infection is only a one-time incidence. So it does not have any acute, subacute, or chronic subdivisions as PGI. The reason being that FRI can take months to get shown. It's moving by itself. Can somebody hold it? Okay. So there is no subdivision. So for example, a fracture-related infection presents after 1 month, maybe after a year, maybe after 2 years, or maybe after 5 years if the implant is in. So whenever there is an implant which is put in for a fracture, and if it gets infected, it is called FRI. So this is the treatment algorithm for fracture-related infection recommended by the consensus meeting, and I'm going through this in my presentation. So once the patient comes to us in our OPD, obviously we take a history, clinical examination, and we send some tests to check for the and confirm our diagnosis. So the diagnosis, they have recommended that there is मेरी presentation खुद से चल रही है, please इसको रोकें जी, प्रॉब्लम हो रही है ना? आई एम नॉट कुछ भी नहीं कर रहा हूँ, खुद से चल रही है. डायग्नोसिस में हमारे पास द इंटरनेशनल कंसेंसस मीटिंग में हमें 2 क्राइटेरिया दे हैव गिवन. वन इज़ द कंफर्मेटरी क्राइटेरिया एंड द अदर आर द सजेस्टिव क्राइटेरिया. देयर आर 2 कंफर्मेटरी क्राइटेरिया. One is clinical and the other are radial and laboratory criteria. The clinical criteria is, one is if you see a fistula or a sinus which connects to the plate, and the other criteria is a purulent discharge with a visible pus. So that will confirm the infection. The second criteria is phenotypically indistinguishable pathogen which is identified when we take a deep culture. So that is very important. And taking cultures from FRI specimen or plate is very important. So how they recommend? They recommend that ideally before we take culture, the antibiotic should be stopped for 2 weeks. And while taking culture, the culture should be taken from bone implant interface. Thirdly, a no-touch technique should be used. At least 5 or more cultures should be taken. And for every culture, a new sterile set of forceps should be used. Superficial skin and sinus tract must not be sent for cultures. And swabs have a very low yield, so swabs should not be taken for cultures. The second, last criteria, confirmatory criteria, is the presence of more than 5 polymorphonucleosides per high power field. And this has a very high, more than 97% of sensitivity and specificity. And for my clinical practice, I do rely on this a lot because we have a frozen section available. So you take some tissue, send for a frozen section, within half an hour you get the result under the microscope. So once we are done with the confirmatory criteria, there are few signs which are other things which are suggestive. So the suggestive criteria for FRI is, one is the journal criteria as redness and fever, which are the local sign, and then any new joint effusion, then the radiological signs of infection appearing in the radiograph or a positive bone scan. These are suggestive criteria, but these are not confirmatory criteria. For example, if these things are present in some patient, it means that he might have infection. Then there are elevated serum markers. If all these things are present with elevated serum markers, then one should go for surgery. So once we are done with that, then obviously we will have to assess our patient, that what is our host like. For example, if whether the condition of the host is good or not, so we have to see the general condition of the patient. And obviously as an orthopedic surgeon, I cannot deal all the patient problems. So the systemic target for optimizing the patient with FRI is treat the malnutrition, stop the smoking, control diabetes, and control the cardiopulmonary status. We also have to look for the local wound condition and the vascular status of the limb, because if these are not good, obviously we are not going to be in success. And once we have done that, then obviously we are going to see it's moving by itself. I'm having problem in my presentation and it is moving by itself. So मैं अपनी बात पूरी नहीं करता हूँ, next slide हो जाती है. So there's a glitch in, there's a problem. So once we have done with the diagnosis and we have seen obviously that there is the patient is having infection and we have also assessed our host, then the next thing is the presentation of this patient in MDT. Now as we do, there's a concept of multidisciplinary team approach for oncology. Similarly, there is a multidisciplinary team approach for the management of an infection patient. Because obviously our patient is going to have diabetes and other problems. And we know that as an orthopedic surgeon, I'm not going to deal with it. So at least 3 people are recommended for that by the International Consensus Meeting Group. That is an orthopedic surgeon, an infectious disease specialist who has a specialty in dealing the musculoskeletal infection, and a clinical pharmacist. And depending upon the availability of other subspecialty, we can also include them in our team. So the case should be presented in MDT and the treatment then should be discussed and then followed after that. It has also been seen in the literature that if these patients and these surgeries are carried out in specialized centers, then the outcome of these patients is going to be improved. So treatment goal obviously is fracture consolidation, restoration of function, healing of the soft tissue, prevention of chronic infection, and eradication of infection as a final outcome. The antibiotic principles are 2. Obviously, when we are treating, we have antibiotic and we have surgery. For antibiotic, we have to decide whether we are going for eradication or we are going for suppression. For eradication, obviously, we cannot eradicate the disease with the implant inside the body if we do not have antibiotic which will penetrate the biofilm. And for gram-positive organism, that antibiotic is rifampicin, and from gram-negative organism, that antibiotic is fluoroquinolones. So we need to have these antibiotics with us in the armamentarium if we want to eradicate the infection. Then coming to the surgical management, obviously, if the fracture is healed, then the problem is simple: remove the implant and treat the osteomyelitis. But if the fracture is not healed, then we have to decide whether I'm going to retain the implant or I'm going to remove the implant. So the nutshell for that, obviously, there is no single criteria or time period that after 4 weeks or 6 weeks or 12 weeks or 1 year, you're going to remove the implant. So there are multiple factors. The main factors are, number 1, the patient's general condition. We have to see whether the patient is diabetic, how is cardiac condition, and the other things, obviously, which we have already discussed. The second important thing, how much time has passed since the implantation. So it has been seen that debridement, antibiotic, and retention of implant is going to be successful by 90% if the patient presents in 3 weeks. And thereon, as the presentation delays, then obviously the success is going to be decreased. Then it depends upon the stability of the fixation, then what are the antibiotic availability and the patient tolerance. So I'm going to summarize that retention. If I'm planning for retention, then what I'm going to see that my construct should be stable, the patient should present early, the patient should be in a very good condition, that the general condition of the patient should be good, and I should have availability of the biofilm penetrating antibiotic, then probably I will have success in retaining the implant. But for example, if the implant is unstable, then probably I should go for surgical debridement, remove my implant, put some antibiotic cement rod inside and stabilize the fracture, because if I will not stabilize the fracture, the infection will not finish. Then start the antibiotic and then look at the soft tissue coverage. If I require one, I should involve plastic surgeon. So about the cemented beads, obviously, there is very limited evidence that antibiotic coated plates and nails are going to help. But if we are putting a cement rod or beads in, then 4 gram of vancomycin or 2.44 gram of aminoglycoside per 40 gram of cement should be placed, and then a spacer made out of it should be used to control the infection. So lastly, once we have done that, obviously we will have to reassess the patient in our clinic along with our MDT team, solve patient problem. Most important problem in these patients will have is the side effect of the antibiotics. For example, they are on vancomycin, they can have creatinine problem, they are on other antibiotic, they will have other issues. And then obviously with my multidisciplinary team, we treat patient and reassess, and before we discharge the patient, we have to make sure that we have addressed all these problems. Thank you very much. Any question?
We'll come to the question sessions after the next talk. Like again, open fractures are a cause of infections, and I would like to ask Dr. Syed Khalid Karim to come to the stage and give his talk. Thank you. We started a bit late, so there's a slight alteration in our program. We'll be going to the online virtual talk from our overseas speaker immediately after Dr. Khalid, and then we'll have a combined question-answer session.
After this talk, we will take the...
Yeah.
Okay. Assalamu alaikum. My name is Dr. Khalid Karim. Thank you, Dr. Akram Sultan, for giving me the opportunity. The open fracture, basically the open fracture, the one point you people have to keep in your mind that the open fracture is an orthopedic emergency. And what is the open fracture? The open fracture, when the fracture site communicate with the outer environment, and if you have a soft tissue wound in the proximity to a fracture, it should be treated as an open fracture until proven otherwise. Why we discuss the open fracture as a separate entity? Because, again, same problem. Okay, so why we discuss the open fracture as a separate entity? Because there is increases chances of complication. The risk of infection already discussed by Dr. Nasir Ahmed, and soft tissue damages and the rest of the complication as well. So what is the goal of management? The goal of management is to prevent the infection and achieve bone union and restoration of function. So when we discuss about the epidemiology, the incidence, it is common, and 30.7 per 100,000 people per year. And the demographically, it affects the young population, the 45-year-old age. And most commonly, it involves the tibia and the phalanx. When we talk about the etiology, it results from the high-energy trauma, and most commonly, it occurs due to the inside-out open fracture. And it is associated with additional injuries in 30% of cases. One of the important points is about the compartment syndrome. The presence of open fracture does not preclude the occurrence of compartment syndrome in the injured limb. So, there's a universal classification, that is the Gastillo classification, in which we classify the open fracture into 3 categories, the type 1, the type 2, and the type 3. The type 1, the wound size is less than 1 centimeter, and there's a minimal contamination and muscle damage. In the type 2, the size of the wound is from 1 to 10 centimeter, and there's a moderate soft tissue injury. In the type 3, we have 3 subdivisions, A, B, and C. In the A, the wound size is more than 10 centimeter, and it results from the high energy trauma, extensive soft tissue damage, and contamination as well. But there is an adequate soft tissue coverage. The farm injuries are automatically classified minimally into the 3A. In the 3B, there is an extensive periosteal stripping. The wound requires the soft tissue coverage. In the type 3, there is a vascular injury, and the patient needs the vascular repair. The most accurate way to grade the open fracture is by the intraoperative examination. While taking the history, because it is an emergency situation, you have to keep the few points in your mind because it is a team approach to manage the open fracture. Obtain the information regarding the mechanism of injury, the location, and the timing of injury, and any pre-existing psychiatric problem, because it will affect the patient outcome. In the physical examination, assess the soft tissue damage. And the most important point is the size and the nature of external wound may not reflect the damage to the deeper structures. Check the neurovascular status. If you think there is a vascular insult, check the ankle brachial index, and it should be more than 0.9. If it is less than 0.9, you need the emergency vascular consultation. There are the few important provocative tests. If you suspect that there is a traumatic arthrotomy, consider for the saline load test or the CT scan test. Now the studies show that the CT scan tests are more sensitive than the saline load test for the knee joint. And the most important point is the photographic documentation of the wound, because it is an emergency situation and most of the time we forget to take the photographs of the wound. So in the imaging, of course, we all need the radiograph. There's a certain indication for the CT scan if you suspect any periarticular injuries and if you suspect the traumatic arthrotomy of the knee joint. But the key consideration, do not delay the wound care and antibiotic administration just because of imaging. So, from the management point of view, there's a two-part of management, one in the emergency department and the second one in the operating theater. Basically, the management of open fracture starts from the scene from the site where the incidents occur. But in this part of the world, we don't have this facility. So most of the time, the patient take the treatment after reaching the emergency department. And if the patient is fortunate enough, if the trauma center or the emergency department have this facility. So in the pre-hospital care, stabilize the patient using the ABCD protocol, apply the sterile dressing on the open wound, immobilize the limb by splint or traction, and transfer the patient to the trauma center. And if there is an active hemorrhage from the site, then control the hemorrhage from the site as well by just applying the pressure. In the emergency department, because most of the time in our setup, the treatment starts from the emergency department. So control the hemorrhage by applying the pressure or by using the tourniquet, give the analgesia, and this is the most important point, that give the antibiotic as soon as possible. There's a literature said that give the antibiotic within the 3 hours of injury, because the studies show increased infection rate when antibiotics are delayed for more than 3 hours from the time of injury. Now the next question is, for how long will you give the antibiotic? Continue for 24 hours after the initial injury if wound is able to be closed primarily. And continue for 24 hours after the final closure of wound if wound is not closed during the initial surgical debridement. So what type of antibiotic will you select? It depends upon the type of wound that you are dealing with. In the type 1, you will give the first generation cephalosporin. If the patient is allergic to the cephalosporin, then you can give the clindamycin and vancomycin or the vancomycin. In the Gastilo type 3, first generation cephalosporin along with the aminoglycoside. In the few centers, they recommend the third generation cephalosporin, and in some institute, they use the vancomycin along with the cefepime. There's some special circumstances. If there is a farm injuries, heavy contamination, or possible bowel contamination, then add high dose of penicillin or the metronidazole for the anaerobic coverage. If there is a freshwater wound, fluoroquinolones or the third or fourth generation cephalosporin you can add, and use the doxycycline or the ceftazidime in case of saltwater wounds. So, after giving the antibiotics, the next important component is the tetanus prophylaxis. It should be given in an emergency department. There's two types of tetanus prophylaxis. One is the toxoid and the second one is the immunoglobulin. For the toxoid, there's a universal dose that is a 0.5 ml regardless of age. And for the immunoglobulin, if it is a less than 5-year-old patient, give 75 units. If it is 5 to 10 years, give 125 units. And if it is more than 10 years, give 250 units. But the point that you should keep in your mind that the toxoid or the immunoglobulin should be given intramuscularly with 2 different syringes in 2 different locations. The guideline for the tetanus prophylaxis depend upon the 3 factors: the immunization history, the vaccination history, the date of most recent vaccination, and the severity of wound. So if the patient have unknown history of immunization or less than 3 doses, and you are dealing with the type 1 fracture, give vaccine only. And if you are dealing with the type 2 and 3 fractures, give vaccine along with the immunoglobulin. If the patient have complete vaccination history, that the patient is taking the 3 doses of tetanus toxoid, then you have 2 scenarios. In the type 1, no prophylaxis if last dose of vaccination within the 10 years. And give the vaccine in the case of type 2 and type 3 open fracture if it is more than 5 years old. So after giving the antibiotics, the tetanus prophylaxis, stabilize the limb, dress the limb, remove all the gross debris from the wound site, but do not remove any fragment in the emergency department. Place the sterile saline soaked dressing on the wound. There's a little evidence to support the aggressive irrigation or irrigation with antiseptic solution in the emergency department, as this can push the debris further into the wound. Now the surgical management. In the operating room, you will do the irrigation and debridement. There's a recent meta-analysis have recommended debridement within the 24 hours to minimize the risk of infection for type 3 fractures. And it should be within 12 hours for the type 3B open tibial fractures. Stage debridement is recommended after every 24 to 48 hours depending upon the type of wound and the level of contamination. During the irrigation and debridement, extend the wound proximally and distally in line with the extremity to adequately expose the open fracture. Then you have a few burning questions that is there any difference between the low pressure bulb irrigation versus the high pressure pulse lavage? Studies have shown that the low pressure bulb irrigation is less expensive than the high pressure pulse lavage and has no difference in infection rate and the union rate. The next is the saline versus the saline with the Castile soap versus the antibiotic solution. The studies have shown that the saline with the Castile soap has decreased primary wound healing problems when compared to the antibiotic solution. And what is the quantity of the fluid that you will need? It depends upon you will follow the rule of 3 for each type. During the debridement, you have to remove all the devitalized tissues and bony fragments in the operating room and remove all the foreign bodies and the contaminated materials. So then after it, you have to stabilize the fracture temporarily by using the external fixator. And what about the local antibiotic administration on the serial debridement? If you think there is extensive soft tissue injuries, there is a gap at the site, then you can put the antibiotic cement beads at the site as well. For the soft tissue coverage, this is the most important point, that the soft tissue coverage, you have to cover the wound as soon as possible. If you think that you cannot cover the wound right at the time of debridement, then you have to cover it within the 7 days, because after the 7 days, the odds of infection get increased with the passage of time. And if you cannot cover the wound primarily, you can use the negative pressure dressing. So the management of the open fractures, it is a team approach. We need a team for the proper management to cover the treatment from every aspect. Thank you.
Thank you, Dr. Khalid. Is Dr. Umraz online with us? Right, our next talk will be, just shuffle the sequence a bit because of we are running a bit late. Our next talk is by Dr. Umraz Khan. He is head of orthoplastic surgery at the North Bristol NHS Trust, UK. Dr. Umraz, can you hear us? Right, I think your mic is on mute. Can you unmute it, please? Your mic is on mute. Right, welcome Dr. Umraz. We can see your slides over here, so you're good to go.
Lovely, thank you very much. Can you all hear me now? Are you all able to hear me? Okay, I assume you can hear me. I'm grateful to the committee for this invitation and to Hassan Kashif for bearing with me and organizing this Zoom attendance. Unfortunately, we tried everything to get me to attend physically face-to-face with you guys, but I had other commitments and we couldn't change the dates. The previous speaker was very eloquent and gave a really good talk on the essence of what are the challenges for open fractures. And I would like to just tweak that a little bit and maybe discuss how we can improve outcomes. And hopefully some of you will find this insightful and educational. So I've got no disclosures, nobody is paying me to be here, and I'm not trying to sell you a product or an implant or anything like that. After this talk, which is brief, I've truncated it. I get a very many invites to give talks such as this in different healthcare systems, because people are keen to learn from how we in the UK, and particularly in Bristol, how we've improved the care of these individuals and how we coordinate it, and they're keen to learn from us. But the objectives from this talk, which is a shorter version of my big talk, is that we must appreciate this new concept of orthoplastic surgery. In the UK, we've embraced this. In the US, they're slowly beginning to do so, and as well as in Europe. And I'm hopeful that in Pakistan, they would likewise do that. As the previous lecture taught you, that there is a timeline. When you get a wounded limb, so this could be probably upper extremity as well as lower extremity, the clock is ticking. You don't have a lot of time, unlike closed fractures or closed injuries where you can get lots of scans, lots of opinions, and then do the right operation. In these set of circumstances, the time is against you. So you must have what I call a well-trodden path way in which to manage them. I'll repeat this again, the single most important decision that has to be made by the treating physician or surgeon is their initial assessment of the severity of the soft tissue and the hard tissue injuries, and indeed if there are any other visceral trauma. We do propose this and promote this concept of fix and flap, and I'll talk about that in a bit. And of course, we must consider outcomes. So this is a map of the UK, and in the left lower corner is the southwest, the one in pink. This is where I work, and in the southwest we have 3 major trauma centres. Remember, in the UK, we had no major trauma centres until about 10, 12 years ago. And like the American level 1, 2, 3, we've sort of followed the major trauma centre, trauma unit, and trauma facility as a network. The major trauma centre is where all emergency services are co-located. That's the principle. And in the southwest, we have 3. 2 are in Bristol, one is for adults and one is for children, and one is in Plymouth on the coast. When I first started in Bristol a long time ago now, I'm in the center and we've got 2 orthopedic surgeons, one to my left, one to my right. On the screen to your right is Mark Jackson, who is a well-known orthopedic limb reconstructive surgeon. And on your left is Mike Kelly. Mike treats the acute fractures with me, and Mark the bone infection cases. And together we set off on a journey to try and establish something in which we could improve the basic outcomes, like improving union rates, reducing infection rates, improving functionality. About 10 years ago, we moved into this new building. This is our new MTC, and we were able to construct the theatres set up so that orthopedic and plastic surgery were opposite and very close to each other in their theatre setup. That means that your equipment is not far away, regardless of what operation you need to do. We started off with a small team, that's me in the center with 1 plastic surgeon. We've now grown to 4 plastic surgeons and 4 orthopedic surgeons with fellows and specialist nurses. So let's look at outcomes. If you look at open fractures and you look at what the ancient outcomes were, this is sort of obviously medieval. You can see that in this drawing, someone's taken a leg off. A good outcome in ancient times was to actually survive the trauma. Why? Because the patient died from bleeding, usually, acute hemorrhage or hemorrhage at the time of amputation, or gangrene. Things have advanced now, and I'm sure you will hear a lot of very eloquent talks on modern technique and modern implants and ways to fix broken bones. So orthopedic implants have become more niche, they're becoming more sophisticated, circular frames have found a role, etc., etc. In soft tissues, however, in plastic surgery, we have also, sorry about the typo, soft tissue reconstruction, that should say, have gone from local flaps to free flaps. Now, if you look at the old traditional way that open fractures were managed in the UK, this is not atypical. And this is an old historic slide of mine, probably taken 20, 25 years ago. There's an external fixator and there's a wound laterally, and these were just dressed, wet to dry dressings, because all wounds, provided there's no necrosis or infection, will heal eventually. The skin is very, very good at that. The trouble is you end up with a very troublesome limb, even if the soft tissues have healed, and you get sinuses forming, the patient gets pain. So these are not great outcomes. And the way that plastic surgery is advanced is those wounds, we, plastic surgeons, can reconstruct them. So the time to healing is reduced for the soft tissue envelope. And either a mixture of local flaps where its tissue is rotated into the defect, or indeed free flaps, which is what this is. So this is just a skin. So this is how far free flaps have evolved. We no longer take morbid flaps like rectus abdominis or latissimus dorsi. These are old generation 1 flaps. We just take skin only with its perforating vessels. You can see an artery and a vein. And then under a microscope, we're able to stitch them together, enter side into the artery, end to end onto the vein. And if you look at why we're doing this, is because you look at the health impact of poorly managed extremity trauma. And I show you this meta-analysis, which came from the USA. And this is a diagram. So the general population, you can see at the top, if you can get up to health status score of 1, that means you're very, very healthy. And of course, 0 means you're dead. And in the middle of that table is beginning of non-union, so humerus, tib, fib, femur, etc. The impact on the patient is worse than having a heart attack if it's poorly managed. And I think these sort of things, these health studies, there are a lot out there, and this is why, although it's hard work, to get it right at the beginning is really, really important. So before we can start lecturing to people, we need to be clear on what a good outcome is. So if you save the limb, is that a good outcome? If the skin is healed and the bone's healed, is that a good outcome? Again, if the patient is not complaining of symptoms, and are they able to contribute to society by going to work? All of these, I think, can be argued that this is a relatively good outcome. The flip side of that is, should we also consider what a bad outcome is? The reason I say this is there are many healthcare systems where orthoplastic surgery can't be delivered, and unashamedly, the patients are taken to theatre multiple occasions where decisions aren't made, and this is piecemeal surgery. This is a bad way to manage your patients. If you do free flap or any flap surgery and the flap necroses, dies back, of course, that's black and white. It's a bad outcome. If the orthopedic strategy needs to be changed because the osteosynthesis is poor at the beginning, again, I would argue not a good outcome. If the patient has chronic pain, as a salvaged limb, but they can't use it, I think that equally is a bad outcome, because that often means they're not able to get into gainful employment. So what did we do to try and sort of negate these problems and try and face them head on? Well, the first thing we did, we set up a database back in 2011. All patients that came to our MTC were entered onto this database. And we don't get that many, but maybe 4 or 5 per week. And the database has almost 2,500 entries into it now. But at the time, I wrote this article in Injury, which said that really in modern trauma systems, to be effective in extremity trauma, particularly the complex ones, then I think the system has to have some method of accessing orthoplastic surgery. This was then popularized by the orthopedic community in the UK. It became very sexy to be part of orthoplastics. And of course, people were engaged with it. Trainees were interested to learn about it and come to our Center for Fellowships. And then multi-center studies have proven the effectiveness, the efficacy of doing the right operation, the right pathway at the beginning for these patients. So let's look at the timelines. We've been told really as a historical lesson that there's something called a 6-hour rule, where a traumatic, often a ballistic sort of injury is taken to theatre within 6 hours, based on animal studies where you can inoculate a guinea pig and then remove the inoculant hourly up to 6 hours. After 6 hours, infection establishes. So these sort of things are there, and limited clinical studies. And these are those two studies which reflect those that ethos. However, we don't believe in the 6-hour rule. I don't think it holds much scientific basis now in 2024, because there's an advent of very specific broad spectrum antibiotics. We know that this 6-hour rule has been debunked, particularly in places like Australia, where to get to a hospital can take you a day or two. And their outcomes aren't any different. And of course, there have been advocates since as long ago as 2006 for specialist center treatment of these patients. And it's really important because the time to debridement, so this is another thing of mine, we stopped calling it debridement, we call it a wound excision, because it graphically describes what the surgeon needs to do with the wound, which is to systemically excise the wound. So the time to wound debridement excision is absolutely critical to reduce one bad outcome, which is a deep infected non-union. In 96, 97, the British Association of Plastic Surgeons and the BOA produced a handbook, a little guideline talking about the management and how to improve care. And this was the first time really in the literature where it was shown you have to work together in a combined way and bury your egos. These patients don't belong to you. They are patients who you have the privilege of treating. Talking of privileges, I had the privilege of writing the update to that 97 document. This 2009 document came out. This was a bit more literature based, so and it's available on the website. It's not particularly difficult to get hold of. And this was the first time where we looked at the evidence for all of the things that we do when we have a patient with a traumatic wound. The 6-hour rule, again, we debunked it. We did this multi-center study looking at the time of initial debridement of wound excision, the so-called TIDE study, and it is safe to do it within 24 hours. The reason we did this was to avoid people or prevent people going into theatre and making mistakes, errors in the middle of the night. So the definitive reconstruction, should we do it at the time of the wound excision or later on? And there are proponents to say you can do it a fix and flap in the middle of the night, emergency sort of type of situation, and there are papers to support that. We do not want that, and I'll tell you why. So this case came to our clinic, it was referred to us for a third opinion. It was a guy's limb. He was a British citizen who'd gone to the States for a holiday. He looked the wrong way and got hit very badly. He got an open distal third fracture, and he was taken to a level 1 trauma center where you can see there's a segmental tibial fracture which had an IM nail, beautifully reduced, really good length. So the orthopod did a very, very good job. The wound, however, was neglected a bit, and he had a VAC dressing on for a while. About 12 days later, he returned to the UK, and he had that flap. So if you look at the flap, at the bottom, there are 3 sinuses that opened up, and he ended up with an amputation below the knee because he had a rampant infection. And this is another principle. Avoid definitive internal fixation if you cannot provide definitive soft tissue cover. We showed that if you look at the infection rates, the deep infection rates, you increase this by 4 or 5-fold if you do an IM nail in one hospital, put a dressing on, and then send them to the local plastic surgeons for a soft tissue cover. And the same with the union rates. And this has been written up, so it's in the literature if you want some evidence based to your practice. So this is what we recommend. Excise the wound within 24 hours. You can apply temporary dressing until definitive reconstruction. We favor staged reconstruction. It's safer. And again, we've written about this. This is in the literature, and it can be used from our orthoplastic center in Bristol. Yes, this is another reconstruction. So injury recognition, very important and very badly done. So this is a lady, an old lady who has got degloving of her leg skin. There's no fracture. So this is purely a soft tissue problem. What do we do with this flap of skin? Do we stitch it back, etc.? Trouble is, if you look deeper, there are thrombosed veins within the subcutaneous tissue. This is always bad news. So if you can inspect the subcutaneous tissue and there is thrombosed veins, this skin is never going to survive. You've got to excise that skin. Consider this case a very high energy knee, thigh run over by a tractor in a farm. He had a severe distal femoral fracture, open knee. You can see the lines there. This skin is never going to survive, and I opened this and excised this. You can see how much excision has been done. Medially, there was another track, and the question to me was, shall I remove this? Because you can put a hand in and get all the way in. Well, if you inspect it like I did, you'll see that the deep veins are intact. They're not thrombosed. So I left it. I resurfaced the front with a free flap, skin flap, and then the medial bit recovered. So it does work. And we've reported on the classification systems of degloved injuries. They're very, very capricious injuries, and I urge you to read that article. So here's a very very easy, difficult fracture. So this is an easy in that we know that this is severe. There's grass, there's stripping of the tibia, the muscle groups are contused. So this needs urgent trip to theatre, systematically excising the skin, the muscle, the bone, if it's needed. Obviously, the nerves and the vessels are left in situ. And then once this is excised, we can then grade this injury and make a decision. Is it salvageable? If it is, what type of reconstruction is needed in terms of fixation and flap coverage? So that one's easy. This is difficult. Now, there'll be some people in the audience who would stitch this up and put a nail in. There's a tibial fracture underneath there. This was a high energy crush, not segmental, single, but comminuted. And some of you will get away with that. And the problem is, if you look very carefully, there is a lot of contusion, bruising of the skin as the energy was imparted into the limb. And in our center, this is what we do. We excise that contaminated and devitalized skin, and then they get a fix and a flap 2 or 3 days later. So from this injury...
Excuse me, Dr. Imraz, I'm sorry. I think we are overrunning a bit. If you could summarize it.
This is my last slide. Sorry, I was getting to that. This is my last slide. Thank you very much. So to improve outcomes, you need a better injury recognition system or a way of documenting that. Disinfecting the wound by wound excision is what we recommend. You have to have lists like we do, which are dedicated, owned and run by orthopedic and plastic surgery. There are strict timelines. And if you have success in free flap surgery, it's incredibly rewarding. Thank you.
Right. Thank you, Dr. Imraz, for the very nice talk. I think we just covered 3 presentations regarding infections and the predisposing factors to leading to infection. We have time for 1 or 2 quick questions, if there are any questions.
Nobody has got a question. Can I
Yes,
do
please.
a suggestion? Nasir, your talk about infection, I think we need to do studies to find out what is the local infection. I think you and Badr and possibly Ahan can start doing cultures on initially when the patients come in to find out exactly what organisms we have got, because we always keep following European standards and they are not our standards. Our environment is different, our bacteria are different. We need to find out which antibody would be best in our scenario. I would strongly suggest with Badr and you combining together, and if you can ask somebody from Ahan to do a study, start this study and find out exactly what antibodies would be better in our scenario. I'm saying all this because last year in the knee meeting, Parvezi from America said that you should use anti-tuberculous drugs for 15 months plus sometimes 18 months. And this our professors, Professor Qazi and Professor Salman, kept saying it that 6 months is not right in bones and joints. You should always use them for 15 months at least. And I have been doing that and it's always successful. See, they found out now and our professor was using it 30 years back. So we need to do our own studies to find out. Secondly, whether we have been doing these flaps all the time, our surgeons do it themselves. And now this specialty is coming in. We should start producing our own papers. And I suggest to the trainees who are sitting here, I think one other specialty you should rotate into it is vascular surgery. We had Dr. Dilip. Is he sitting here, Dilip? No, he's not here. So we had Dilip and he had vascular experience and it made a big difference. Whenever we had problem, he was there to help us out. And that makes a big difference. And I think Anis Bhatti is sitting here. Rotations in orthopedic should be, I think, one plastic and one vascular. I think we should make them compulsory, and that will really help the orthopedic surgeons in the long run. Rather than going to any specialty, they should be asked to go into plastic and vascular. Now you've got a full department, so they can rotate and learn. Then you've got your own surgeon in your theater who can deal with it rather than waiting for the vascular surgeon to come and do surgeries for you. Yeah. That is so nice.
They are doing such a wonderful job for tumors, for trauma, for every time they were available. So,
but you remember
in
when
our MS program, we were there and we sent our resident who did the MS for 3 months in vascular surgery and the plastic. But in FCPS, and recently in the faculty meeting, it was decided that our resident will go and have a training in the vascular surgery as well.
Vascular and plastic, I would suggest that they should be made compulsory rather than going into anything, because those two specialties really help the orthopedic surgery department and the orthopedic surgeon himself who can do so many things with that.
But sir, I must comment on the Dr. Umrah's presentation. It's such a wonderful message, and I have gone through all these literature what he have shown with the paper and POA. Such excellent guidelines. Unfortunately, in our center where we are working, we have every day 10 open fractures.
Yes.
And we don't have enough people to do plastic surgery in every patient.
That's why I'm
such a crush injuries, we have shown yesterday we have 400 amputations in last 2 years because of all these crush injuries in open. So we need to follow all these guidelines as well, because such an excellent guideline they have written, and they have protocols within 5-7 days you have to cover, provide the flap, but unfortunately we have very limited plastic surgeons. So we need to train our own orthopedic surgeons as well to at least do basics, not the microvascular, but at least the basic flaps like gastrocnemius. You can do rotate the soleus, so somehow you can cover this. So you need to train the people who should.
That is what I am saying. We have been doing them.
Discussion we will do later. These are the questions, and there are a lot of papers as well. आपको नहीं रोक सकते.
आपकी मोहब्बत है सर. Can you all hear me?
Yeah.
I am a practicing maxillofacial surgeon, and we use a lot of BIP dressings, which is bismuth iodoform paraffin paste dressing. And we also do, and we see a lot of complex traumatology, patient traumatology, gunshot, RTA, and you name it. And the most complex and the most challenging patients come to my unit. And alhamdulillah, I have a very positive experience of using BIP. It can be left into the soft tissues for a long period of time, prevents wound healing, prevents infection, and promotes healing at the same time. And I was just wondering, Dr. Umrah, you've shown a wonderful work. Yes, I totally agree with what Dr. Badr is saying and all the seniors are saying. Yes, we are overburdened with the disease and the patient's workload. So my humble suggestion and your comments with all the orthopedic surgeons would be to use BIP and see the results. It can be left inside the tissues for even 1 week, keeps the wound amazingly clean. We use facial trauma patients, use BIP, and if possible, we try to provide the best possible treatment as soon as possible we can, but again with the limited a small team and the capacity which I have, sometimes it is not possible. The delay leads to infection. The delay leads to malunion, non-union infection, and so on and so forth. So perhaps BIP is something which is amazing. I call it the wonder drug. So your comments and all the orthopedic surgeons, sir.
Thank you, sir. And thank you, Dr. Umar Daraz. Next, please go to the next stage.
Right, we are going to move on to the next, because of the shortage of time, we are going to move on to the next talk. I would like to invite Professor Zamir Sumro to please come and give his talk on the role of Ilizarov in deformity corrections.
Thank you, Dr. Akmal. It's a great honor to present before your teachers, as Professor Bhatti and Professor Maratib are here. And I must congratulate Dr. Sabir Maimun and his team for organizing such a wonderful conference. This is the second time. And I would wish that in upcoming Ortho Traumacon, there should be more sessions on complex trauma, particularly the skeletal trauma. So today, I am going to talk on the role of Ilizarov in deformity correction. Is it working? I have greetings from my native town, that is Mohenjo-daro. And I'm going to present what is history of the deformity and its type, its causes, methodology of the treatment, and what are the principles of Ilizarov. What is deformity? The deviation from normal alignment in frontal, sagittal, and axial plane. But it is not only deviation. It is creating disfigurement, difficulty in movements, and disability. If it is for a longer period of time, disability not, deformity not, it is. What are the types of deformities? These are the angular deformities, translational deformities, rotational deformities, axial translation, which may be shortening and even limb length discrepancies. These are the common types of deformity around the knees. What are the causes? These are the general causes of the deformity: trauma, malunions, infections, epiphyseal arrest at the growing age, metabolic disorders, osteoarthritis, rheumatoid arthritis, Blount's disease. These are the basic causes of the deformities which we come across. These are the treatment options. Non-operative, especially in the young age group, the manipulation and braces, especially when you have foot deformities or other deformities. And operative treatment, which addresses the soft tissue releases, osteotomies, guided growth with the epiphysiodesis, gradual soft tissue and bone destruction by Ilizarov, and fixed-assisted smart correction. What are the principles of correction with Ilizarov? The most important is the human mechanics of the human body. And this is the alignment. When you refer to the alignment, it refers to the collinearity of the hip, knee, and ankle. And these are the mechanical axes of the lower limb, which always go from center of the hip to the center of the ankle. When it is deviated, it means it is a deformity. This is the normal anatomical and mechanical axis of the femur and tibia. And this is the deviation of the mechanical axis due to deformity. You can see the mechanical axis deviated due to deformity in the knee, in the femur, or in the tibia, you can see. These are the different sources of mechanical axis deviation. And these are the deformities: mechanical axis deviation due to femoral deformity, due to tibial deformity, and inside the joint, all producing different deformities. And we have to apply the male alignment test to see the cause of the deformity, where accurately apex of deformity is. Then we have to sort out or plan the osteotomy, where we have to do the osteotomies. These are the different osteotomy rules for doing the osteotomy and correction the deformity. And when the level of osteotomy and hinge placement, when the apex of deformity is metaphyseal, the osteotomy done at the level of apex and hinges placed at the level of apex, you can see here. These are the normal ranges of the deformities. So before showing few examples, I must thank to my mentor, Professor Yunus Sumro, Professor Marizo Katani, and I pray for the great soul who helped us a lot, and that's why we are on the stage, Professor. So few examples for correcting the deformity with Elizarov. You can see this is a young patient who has an injury at his childhood, who presented with this deformity. You can see the complex deformity around the knee, and you can see the gait. And this is the different views. And this is the application of the frame according to the assessment of the deformity. This is the proximal hinge, placement of the hinges. This is the motor for correction of the deformity. And this is after surgery, application of the frame. Gradual distraction for correction of the deformity. This is the correctness of the alignment. After removal, you can see it is aligned in both planes if you're drawing the mechanical axis. And this is the clinical outcome of the patient. And now his limb is aligned, and he has a limping due to ligamentous issue. This is young child having a epiphyseal injury with a deformity around the knee with scar tissue and limited. This is the application of ring fixator. क्या हो रहा है भाई? ये ऑटोमेटिक चल रही हैं. Okay, so this is application of the frame for correction of the deformity. And I'm sorry for this. नहीं आपके इसमें गड़बड़ है ना, एक दफ़ा दबाते हैं, चार दफ़ा दब जाता है. So this is correction of the deformity. You can see the alignment. And after removal, the deformity is fully corrected in a child. This is the range of the knee and walking of the child. Another complex deformity around the knee, you can see from the clinical picture, and also how huge and complex deformity. This is the only segment of the knee. This is all the fibula, and this is non-union. So complex deformity around the knee. This is the application of a frame in both planes for correction of the flexion contracture here and extension contracture here with non-union. Gradual correction and alignment. This is another patient with fixed flexion contracture of the knee. Application of the frame according to principle with hinge placement, gradual correction of the contracture, and this is the correction. Another patient with deformity, that is CPT, and this is after correction. So in conclusion, I would like to say the deformity correction following principles of correction with Elizarov ring fixator is a viable option for gradual correction, but it needs a comprehensive pre-operative assessment and planning and post-operative management with adequate counseling of the patient, and it needs a team effort. the message, it is important to identify and treat the correct deformity and not create a deformity in effort to treating a deformity. An isolated deformity in one bone should never be treated by a corrective osteotomy on another bone, and corrective osteotomy of the tibia, which was done in tibial. So these are my patients. Thank you.
Thank you, Dr. Zamir. I think
you.
we'll be taking questions in the end of the session.
Thank
now,
you.
Please. Thank you. I'd like to invite Dr. Ziaur Rahman. He's a very known vascular surgeon from Aga Khan. He'll be talking on extremity vascular injuries, challenges and updates.
Thank you for the invitation. The challenge has started. And it is really a great. So I start my talk. There are some descriptions of the vascular injury. I will not waste time. Probably we will waste time in here. Yeah. So there are a lot of challenges in dealing vascular injuries. I have been practicing last about 15 years. One of the major challenge is the burden of the disease. And these are usually the young patient, and they actually go from one hospital to another hospital before reaching to a vascular center, before they can get a vascular repair. The golden time period, that is within 4 to 6 hours, has been lost. And that is the biggest challenge I see. And for that, we need to increase the awareness. We have to increase the man force. We have to increase the skill. And we have to develop more centers to deal it up. The second challenge which we find as a vascular surgeon is they are distracting injuries. For example, a patient comes in ER with a mangled extremity, whole of the attention will go to that mangled extremity. And it is very likely that their abdominal and chest injuries are going to be neglected, and they need attention, because if the major abdominal or thoracic injury is not going to be dealt, patient can lose the life. Third is the identification of the vascular injury, for which we need high index of suspicion that this patient presenting with trauma, lying on a side bed, may be having a vascular injury which needs identification and need to be dealt. And simple thing is required, that is the clinical examination. The hard signs and soft sign. Every surgery residents know what is the hard and soft sign, and the importance of those that hard signs mandate early exploration, means they have the vascular injury and that mandates early exploration. If there is pulsatile bleeding, if there had been expanding hematoma, if there has been a thrill, palpable or audible at the site of injury, or the patient has very cold limb, they are having a vascular injury. And no time should be wasted in doing unnecessary investigation, doing CTA to confirm that injury, and patient needs immediate exploration. And there are some soft signs of the vascular injury which needs to be remembered. For example, if there is asymmetrical limb temperature, the pulses are weak or asymmetrical, or there is injury to anatomical related nerve, or there is history of the bleeding there. These are the patient which needs investigation in the form of CTA to identify those source of the injury. And the high suspicion, as an orthopedic surgeon or a surgery resident, you should have to remember there is certain pattern of the injury which harbors vascular injury. For example, if patient present with shoulder dislocation, there is high likely axillary artery injury. If there is supracondylar humerus fracture, brachial artery injury. If there is knee dislocation or tibial plateau fracture, popliteal artery injury should be considered. And then they need to be sent to a center which can deal these injuries quite early. But principle remains the same. Life takes precedence over the life. limb. And when we have to make a decision between the limb and the life, we have to take consideration of the life first. And we have to adhere to the protocols of the ATLS. This is simple algorithm for the ER people to follow it up. One best way to identify vascular injury is use ankle brachial index, and that is simple measurement of the highest systolic pressure between the injured and the normal vessel, normal limb. If it is less than 0.9, patient may be harboring the injury. So if patient is having hard sign of extremity vascular injury, they need to be taken to OR. If there is less than ABPI, they need to have investigation to identify it up. Then a major challenge comes whether the limb is salvageable or not. Although we have mangled extremity score, which has 4 components, which shows soft tissue loss, shock, age, but it is usually an individual decision. And if patient present late, that becomes usually patient may end up in amputation. The principle of vascular repair is the planning. What you have to plan. Plan is control of bleeding. You have to save the life first. Then you have to get a proximal control. You have to reduce the ischemia. And then you have to cover it with a good soft tissue. So always think of where you get proximal control, from where you can get distal control, how you are going to deal the veins, how you are going to deal if there is orthopedic injury or bony fracture, how to do it up. So we usually use a wide exposure. I use longitudinal incision that give me a wide exposure to get a proximal and distal control. I always identify the site of the injury after getting the control. I debride the tissue up to the healthy issues when the tissue is there. And then I use embolectomy catheter. Embolectomy catheter to remove the clot, to restore the circulation, and put local heparin. And then I restore the circulation. Make a decision whether this is a candidate for damage control or definite repair. If it is damage control, then put a shunt, fix the bone, and if it is definite, I repair it with vein. For the large arteries, like axillary, femoral, iliacs, I go for prosthetic graft, but for the smaller one, I use native graft, maybe long saphenous vein. And that should be considered whenever you are planning it for the vascular repair. And primary repair is usually I do for less than 50%, and if there is more than that, I go for interposition graft. And it should be tension-free repair. There is areas which has to be considered that if there is combined injury, for example, vascular and orthopedic, who goes first? We have a meta-analysis which shows that fixation, vascular versus orthopedic, does not affect the amputation rate. Our practice is that we get wide exposure, we repair the artery, and we stay in the OR. We talk with our orthopedic colleagues who are very intelligent and very cooperative. They place a fixator, and we have never a problem. And at the end, we close the wound together. And that leaves a very good outcome. And then never to forget that patient may be candidate for fasciotomy, and especially in those patients who present late, who have a combined injury, who have arterial injury which has required repair. So never a vascular repair has ended up in amputation. It is usually the extent of soft tissue injury, patient comorbid conditions, or ischemia time, which is long, that leads to the major amputation. So there are 3 issues. How functional are those limbs? Number 2, what is the outcome in children? And can we use the prosthetic graft or not? So this was one of our studies in which we checked the functional outcome of the patient who have salvage limbed. And we have 95 isolated injury patients, in which 75 patients have arterial repair, and out of them, 73 patients have limbs saved. And when we check the functional status, their functional status was quite good. So in a selected patient, If prompt repair is done, it results in a very good repair. Children present a special problem. They have small vessels that goes into spasm. What is their outcome? This was our experience that out of 1,718 children presented in our ER, and out of every 23 children, one has vascular injury. And when we repaired them all, they have 92.6% salvage rate. With sticking to the general principles, the outcome is quite good. Then, what is the outcome of using the prosthetic grafts? So we have 40 popliteal artery injury repaired, 20 by veins, 20 with prosthetic graft, and we found no difference in outcome of those patients. This study was very important in our setup, where patients present in unstable stage, late, and we have no time to dissect the vein. So this study was quite good. But for a vascular, for a orthopedic and general surgery colleagues, I will say damage control is very important. And 2 points I will consider. Whenever you have to do a damage control, do not place a shunt in a loop fashion. Do not place a shunt without an embolectomy. So always get a proximal distal control, do embolectomy, remove the clot, put a shunt which is straight. It may be any tube which is available in OR, and tie it about 1 to 2 centimeters away from the edge. And that is enough. Let the patient stabilize and shift the patient to a center or call a vascular surgery colleague, and that will save the limb and the life of the patient. Thank you for that. Assalamu alaikum.
Thank you, Dr. Thank you, Dr. Zia, for your excellent talk. Right, we're going to start with our series of debates now. I'd like to invite Dr. Mehroz Zamir from Patel Hospital and Dr. Osama bin Zia from Darul Sehat Hospital, both of them to please come to the stage on the white chairs. The first debate will be the DHS versus PFNA, choosing the best for hip fracture fixation. Dr. Mehroz will give the first presentation. Please, both of you please sit on the stage. And Mehroz, आप start करेंगे please.
All right. Bismillahirrahmanirrahim. So, I'm talking about a very, very, very old implant. Everybody in the orthopedic community knows about it. This is the first one that they get used to, and still cold. All right, you cannot abandon it. That's what I'm talking about. So, in order to defend this, I can use all the statistics, data, and analysis, but it's mostly quite confusing for me. And most of the people who are present obviously have been sitting here for a very long time, and they will also get confused, and probably this will be the end result. So let's skip that and talk about the facts. So what can be, so where does the DHS stand? In the hip fractures or the proximal femoral fractures, this is the spectrum of injuries that the DHS can be applicable or can be utilized with. My colleague will be defending PFNA. I think this is not the complete spectrum that PFNA can cover. Coming to the simple pertrochanteric fractures, a DHS may be more than enough to stabilize the fracture and achieve a good union. You can see what is the mechanism. It's the sliding hip screw mechanism, the sliding that can compress the fracture and get a good healing if you get the reduction right. But what happens in the cases of PFNA, what problem is, most of the people, they do not, they underestimate how to make a correct entry, and they get inside the fracture zone. They make the entry to the fracture zone, and then the fracture is distracted. So the nail tends to actually distract the fracture, and it's a very cumbersome situation where the nail will not allow the healing, and the helical blade will not provide a sliding mechanism. And these can be, these can be the outcomes. The helical blade can cut out, then can migrate in the pelvis and erode the hips as well. A similar situation, the helical blade can pose a lot of stresses at the nail when it is the weakest from where the helical blade is passing, so it can break. This is one of our cases of our seniors. It was then salvaged with a varus deformity and compression and a proximal femoral LCP, and eventually united at 5 months. So how it is corrected, I will help my colleague. go a little more medial, get the entry right, involve the fracture, go medial to the fracture. But there are certain situations that it is not very easy. So, coming to the comminuted types. Comminuted pertrochanterics can be further stabilized with the DHS very easily. And even if you look at the rightmost area, this is not a fracture that can be stabilized with the PFNA. It's a 150-degree poliomyelitis patient, post-polio deformity patients with a valgus angle and a 150-degree DHS was useful. So we have a variety of options available, not the case of the PFNA. We have 135, 150, even a variable angle. And a pediatric DHS is also available that can be used for pediatric population. So the spectrum is very broad. Coming to the unstable types. So obviously not very much recommended. I would definitely agree with that. But if you get the reduction right, you can sometimes get away with situations like these as well. So the next question comes, how about these ones? So we still have one trick up our sleeve, which is called the trochanteric stabilizing plate. And if you get the reduction right, hold it with K-wires, and then apply a trochanteric stabilization plate, that will buttress the lateral collapse and will prevent further lateralization of the cortices. And you can still have some rotational stability with an additional screw. You have also, we have an option of locking type of TSV as well, which can provide some locking screws into the lateral buttress fragment, and that can provide some additional stability. So what's the problem with PFNA? Another problem that you see, these are short nails are straighter ones. And with the passage of times, the elderly, the osteoporotic females and males, they have a curvature of the femur, which is increasing with the passage of time. And these nails, they get impinged on the anterior cortex tips. And this is not our case, but it's a case from the internet. You can see the guy was very smart, and he stopped putting the nail further down, and he left the screw slightly superior as we would have wanted it. We would have wanted it to be further down, but he knew what the risk he would have faced. Sadly, our resident did not recognize these kind of situations sometimes. So what happened is he used a larger nail and banged it in all the way in, and it caused a kind of a stress onto the femur. And when the screw was inserted, the crest gave way. And within a week, we had a catastrophic failure of the PFNA, and we had to salvage it very early. Another problem that can be there with the PFNA is that it has a very large fragment, large proximal segment that is in the 70-degree valgus, and it is a 17 millimeter diameter. So this was a fracture that was, the lady was treated for concomitant neck of femur and a femoral shaft fracture. Now you can see we had to leave the nail up, because if you would have tried to bang it further down the canal, it would have created a lateral split of the femoral shaft. Coming to the neck of femur sides, so obviously cannulated hip screw is the best one, but PFNA is not applicable at all, while DHS can still provide some special consideration. There is some special consideration like the Powell's type 3, where the dynamic hip screw can help you out, because the vertical forces cannot be withstood by the cannulated hip screw. And in the similar case that you can see, what happens is the force is vertical, but it is translated into a compressive force with a fixed angle device like a dynamic hip screw. A similar case where we had a very comminuted fracture of the right side of the neck of femur, and actually it was an open fracture of the femoral shaft as well. So obviously the nail was out of the question. This is, sorry for the bad x-rays, but this is the type of comminution we had. And what we did is we stabilized it with a dynamic hip screw along with some derotation screws, and applied an external fixator bypassing the DHS. And when the wound healed, we just went in, removed the X-fix, and later on we removed the plate of the DHS and applied a longer plate and stabilized the fracture. So it was quite easy. So in summary, DHS is still the gold option. You cannot avoid it, And obviously, it's better to have some more armamentarium at your back. Thank you.
Right. I would now invite Dr. Osama to give his defense of the implant that we use.
Assalamualaikum. My name is Dr. Osama Binzia, and I do agree with my colleague Dr. Mehroz that the implant complications happen to any implant, but you have to be smart enough to choose which implant is better for which fixation and which indications. So it's always a debatable challenge that whether we have to use PFNA or whether we have to go towards the DHS. So it's a debatable topic, but it's not controversial, I must say. So we will talk on some scientific grounds and not just the implant. As you know, the main indication for the DHS or the PFNA is basically the stable intertrochanteric fractures or the unstable intertrochanteric fractures or the intertrochanteric fractures with subtroch extension. So these both implants can be used in these indications. So talking of the hip fractures, as you know, the hip fractures are a major burden towards society, and it is estimated that by 2025, 2.6 million people will be affected by these intertrochanteric fractures, and by 2050, 6.25 million will be affected because the population of elderly is increasing in the Western population. And it is also estimated that the hip fractures comprising the intertrochanteric fractures is nearly 50%. While we talk about the developmental history of PFNA was first invented as PFN, which was developed by the company franchise AO in 1996, and it was conceptualized as a less invasive alternative, especially for the treatment of the unstable intertrochanteric fractures and subtrochanteric femoral fractures. And then another invent was made in the PFN, that was the PFNA, which was invented in 2003. And why it was introduced? To keep your construct more stable. And what special was that the helically shaped sliding column blade design, which was providing an increased contact area between the bone and the implant. And it was mainly induced to prevent the cutouts, which was seen in the previously, like the DHS and the PFNs. So this is some instrumentation of the PFNA, where you can see there is a specific helical shaped spiral blade, the compression nut unit, and this is the aiming device, this is the insertion handle, and this is the end cap with this screwdriver. The special thing about this end cap is that it further enhances the construct. What happened with the enhanced construct, that it fits into the helical blade and prevents its rotation furthermore, besides its construct stability. And also it prevents the ingrowth of the bone into the nail. And this is the full form of the construct, which is present in the mannequin form. Now, what was the purpose of design when already DHS was working? It's an evolution in the orthopedics, and the persons who are not abilized, they get retained back into the goldstone stages. So the main advantage of PFN is that it reduces the surgical trauma which is inflicted to the bone and soft tissue. And the main thing about the PFN is that it is an intramedullary device, and the shaft fixation in the PFNA is closer to the center of rotation of the hip. And what it causes, the load is transmitted to the femur along a more medial axis, which results in a shorter lever arm. So here are some scientific points which I want to highlight, which make a comparable between the DHS and PFNA. Number one is the mechanism difference. As you know, the PFNA is an intramedullary device, and it has some anti-rotation features which prevents the rotational malalignment of the fracture fragments, while in DHS it is lacking. Second point, improve the stability. Because of its anti-rotational stability and its design, and helical blade offers a good purchase in the femoral head as compared to the DHS, and it helps in reducing the risk of implant failure by offering the better fixation in the complex fractures, as I have indicated in this AO classification. Again, the reduced risk of malunion or the non-union. Due to its design, the anti-rotation features helps in maintaining the fracture alignment. Next point, less surgical time, as if the PFNA is given in the hand of an expert surgeon, so he will take a less surgical time to induce it into the fixation. because of its streamlined procedure and the fixation handling. And also a minimized blood loss as you do it in a minimal invasive way, so it offers the reduced blood loss during the surgery as compared to the DHS. As about the cutouts, both implant have some cutout rates, but the PFNA has lesser cutout rates than the DHS, and better functional outcomes in terms of Harris-Hipp scores. It occurs due to the fixation stability and reduced risk complications. Another issue which I want to highlight is a telescoping issue. What is telescoping issue? It is an issue in which both DHS or PFNA starts to collapse or move inwards, leading to the shortening or the misalignment of the fracture bone. And why does it happen? It happens because of certain factors. And what are these factors? Inadequate fixation by a surgeon, the poor bone quality, as the osteoporotic bone is a poor bone quality bone, and the fracture alignment is not maintained peroperatively, and if the device design is not chosen appropriately, or the post-operative complication if occurs like infection, तो इसकी वजह से telescoping issues जो है वो raised हो जाते हैं. Here is a diagrammatic presentation which is showing you the example of a cutout. If you induce DHS in an unstable variety of intertrochanteric fractures, this telescoping issue is much more as compared to the PFNA. As it is an angular stable device PFNA, so it causes less telescoping issues. Here is another diagram. This diagram is showing the nail and the helical spiral blade. The anatomical design of the nail allows the insertion at the tip of the greater trochanter, as Dr. Meros has already indicated. It allows the greater fit-in and the bone contour more as compared to DHS. And while we talk about the helical spiral blade, this blade got impacted into the femoral bone, so it causes a lesser amount of bone loss or a bone eating ability of a leg screw as compared to this helical spiral blade. So this is a point which it is not in favor of PFNA, but again I would say that if an expert is doing PFNA, so he can or she can reduce the surgical time and also the intraoperative fluoroscopy time, which is it is a minimal invasive approach, so the time taken into the fluoroscopy and the more shots will be taken in a minimal invasive approach as compared to the DHS. Working. Okay. So here is a study. It is a comparison between the DHS and proximal femoral nail, in which unstable variety fractures were taken and multiple factors were considered. It is a retrospective study of a 5-year study. More than 60 years of age of people are considered in this study. Multiple variables were taken like incision, operative time, the blood loss, the post-operative complications, the hospital stay. All these findings were statistically insignificant, but the PFNA had upper edge over the DHS. But when it comes to the post-operative hip pain or the post-operative Harris-Hipp score, the outcomes were more preferable while using the PFNA as compared to the DHS. Overall study also indicated that the PFNA fixation might be slightly better than DHS fixation for unstable intertrochanteric fractures. Here is a systematic review and a meta-analysis of the randomized controlled trials. From 286 identified trials, 12 RCTs were eligible for the inclusion. And this RCT is indicating the overall conclusion is that the shorter operative time and less intraoperative blood loss was seen while using the PFNA as compared to the DHS. But however, no significant difference was seen for the post-operative complications. But again, the PFNA always had an upper hand over the DHS in terms of complications and less of intraoperative time and blood loss. So my take-home message is that it's an era of evolution, and the things are changing both in the world and the field of orthopedics. So we have to induce ourselves and get upgraded ourselves. And this is a smart implant PFNA, and we should make it in our practice. And it is the future of orthopedics and the trauma care. Thank you.
Thank you, Osama. I think that was a very interesting debate from both of you. I think there is no correct answer to it. Both have got their own indications and uses and their pros and cons. I think in the next Traumacon, we will introduce the TFNA and the newly introduced proximal femur bionic nail also. Right, thank you. Right, we'll move on to the next debate. I'd like to invite Dr. Kazim Rahim from Liaquat National and Dr. Naveed Khan from JMDC to please come to the stage. This debate is on the topic of to save or sever, navigating the critical decision between limb salvage and amputation. Dr. Kazim will have the floor first.
Assalamu alaikum everyone, good afternoon. So thank you very much first for inviting me over here. My today debate to save or severe, navigating that critical decision between limb salvage and amputation. So my talk will be save the limb. First of all, welcome you all to Karachi, the 5th biggest metropolis city of the world. We have a beautiful seaside, beautiful high-rise buildings, old ancient building embedded with that. And this is known as a city of light, reason Karachi never sleep. So what other that problem? Contrary, what are the issues? This what we are seeing on the road. Because of lack of infrastructure, transport, that's what we have to face. And these type of injuries that the patient come to us. Again, the lack of following the law and rules of the road, the bus coming down from the flyover on the car, there's a mass injuries with that. Of course, overcrowded roads, that what you see, and then lack of infrastructure, that what we have to deal with it. What else? This is a beautiful video that's regularly we are encountering on the roads. See this heavy vehicle striking this bike, but at the end he is very lucky. He is coming out of it. So that's not the luckiest thing that we are seeing it regularly, but we have to save the life of these people. Karachi, we all know this is the economical hub. So that's what we are facing daily. The limbs, amputated limbs. Okay. So amputated limbs that coming to our emergency very regularly, and that's what we have to deal with it. This has been transacted because of the road traffic accident, because of the industrial hazards. So where they have to go? They have to go to the level 1 trauma hospitals. So what are the options? These are the few of the options. That's so I am too fast now. Thank you. So these are the level 1 trauma hospitals. That is for these type of patient mass disasters that's coming, where there is equipment, there is a trained and skilled surgeon with a multidisciplinary approach to save the life and the limbs. We know there's 3 peaks of that. First, when there is a strike, the patient of the maximum injuries that has been, we can't save the life. This is what we all have to strive to save the life in the second peak. That is a golden hour. That's maximum, giving them the best treatment. You can save the life and at the same time the limb. So this all the approaches, trauma team, where you keep calm and damage control, stabilize the patient, and at the same time you can save the limbs. And then that's what can be done through the ATLS protocol. That's what we always, we all should be known of. We should learn about it. So after that, the secondary survey, what we do to assess about the level of the injury that the patient might have, that will able for the prognosis, outcome, and its management. So these are the closed wound, grade 3 type of injuries. Patient frequently coming with us with this type of vascular injury. These are the type 4 close injuries. And then again, they need early intervention to save the limb. This is very frequently we all are seeing, Dr. Badar have said, like so much in every emergency, this what the condition are because of the bike that is being road traffic accident. So again, this is the amputation. This is the open grade 5 type injuries patient because of the amputation, traumatic amputation comes to the emergency. So this is a beautiful saying of the Girdlestone. He have once said, the bone is an implant that is rooted into the soft tissue. When its vascular connection are damaged, it often required not technique of a cabinet maker, that means orthopedic surgeon, but the patient care and understanding of the gardener. So that's her approach should be. So how we decide on salvage? There's a different parameters or scales that we all knows it, and Dr. Ziaul Islam have talked about it, the vascular surgeon. He has made my life easier to make you understand. So that's where the main focus should be. Multidisciplinary surgical team approach once the patient is in the level 1 trauma. It consists for the limb, it consists of vascular, plastic, and orthopedics. So of course, again, you have to have the awareness how to bring the amputated limb to the hospital. So these are the different research which says if you're able to salvage these high extreme injuries, their outcome is much better than the amputation. Return to normal life, it has been shown, is better if you are able to salvage the limb. So these were the few of the cases that you have seen. The foot, traumatic, then external fixator was applied. These were the forearm, that was traumatic amputation was done, which was again retransplanted, and now there's a flickering movement that have started. Yeah, video play please. No. Okay. So see, if you see, there's a start with the movement. If you are able to save the limb. So same goes this hand, which was traumatic, being amputated, it been re-implanted, and now the patient started to have the movement after 6 months. Please play the video. So this is the beauty or the miracle of the multidisciplinary team approach. So this was the patient who had a road traffic accident, distal femur fractures, present emergency. His neurovascular was compromised. Vascular surgeon went in. They revascularized the limb, and then external fixator was placed. After 2 months, we went inside and put plating. And now this is 7 months. He is now walking at 7 months with the help of a stick. And last night, I called him and requested to send me the video at 12 months. And that's what the outcome is. Next video, please. So now how is able to mobilize himself. So take home message, timely transfer to the level 1 trauma hospital, trauma care team to manage polytrauma patient, multidisciplinary surgical team approach, and good rehabilitation can save life and limb of the patient. Thank you very much.
Thank you, Kazim. Right, I would like to invite Dr. Naveed now to give his end of the debate.
Thank you, Dr. Akmal. My name is Dr. Naveed Khan, and I will be in favoring of severe the limb. So all possible measures should be attempting to save the life and limb of the patient, but there are multiple prerequisites. So we do not fit into this world without amputations. So what is the problem? Attempting to salvage a limb that without the necessary resources, attempting to salvage a limb that would have been salvaged into a functional extremity, attempting to salvage a functionless extremity, and attempting to salvage a limb that contributes to the patient demise. So saving a limb may ruin a life. So Hansen concluded in type 3C tibial fracture, futility of salvage, disservice to a patient, Saving a limb may ruin a life. So there are three variables: the injury, the patient, and the hospital, and you, doctor. So got to know the injury, just not the radiograph. Knowing the mechanism of injury, assess the severity. Sorry. So do not forget to take pictures, make drawing, take radiographs, document discussion with the patient. So what can we repair or replace? Can we solve this problem? Skin, muscles, nerves, blood vessels, and the bone. So what he does for living, is he living with a family or alone? Is there any disability with the patient, friends, family support, social history, addictions, and what are their expectations? So you and the doctor, the variable 3 is the impact of trauma center care on functional outcome following major limb trauma. So McKenzie concluded that evidence that patient who sustained high energy lower limb trauma benefit from treatment at a level 1 trauma center. So the questions we need to answer is the outcome better after amputation or reconstruction? Is there a limb salvage to score to help or decide? No tibial nerve, no reconstruction. Does foot involvement change the plan? And what drives patient satisfaction? So the limb extremity assessment protocol concluded that outcome after amputation would be better than outcome after reconstruction for a high energy lower limb trauma. So for controlling the patient characteristics, data published in 2018 from the LEAP study measured the functional outcome using SIP, sickness impact profile. So Bossier et al. Concluded there is no difference between the amputation and the reconstruction group at 24 months. And those who had amputation, those who had amputation would have better functional outcome and more hospital readmission as problem. So patient who had limb salvage was observed to be more hospital readmissions related to a complication and longer rehab time. So meta-analysis was carried by the Bossier and colleagues comparing 9 observational studies in which he regards to additional surgeries, longer rehabilitation time.
Apologies for the technical glitch, not in our hands, sorry. ये काजिम ने बदला ले लिया I think because of these technical glitches, we will be running short of time. So we will finish this, but I think we might have to forego the question and answer session because the closing ceremony is going to be held over here and we've been given a deadline. So apologies for that. And I would request the last 2 debate speakers to, if possible, go through their slides a bit quickly. Thank you. I think while the technical glitch is being sorted out, I'd like to answer Dr. Maratib. आपने जिक्र किया था about the research about the bugs and the antibiotics. So I'll let you know that at the trauma center we already have developed our antibioticogram and we have already isolated which antibiotics we have to use, and it's about to be implemented very soon. Which, yeah, exactly.
And you can really develop new protocols for even managing trauma and things like, if you look at ABCT protocol, in Afghanistan, it changed to B becoming first, because sometimes bullet injuries, the bleeding was so massive that you have to stop the bleeding, otherwise the patient will die. So A came after B. So they changed that according to the local scenario. So that is what we need to do. We have to have our own protocols for everything.
Yes, exactly, because the bugs that we grow is like very different from the bugs in the West.
Yes.
Because over there they are scared of MRSA. Over here we get Klebsiella and Acinetobacter. So we have developed our own things now.
And also, if you look at the infection, Nasir's lecture on infection, we have got a lot of infection as compared to first world countries, because the management in our hospitals, and we haven't got laminar flow theatres everywhere. So normal fractures get infected very frequently as compared to what they happen in Europe. I mean, their incidence is 1 to 2% maximum, and I think our incidence is in a clean fracture also, not even open, is 10% around. So we have to have our own data.
ये लेमिनार फ्लो की जो बात की ना आपने, वो भी इतना ज़रूरी नहीं है. उससे पहले बेसिक्स तो ठीक करें, स्टरलाइजेशन प्रॉपर हो, प्रॉपर प्रोटोकॉल फॉलो करें, अटायर्स प्रॉपर हैं, तो कभी भी सब प्रॉब्लम नहीं होता. And one of the good study was also available on the in the fracture management, open fracture, Imtiaz Taggo in 2004, I think it was published in the JCP SP from JPMC. One from the Gurki is also available, and Ziadin Hospital also has their own criteria for the, after looking at the organism mostly in the pathology department, and they set their criteria as well. So we can do. Okay, Dasha.
I just have time things are ready. I just wanted to ask Dr. Kazim, what if you said saving the limb? What about like saving a limb with limited range of motion, limited function? Will you still save the limb? Will you still encourage to save the limb? That is my question.
जवाब वो दूसरा देगा.
अभी नवी दे.
Shown, if you're having a leg and there is an above knee amputation, thus having the preserved leg function better as compared to the prosthesis if it's there.
What about having a very good functional prosthesis with on an amputated limb rather than having a nuisance or a limb which is not functioning?
So it is.
Sorry, I think Naveed is going to answer that. That is thing. I think.
I have other questions as well,
yes,
but
we can continue this later on. Shortage of time. Sorry.
So is outcome better after amputation or reconstruction? The sickness impact profile was slightly higher in 12.2 as amputation group as compared to reconstruction group.
काजी ने पक्का काम किया. गजनफर नवीद की साइड पे आ चुके हैं तो फिक्र हो रहा है.
So what are the predators of high sickness impact profile? Rehospitalization, low education, poverty, no health insurance, poor social support and self-efficacy, smoking and involvement with agitations. So there is no difference in SIP, but we can observe rehospitalization, osteomyelitis and more surgery were more involved in reconstruction group as compared to amputation group. So there is a score to decide. Low index score predict limb salvage potential, high scores not accurate predictor of limb amputation, so did not support utility for lower extremity indices to determine salvage versus amputation. So half regain normal sensation by 2 years, not predictive of functional outcome, not reliable, do not use as an amputation criteria. So the patient satisfaction driven by function, pain, depression, and it is not related to injury, treatment, and patient characteristics. So military extremity trauma amputation limb salvage study reported that participants who had amputation not at better functional outcome but were more involved in vigorous sports activities and less probability of developing post-traumatic stress disorder. So the Mess and McNamara and colleague retrospectively studies 24 patients who sustained open fracture of the tibia with 3B and 3C Castillo-Anderson classification and perform a comparison between the Mess and the NISA scores. So although both the scores were accurate and statistically significant in predicting amputation, they found that the NISA score were more sensitive and more specific than the Mess. So this score, MAS score, was further evaluated and modified by the McNamara et al. To devise the nerve injury, ischemia, soft tissue injuries, skeletal injury, shock, and age of the patient. And this scoring NISA also incorporate neurological findings such as plantar sensation as an arbitrating factor. So scoring system assists the surgeon in the decision-making process. These scoring systems are by no means infallible and cannot be used as a sole criteria while making decision. So they fail into taking account related to the patient quality of life, wishes, pain, occupations, and socioeconomic status. So meta-analysis, systemic review comparing the current scoring, Shiro et al. Concluded that showing reliability in discriminating the limb injuries requiring primary or secondary salvage and failed to predict the functional outcome following successful limb salvage. So all of these scoring systems were developed prior to the implementation and reorganization of the trauma network system. So with modern development in the trauma resuscitation, these scoring need revisions and updating to be more applicable. So the most important point to be considered is what time of patient present in the ER, is it arrived within 6 hours or late presentation, affordability of the patient is in private setup or government setup, and the hospital must be tertiary care hospital, there is availability of multidisciplinary approach, plastic surgeon, vascular surgeon, available 24 hourly. Ideally, all attempts should be made to save the limb. This might be impossible in majority of cases like late presentation, nerve, arterial, soft tissue injury. So decision of amputation should be taken by two consultants of two different specialty. Goals to be set should be functional and sensate limb rather than cosmetic functionless limb. So what would you do if you are me? Can you save his leg? So take home message is 2 to 7 years follow-up. SIP is the same. Complications seen lower in amputation group. Limb assessment score, do not use. Plantar sensation, do not use. Is it available? Cheaper reconstruction in our society? Still a question mark. Thank you.
Thank you, Naveed. Again, thank you for the debate. Apologies for the technical glitch. Rushing on with the program, I would like to invite Dr. Fahim Ahmed from Trauma Center and Dr. Rizwan Haroon from Aga Khan to kindly come to the stage. The debate will be on ankle fractures in diabetic patients, to fix it or to leave it. Dr. Fahim will be taking the stage first.
Starting with the name of Allah, most merciful and gracious, I will be in favoring the diabetic foot fixation. First of all, the subspecialty of foot and ankle surgery is evolving. The outcome definitions as per patients are evolving. What was the old concept and what is the new concept is changing among the foot and ankle guys. We are dealing one of the most difficult and challenging foot and ankle injuries at Level 1 Trauma Center, Shahid Mohtarama Benazir Bhutto Institute of Trauma. And I am highly thankful to Professor Dr. Sabir Memon and Dr. Akmal for putting confidence in this subspecialty to start at a public sector. Okay, let's start. Is it working? वहाँ से चला नीचे okay, okay. Okay, so what's new in the diabetic ankle? That's a really good slide that I have searched over like 40 to 50 papers, and I have come out of this thing. What was the old concept that an orthopedic surgeon used to think? A diabetic with old fractures can be treated non-operative or with protracted fixation. Because the ankle is the joint that is watershed area. There is no muscle around the ankle. So the possibility of fixation and getting it infected may go up with the horrible results. What is the new concept? The diabetic ankle should be fixed rigid plus fixation, or there is a new concept of plus fixation. It means you don't leave anything unattended. So new concept is that we will always fix the ankle in a diabetic Okay. The other point is that fixation should be protected for extended period of time. That is old concept. That there is osteoporosis, diabetic patient, you should put a back slab splint for like 3 months and these things. Now the new concept is fixation should allow immediate range of motion and follow accelerated rehab for good results. The third one is the posterior malleoli, if less than 25%, can be treated conservatively. The things have evolved as well. Most of the foot and ankle guys will be fixing it rigid for early mobilization purpose. The newer one is Charcots are not intervened. The patient who have already having Charcots findings and history and uncontrolled diabetics, the surgeons used to leave it as such due to protracted bad outcome, but the things are inverse. Charcots will be fixed now. Okay. The fusion surgeries as a primary was more common. The joint is already destroyed, you cannot save the joint, just fix it. The new one is that the reconstructive surgeries are mostly the primary surgeries now. Okay, see, if you leave the ankle unfixed, the diabetic Charcotopathy, the disease onset results leading to complete destruction of the joint. And even with that destroyed joint, still it needs to be fixed by the fusion methods. So you cannot leave just ankle as such and putting a plaster. You just need some sort of fixation and a rigid fixation. Otherwise, the outcome will be even worse. So there are some facts. The recent paper in JBJS in 2023, what does the paper say that the patient with diabetes are at risk of higher complication after surgical fixation of unstable fractures due to the impaired neurovascular functioning and bone healing capabilities. And among the diabetic patients, the ones who were uncontrolled diabetics had the worst outcome as compared to the controlled diabetics. And among the diabetics, if you leave it as such, the outcome was bad as compared to the ones that were fixed in the diabetic population. Okay, there is another paper, Foot and Ankle International in 2017. In 2017, can you hear me? Okay. And non-operative treatment was associated with 21-fold increase odds of complication. So just compare, if you leave a diabetic conservatively, there is 21-fold, 2100% increase rate of complication. This is highly unacceptable. And with the operative fixation and early operative fixation has better results as compared to the delayed, like there's the old school of concept or like that, you control the glycemia and we will fix you after 3 weeks, after 4 weeks, nothing like that. You have to get this sugar get controlled in a couple of weeks at the maximum, and then you have to fix. Otherwise, your outcome is going to be compromised. And in the conclusion of that paper, they said non-operative treatment of the displaced diabetic ankle fractures was associated with unacceptably high complication rate when compared to the operative treatment. Then another paper published in 2020 in EFORT, they also of the opinion that the surgical complications are more common in patients, of course in diabetic patients, but of all the undergoing ankle fixations, approximately 30% are diabetic and 2% have complicated diabetic mellitus. Out of that, non-operative management of ankle fracture in patients with complicated diabetes resulted in an even higher rate of complication. So don't get worried about the thing that if you are operating on a diabetic ankle, the complication, there will be some complication or a patient may go in amputation, nothing like that. Because if you leave the ankle like this, the outcome will be worse. Insufficient stability of the ankle fractures, treated operatively or non-operatively, can trigger Charcot neuropathy. That is a very important point. Okay, you have to fix it rigid. If you will not fix it or leave it as such, it can lead to Charcot neuropathy, and result will be bone loss, deformity, ulceration, and may end up in amputation. Okay, the rigid fixation is recommended. Hindfoot arthrodesis or after failed ankle fracture can be salvaged in approximately 80% of the patients. It means whatever controlled, uncontrolled diabetes, if you do surgery, there are chances that 80% of the ankles will be saved, even if it gets infected. Okay? The early protected wet bearing can be allowed, and provided rigid fixation without deformity has been achieved. Thank you.
Thank you, Thank you, Dr. Fahim. I'd like to request Dr. Rizwan Harun to kindly take the stage.
So, thank you very much. My name is Dr. Rizwan. Thank you, Dr. Akmal, Dr. Ghazi Shah, Dr. Sabir for inviting me for the talk. So, I will be agreeing with my colleague regarding operation on diabetic ankle fractures, but it's not all about plates, no big incisions, they are not necessary. So let's just go. So I just phrase it as diabetic ankle fractures, what to do, rather than fixing plates. That's not necessary. So I have no conflict of interest. Most of the X-rays are my patient's own property and have been consented for. So it's a multimodal TN approach. As we all know, I'm lucky working at Aga Khan. I've got vascular surgeons, Dr. Zia with me, endocrinologists. It's not a simple job. You just not go in the late hours and fix ankles in diabetics. So previously, just like the pyramid of Giza, so it has statistics that it was better to aversion to the operative management of ankle fractures in patients with diabetes. But in 2017, a landmark study by Louis showed that if you don't fix unstable diabetes fracture, there is a complication rate of 75%. What else do you want? 75 for not touching the diabetic ankle fracture, unstable. I'm not talking about stable fractures. So Fahim has already told us about type 1 has got more chances of complication, insulin dependent has got more complication chances. But how to fix them? You don't go and plate everything. So there was a concept. So we have to define complicated and uncomplicated diabetes. Uncomplicated, no systemic manifestations. Complicated, where there is neuropathy, retinopathy, peripheral arterial disease. So there was a concept of super construct which Dr. Fahim touched, which is called ORIF+. It was basically meant for Charcot fusions. But Samarco defined that with the advent of MEPO techniques, you just span, don't cut, do a MEPO technique. If there is some sort of deformity, you take out the bone, don't let the bone impinge the skin. Use the strongest device. That doesn't mean use a 4.5 mm plate on an ankle. Use a 2.7 plate in an anti-glide mode. This is the strong possible thing. And fixation should be applied in a manner that maximizes mechanical function. So what do you do this? This was one of my patients. I fixed it. I did a super construct. Dr. Zamir is sitting. Sir, the concept of surgical synostosis in tibial non-union Campanacci. So now we are using this. So you fix the fibula. We know that fibula is the basic cornerstone on ankle joint. So you overfix the fibula and don't try to fix posterior malleolus. It will be a stable construct. So this is a very good algorithm. Diabetic unstable fractures, uncomplicated diabetes, you go in and standard fixation. For complicated, if there is a simple fracture, go for MIS. If there is a bit of bimal, trimal, go for an ORIF+ like super construct, and always have arthrodesis in your armamentarum. So this happens all the time. आप सबने देखा होगा फिबुला पे से सुराख बन जाता है और वो फिर रहता ही रहता है. So you just modify your technique. You go posterior lateral. भाई fibula पे direct incision देने से अच्छा है. You go between the plane of peroneum and flexor hallucis longus. There is good muscle mass. You can mobilize the skin. You will never have a problem most of the time. Never is a bad word, but most of the time with these locking plates. So fibula protibia technique, surgical synostosis for tibial non-union, 1945, it was discussed. Now the ankle fracture, I never fixed the medial mal because there was a big blister. अगर मैं वहाँ पे cut लगा के screw वगैरह डालता, the skin would give away. So I just fixed the fibula and it healed. Because you have to reduce the fibula very correctly. So this is an Adelaide fracture score. It's a verified score. If the score is more than 5 with an ankle fracture in a diabetic, there are high chances your fixation will fail. You do a primary arthrodesis. Uski reasons are there are 2 points and 1 points. It's easily available on the internet. आप देखें उसका क्या score बनता है उसके हिसाब से there is guidelines, checklists. So this is another way. Adelaide foot ankle score more than 5, you will always be saved by arthrodesis. So this was one of my patient, Adelaide score of 8. I will never fix this. This is too much of a thing. Charcot joint is already in place. I will put so many plates, posterior mal, everything, ligamentous injury, it will give way. What I did? I just put in a nail. Make the फ़हीम की आधी बात मान ली. चौथे हफ्ते से चलाना शुरू कर दिया. It healed. So this is a very good paper. Current concepts, so they have now come with a level 3 and 4 evidence guidelines, but they are 3 and 4. Sorry. The presence of diabetes carries an increased risk of infection. That is, you have to tell your patients. Complication is increased in the insulin-dependent patients. Managing unstable ankle fractures, non-operative in the presence of diabetes increases the risk of complication. This is a level 2 evidence which is strong enough to make us sure that unstable should not be left alone. Control of post-operative blood glucose and HbA1c can reduce complications, and you have to use the superconstruct thing. So I always say this Jigar Murad Abadi share whenever I am doing an ankle fracture in diabetes. ये इश्क नहीं आसा इतना ही समझ लीजिए एक आँख का दरिया है और डूब के जाना है तो यू विल बी सीइंग कॉम्प्लिकेशन मगर 75% से कम ही होगी इंशाल्लाह. थैंक यू वेरी मच.
Thank you, Rizwan. I think all of these topics are very controversial and there's no fixed answer for any of these debates and everything, but thank you very much for your input. Right. I would like to invite our chairs, Anis Saab and Maratib Saab, to kindly sum up the session. And I would request all of you to kindly remain seated because the closing ceremony is going to take place over here immediately after we end. Anis Saab.
उससे पहले तो भाई अपने वायदा किया था क्वेश्चंस डिस्कशंस अभी कोई रहती है इस डिबेट के ऊपर क्योंकि कंट्रोवर्शियल तो है मगर बहुत ही इंफॉर्मेटिव लेक्चर्स थे. इज देयर एनी क्वेश्चंस फॉर डिस्कशन? Yes, I know it is too cold now, particularly for Badr. 2 times he went there, me as well. Hanji, nahi. Okay, there were good papers here. First 2 papers were on the pelvic injuries, where Intikhab Tawfiq and Badr has given a very nice account of their fixations and ring stability, how to manage this overall. Then acetabular fracture and this whether your technique remind me when I think 2008 में ज़िलज़िला आया था. Then there was an acetabulum fracture and there was English surgeon from the France, he was not able to do. I asked him, I will do tomorrow. He said, how? मैंने कहा, you will do it. Then I opened it and taken 4.5 millimeter DCP 8-hole and molded it. And then I gave him, and I said, now fix it. So he said, how did you done this? And Pakistani tariqa he did. So good enough that, and you used to do that, and newer plates are really give the good results, particularly quadrilateral plate fixation. Because of that impact at the time of trauma, the AVN usually occurs. Otherwise, on the weight bearing area pressure, it is just like in a boiled egg. When there is a significant injury, the boiled egg crushes and never come back roundness. So that is the basically impact of the injury which leads to the AVN, and the particularly the quadrilateral plate fixations has great role, and many plates has been designed for, but they are so costly for us. But we can manage with them by preparing our hooks, as we used to prepare semi-tubular plate for the olecranon plate we used to do, and now they are our anatomical plates. In those days we used to do that. Then the infections were discussed in the open fracture and the role of infection. Very nice discussion, nice presentation were there. There are multiple fractures available in Pakistan, and at early 20s, Imtiaz Tago has published a fracture in CPSP on the infections in the open fractures, and good, you can read there. Then there was a paper from Gurki as well. And then multiple our institutes also have their own profiles and as per their sensitivities, and they are managing. Open fractures has been discussed. Very good context has been given by the Zamir Sumro on the issue of deformity correction, which mostly touch upon the post-traumatic deformity corrections, though he do many of the congenital deformities very well, and he has given also example of the CPT. But I have never seen a case in Pakistan which is being done by the Pele, but he takes 4 crore rupees for the CPT. Two patients I sent, he took around 4 crore rupees on these management. And when he changed the telescoping nail, he said, but he will do it. I can't, because your nail and our nails, we know they break our nails, and he charge 1.5 crore as well for the just change the. So वो facilities और सारी चीज़ें नहीं है, उतना पैसा हमारे पास भी नहीं है तो कर सके हम. Debates vascular injury, very well spoken by our case from the UK, and nice discussion, and the plastic surgery. Then there were the debates, and I will ask my co-chair to discuss on these debates.
Thank you, Anis. You've summarized it very well. I think we have had both debates have been nice, and as far as DHS and PFN is, I think majority of surgeons are doing both, and they look at the scenario where they are working and what facilities are available, and they do the procedure. And I think both have got positive points and negative points, and this is how things evolutionize. And I think we should always try to do new things and see what happens, and develop our own data as to what is the best for our scenarios. Rather, and the second debate about saving the limb or amputation, I think we should always try to save the limb, and it's better than having a prosthesis on your body. So I think throughout the world, everybody is in favor of saving the limb whenever is possible. But I personally feel, do not overdo it, and if the limb is not salvageable, I think amputation is the answer, because that makes, I've seen patients having discharges on their limbs for 2-3 years. They're just, because of trying to save the limb, they've got big discharges, they are discharging pus all the time. It's not a good thing to do. So whenever possible, do save, otherwise I think it's better to do an amputation. Because in our society, we've seen even patients with upper limb amputations, they do walk, but in Europe, they say that if you do an upper limb, above knee amputation, sorry, not upper limb, above knee amputation, they do not walk. But in our society, I've seen people with above knee amputation walking with prosthesis. So, but always try to save the limb. And the third debate, I think we have had a nice debate about diabetic foots, and I think they should always be fixed. That is what it should be done. Thank you very much. I think we have had a long session and we have had an excellent session. I think every presenter has done it very nicely. Thank you very much.
जो ankle fracture fixation in the diabetics, particularly uncontrolled diabetics, are more prone to the Charcot's. It is very right. The poor fixation also leads to the Charcot's disease. But I have seen the cases done by the Rizwan and myself also. When you fix these in Charcot's disease, even if it's advanced stage, when you fix it with the nail, there gives a good results. And in fact, it controls the infection as well. The common thinking we have, we will put the implant, it will further deteriorate with the infection, but it's not so. And you do a good debridement, good coverage, pre and post cultures, and then place a nail, and it shows it little bit rigid fixation, relatively rigid fixation, then it gives the good results. If you leave it alone, then it is the worse. Then it goes to the nearly to the amputation as well. And one thing more in the the severe the limb, as we have seen after 10 and 15 years, the Marjolin's ulcer also develops on the trauma treated with and the deformity. There was a good question asked by the Shah Saab, whether we should disarticulate or amputate when there is a severe deformity. वो सलवार पहन के तो चलते हैं, मगर उनसे अगर आप पूछें ना बैठ के कि हालात क्या हैं, तो वो आपको नहीं, वो सीधी लात करके वो वाशरूम्स में चले जाते हैं और करते हैं. तो in that situation is better having a prosthetic. And nowadays good prosthetic limbs are available and they give the good results. But discussion we can continue unless our organizers here come and say, okay, finish it. Your chief guest is here. One of the chief guests is here. Others, Sabir has gone to take him. So we can continue for a few moments as well for the question and answers.
So anybody has got any?
मोश होके बैठने से सुम्मुन बुकमुन हो जाएगा.
I think एक चीज which is very important that we should develop our own protocols. We should do research, honest research, and develop our own protocols. We have got so much material. We do so much work. We do not document that, and that is what is keeping us behind. Otherwise, new things should come from our part of the world rather than coming from anywhere else. We should make new protocols according to our scenarios.
मरातिब इस पे एक अच्छी कावश जो हुई अभी रिसेंटली, बिल्कुल अभी एक दो साल में, अभी जनवरी में वो किताब भी पब्लिश हुआ है, आर्थोपेडिक इनोवेशन इन द डेवलपिंग वर्ल्ड्स. Very good. Masood Umar and the Harun is edited, and one of my chapter is also there, Bhatti functional scoring, और कुछ और बहुत अच्छा काम जो हम पाकिस्तान में कर रहे थे मगर कभी पब्लिश नहीं किया था. अगर आप ये किताब पढ़े ना बैठ के तो आपको मज़ा आ जाएगा कि भाई हम पाकिस्तान में क्या कुछ नहीं कर सकते, why we कैन नॉट डू द इनोवेशंस, एंड दे हैव डन वेरी लॉट ऑफ वर्क ऑन दिस. 2 साल तक उस पर काम करते रहे. वो पब्लिश हो चुका है, कैम्ब्रिज स्कॉलर्स पे आप चले जाएँ तो आर्थोपेडिक इनोवेशंस इन दी डेवलपिंग कंट्रीज़ में मसूद उमर का और ये किताब बहुत अच्छा है. $88 में घर तक पहुंच जाता है. मेरी 40% की डिस्काउंट थी, वो नहीं दी, मगर आज तक लड़ रहा हूँ उनके साथ कि बीइंग ऑथर इज गिव मी, तो आज उनका लेटर है कि हम $35 आपको वापस करेंगे. $88 में एट होम डिलीवरी है. बहुत अच्छा किताब है. और उसके बाद एक और काम वो भी इस पे अभी मरातब कर रहे हैं, मसूद और दूसरे लोग. आज सुबह भी उसकी हमारी मीटिंग हुई थी कि डिफरेंट एस्पेक्ट ऑफ द डिजीज़ या जो प्रॉब्लम्स है उसके ऊपर हम अपनी गाइडलाइंस डेवलप करें. तो 1-2 मीटिंग शायद नूर को भी पता है, उन्होंने भी की है. सुबह मीटिंग थी जी DDH पे गाइडलाइन किस तरह से डेवलप करें, तो तकरीबन उस पर भी काम हो रहा है. तो हमारी जूनियर टीम या हमारे जूनियर कलीग्स इस पर अच्छा काम कर रहे हैं और ये फर्दर मुस्तकबिल की बहुत अच्छी कावश है. ठीक है ना. तो वो बढ़ाओ आगे यार जब तक वो आए. जी गजनफर, कुछ क्वेश्चंस और डिस्कशन होनी चाहिए जब तक साबिर मुझे वहाँ से नज़र आए.
Like for
ये सारे लेक्चर्स जो आज यूएस पे डिस्कशन करें थोड़ा.
I think they need to change the setting of the stage and they want us off the stage.
Okay, thank you very much to everyone, sir.
Respected Chief Guest, patrons, distinguished guests, ladies and gentlemen, good evening and a very warm welcome to all of you to the closing ceremony of Pakistan Trauma Conference 2024. My name is Dr. Washma Amir. I'm currently working as a medical officer in the emergency department at SMBBIT. And today I have the privilege to host this amazing event. Before we begin, I'd like to call on stage our honorable chief guest, Mr. Murtaza Wahab, Mayor of Karachi, known for his commitment to urban development and community welfare. Next, I'd like to invite the esteemed Executive Director, SMBBIT, Dr. Sabir Memon, on the stage. We'll begin with our guests of honor of the evening, Dr. Taj Hassan, past President of the Royal College of Emergency Medicine, Director of the European Leadership Program in Emergency Medicine, and a consultant at Leeds Teaching Hospital NHS Trust. So can we have you on stage? Next, I'd like to invite Professor Connor Daisy, Clinical Director, Emergency Medicine and Acute Care, Professor of Emergency Medicine, Cork University Hospital, Ireland. Next, we have with us Dr. Mustafa Mahmood, Consultant Emergency Medicine at St. James Hospital, Dublin, member of the Royal College of Emergency Medicine. I'd like to invite Dr. Sajda Qureshi, Chair of Scientific Committee and Dean of Surgery, Dow University of Health Sciences. Lastly, we have with us Dr. Benjamin Thull, Emergency and Primary Care Physician, Deputy of Scientific and Medical Director, Vienna Ambulance Service, Austria. Thank you all for being here. As we wrap up what have been an extraordinary few days of sharing knowledge and collaboration, it is an honor to reflect on our achievements and express gratitude. So to commence this evening, we'll begin with the glorious name of Allah Almighty, followed by our national anthem.
الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
Can we have our national anthem? Please, everyone stand up for the national anthem. Thank you all for your participation. As we move forward, I'd like to highlight the invaluable contributions that have made this conference a success. First and foremost, I'd like to acknowledge our patron-in-chief, Professor Saeed Qureshi. His support and visionary leadership have been crucial for this event, and we deeply appreciate his guidance. We also like to acknowledge our sponsors and patrons. Your generous contributions have brought this conference to fruition and helped us advance our mission in the trauma care. A heartfelt thank you goes to our Chair of Organizing Committee, Professor Sadka Aftab, and Chair of our Scientific Committee, Professor Sajda Qureshi, along with all the members whose dedication and precise planning have led to seamless execution of this event. While we have many committees and individuals to thank, please know that each contribution has been greatly appreciated and valued. It is your collective efforts that have made this conference a success. We are now ready to move on to the highlight of our evening, the awards ceremony. To celebrate the achievements together, I'd like to invite our esteemed Executive Director, SMBBIT, Dr. Sabir Memon, to oversee this prestigious segment and recognize achievements of our award recipients. A big round of applause, everyone. We will begin with the Research Excellence Award. Each award has a prize money of 50,000 rupees. So we'll begin with our first award, that is the prestigious Professor Shafiq Qureshi Award. I'd like to invite Professor Munir Qureshi on stage. A big round of applause, everyone. The award is for the best abstract, and the award goes to Miss Umme Ayman. Thank you, Dr. Munir, for presenting the award. Next, I would like to invite Professor Rufina Sumro to present the Professor Yunus Sumro Research Excellence Award for the Best Abstract for Day 2. The award goes to Dr. Nimra Rashid. Finally, I'd like to request Dr. Sabir to present the Best Research Poster Award, the Abdul Sattar Eidhi Award, and it goes to Naima Khan. After our prestigious award, I'd like to invite Mr. Murtaza Wahab, Mayor of Karachi, for a few words regarding the conference and to share his insight with us. A big round of applause, everyone.
Bismillah ar-Rahman ar-Rahim. Distinguished guests, participants of this conference, Assalamu alaikum. As a politician or as a lawyer, I'm the wrong person to be speaking at a trauma conference. Nevertheless, I've seen the rise of SMBB Trauma Center over the last few years as to how it has evolved into an institution par excellence, dealing with thousands of patients who come to this trauma center, not only from the city of Karachi, but from other districts of the province of Sindh and also from the far-off areas of Balochistan. And I must compliment the management of the trauma center for the valuable services they've been providing to the people of Pakistan. As the mayor of the city of Karachi, I beam with pride with the way and manner you deal with humanity, you deal with the patients who come to your center and treat those patients. I'm again very happy that besides serving the patients, you're also looking towards academic brilliance, getting people from all over the world to come to Karachi, engage with your practitioners, having people online who can share their experiences with our young talent, who can gain from their international valuable experience. So that's again a great opportunity for our local doctors who can sit here in Karachi and learn from the valuable experience of these international practitioners. Again, very happy to see that somebody from the ambulance service is also here in Karachi, because this is something which is at a very novel stage here in the city of Karachi, with the government now expanding its ambulance service. So I'm happy to see that our team would be able to learn from your experience, and I hope that the trauma center is also engaged with the 1122 ambulance service so that we can learn from their valuable experience as to how can we better cater to the facilities that are being provided to the people. Again, not the right thing to be saying at the closing ceremony, but welcome to the city of Karachi, and I look forward to more and more people coming to the city of Karachi, seeing it's not that bad a place. It's a great place with some very good food. I was speaking to the gentleman sitting right next to me that I hope that you've just not stayed at the hotel, you've also managed to go out. So I hope the organizers would take you out somewhere to a nice place, serve you some good food, and you can see that Karachi also has some great culture to offer. I wish all the participants the best of luck. The people who've managed to win the awards, I felicitate them, and I look forward to engaging with all of you in the future as well. Thank you very much.
Thank you, Mr. Murtaza Wahab, for such insightful and encouraging remarks. If I could request you to come to the stage once again to present the award to our guest of honor of the evening. I'll also request our Executive Director, Dr. Saber Maiman, to present the awards along with Mr. Murtaza Wahab. So we'll begin presenting the awards to our honorable guests. We'll begin with inviting Dr. Taj Hassan to the stage to receive his award. A big round of applause, everyone. Professor Connor Daisy, can we have you to receive your award? A big round of applause, everyone. Next, I'd like to invite Dr. Benjamin Thal to receive his award. We have Mr. Dr. Mustafa Mahmood to receive his award. Thank you, Mr. Murtaza Wahab and Dr. Sabir for presenting the awards. It is time for Mr. Murtaza Wahab to receive his award. And for that, I would like to invite our guest of honor, Dr. Taj Hassan and Professor Connor Daisy to present award to Mr. Murtaza Wahab. A big round of applause, everyone. Thank you so much. We'll now begin with the awards of our organizing committee. I'd like to request Dr. Sabir Memon to stay on stage for the awards of organizing committee. And I'd like to invite Dr. Taj Hassan to present the awards along with him. As I call each name, I would request you to please step forward and receive your well-deserved award. We start with member of the organizing committee, Professor Badruddin Sehto. Member organizing committee, Professor Mazharul Hassan. Member Organizing Committee, Dr. Arif Mateen, Professor Atiq Ahmed Khan, Professor Muhammad Imran, Dr. Zeba Ahmed, Dr. Afshan Bano, Member Organizing Committee. Can we please have you on stage? Member Organizing Committee, Professor Shahjahan Katpur. Member Organizing Committee, Dr. Muhammad Faad Tariq. We next have Dr. Arusa Asim, Member Organizing Committee. Next, I'd like to invite Dr. Azhar Sheikh, Member Organizing Committee. Dr. Syed Akmal Sultan. Dr. Sadia Amir, Member Organizing Committee. Dr. Fiza Iftikhar, Member Organizing Committee. Dr. Hassan Kashif. Dr. Muhammad Yusuf, Member Organizing Committee. Ms. Zahra Naqvi, Member Organizing Committee. Thank you, Dr. Taj, for presenting these awards. I would now request Professor Connor Daisy to join us to present the awards along with Dr. Saber Maiman. I'd like to invite on stage Ms. Anam Wahab, Member Organizing Committee. Mr. Danial Aslam, Member Organizing Committee. Ms. Humaira Ismail, Ms. Sana Amir, Dr. Rabia Asim, Dr. Abid Sheikh, Ms. Zarnab Mary, Mr. Zubair Qureshi, Mr. Harisur Rahman, We will now begin with the awards for the Scientific Committee, and we start with Dr. Baryam, the Secretary, Scientific Committee. Thank you for your hard work and your dedication, Dr. Baryam. Next, I'd like to call upon stage Dr. Beenish Hamid. Dr. Ghazanfar Ali Shah, Scientific Committee. Dr. Sidra Javed. Dr. Maria Shabir, Scientific Committee. Thank you, Professor Conor Daisy, for presenting the awards. Next, I would like to invite Mr. Murtaza Wahab to present the awards to our workshop and registration committee. I'd like to call on stage Dr. Kuratulan Tahir to receive her award. Dr. Kailash, Registration Committee. Okay. Dr. Sunita from the registration committee. Dr. Vicky Kumar. The words enough for Murtaza Wahab. Thank you, Mr. Murtaza Wahab. I would now like to invite Dr. Mustafa Mahmood to present the awards. Can we have Mr. Asad Sajjad from the exhibition committee? Mr. Syed Wajid Ali Shah. Dr. Khalilur Rahman, Finance Committee. Mr. Shadad, Finance Committee. Dr. Hajra Rana, Marketing and Advertisement. Dr. Rabia, Marketing and Advertisement Committee. Dr. Fahim Ahmed, Dr. Vikash Kumar. We have Dr. Fahim Ahmed with us from Audio and Visual Committee. Ms. Shazma Kiran Baloch. Dr. Najmuddin Rajpur, Dr. Tahreem Khan, Dr. Umair Dilawar, Dr. Sara, Mr. Hamad Hussain, Dr. Sobia Munir, Mr. Tayyab. So we have, thank you so much for presenting the awards, Dr. Mustafa Mahmood and Sir Sabir. Thank you so much for your dedication in presenting all these awards. May I please have on stage Dr. Sajda Qureshi. And may I invite Mr. Asghar for his award from Executive Secretariat. Mr. Zishan, can we have you on stage to receive your award? Thank you so much, Dr. Sajda. Can we have a few words regarding the conference from you? Can you send some reflections for the conference?
Thank you very much. Honorable Chief Guest, esteemed faculty members, dear colleagues and delegates, Assalamu alaikum and good evening. I'm sure you all must be very, very tired after 2 very intense days of scientific sessions. Believe me, a lot of effort went into the program, and we tried to make it more diverse as well as inclusive. So we had tried to cover nearly all aspects of trauma care, from, I think, policies, legislation, to pre-hospital care, and then the management of these patients, receiving these patients. And then we did talk a lot about what improvements we can bring to this, to the trauma care in our country. So we tried to make it more diverse, and I'm really, really very grateful to all the speakers, and especially my international faculty members who have traveled for from all across the globe to be here with us. And thank you very much, guys. Your insights and valuable experience has really contributed a lot to trauma care in our part of the world. And I'm sure all the candidates and all the delegates, rather, had a really good learning experience. We, as the organizers, had a really good time organizing this this conference and the pre-conference workshops for you. And I'm sure each one of you have taken something from this conference and the deliberations that were done over these last 2 days. And I'm sure that would help you to put something, one thing or the other that you have taken from these 2 days in your practice, and that is going to make a lot of impact in your future practices. Thank you very much. And I would, at the end, I would like to thank my scientific committee, especially Dr. Variam Vezi. Thank you very much, Variam. I'm 100% sure that we would not have been possible to have this very, very good scientific session and the program without Variam's, input. So thank you, Variam. I know these 3 months have been very difficult for you, and I know you have lost a lot of weight. Let's hope that you gain back that weight that you have lost over these 3 months. But again, and thank you very much all the delegates for taking out time, for being so engaging in all the sessions. And thank you once again, and I wish you all the best for future, and hope to see you all again next year. I think after, I was here in the last Traumacon as well, the first Traumacon, and now today we are ending our second Traumacon. So I think we have achieved another, rather, Shaheed Mohtarma Benazir Bhutto Trauma Center has achieved another milestone, and I think that requires a round of applause. Thank you very much once again.
Thank you so much for such insightful and encouraging remarks. Madam, I would like to invite you again to deliver the awards to the Master of Ceremonies. May I invite Dr. Rahim, the Master of Ceremony for Inauguration, to receive his well-deserved award. Dr. Sara for the gala night. Do we have her here? Do we have Dr. Sara with us? Right, so I think it's time for me to take the award. Thank you so much, all of our guests, for your dedication in presenting the awards. I would now like to invite Dr. Sabir Memon for his vote of thanks and closing remarks. A big round of applause, everyone.
Bismillahirrahmanirrahim. Assalamu alaikum. So we reached at the end of this conference. I am thankful to organizing committee, scientific committee, our guest speakers coming from different countries and taking out their precious time and deliver valuable lectures and presentations over here. I am thankful to our sponsors also to make this event possible. Without them, we can't arrange and continue this event. Thank you very much for this beautiful conference success. I also congratulate to the winners of the researches. So they have received their shields and cash prizes also. And we dedicated these awards with the name of our beloved teachers, Professor Shafiq Qureshi Saab, Yunus Subro Saab, and also with the name of Abdul Sattar Edi Saab. Thank you very much. Tea is ready, so proceed and have a cup of tea with us. Allah Hafiz.
Thank you for your wonderful words, sir, and for wrapping up the ceremony with such grace. We do have a high tea arranged. Please join us there. Thank you and have a wonderful evening, everyone.
पोर्टफोलियो भी तो ले लिया है ना।